song. We welcome Ms. Lakshmi, Nurse Superintendent, Aruna Cardiac Care Tirunelveli for the prayer song. I recommend the prayer song. Thank you.
Management in critical care setting, Dr. Sir, senior physician and diabetologist, Aruna Cardiac Care, Tirunelveli. Dr. S. Madhavan Sir is a proud alumnus of Tirunelveli Medical College, and he did his post-graduation in general medicine from. Cordially welcome Dr. S. Madhavan Sir to take over the session.
This session will be moderated by Dr. A.K. Srinivasan Sir, Senior Physician, Dr. Meena Kumari Ma'am, Associate Professor in Medicine, Tirunelveli Medical College, and Dr. Ilango Sir. We request the chairpersons to the stage.
hyperglycemia in hospital. I am his postgraduate student 25 years back, so 20 years back. So very proud to chair this session.
Good morning and welcome to everybody. We are starting off with a very important topic, namely hyperglycemia in hospital settings. As we all know, diabetics are prone to so many problems, so they are also more likely to get into critical care situations. So how to manage diabetes in such a situation is a very practice. I request Dr. Madhavan to enlighten us on that.
Okay. newly new onset diabetes or newly treated hyperglycemia are in cases known as very control. Whether it's taking that ICU or non-ICU, patients who are new hyperglycemia, these patients are less adapted to what the adapted response will be granted. They may not adapt to the new medication. So these patients are higher mortality compared to the patients who are pre-existing diabetes. You see what is the situation in India. The Health Sector of Hospital has reported that diabetes contributes to 8% of hospitalization and 15% of repair to death.
அம்பு பல்லு தான் போட்டிருக்கேன்.
is to analyze the reservation history. So imagine you are in a clinic setup. Inauguration to the chest pain comes. So now how are you going to approach the patient? So one thing is that the chest pain symptomatology should be very clear in the chest pain should confirm it's a cardiac chest pain. The other three areas we have in the clinic is one is ECG, second one is cardiac, third one is same. I hope most of the clinicians will have all these three areas in their clinic. So with this, now I will tell you how to make a diagnosis of the ACs. So if you look in the STEMI, there will be chest pain will be present, cardiac chest pain will be present, and ECG. Hello. So if an patient presents with the anterior wall MI, in echo, we will come to know that anterior wall is not contracting. That is called regional wall motion abnormality. So suppose if a patient, inferior wall MI patient comes, the inferior wall of the LV won't contract. So with that, we will be able to get an regional wall motion abnormality pathology. So next, NSTEMI. If you look at NSTEMI, chest pain will be always present, and the ECG will show ST depression or STT changes. The cardiac enzymes will be positive. The regional wall motion abnormality will be predominantly present. In an unstable angina, the chest pain will be present. There won't be ST elevation or depression. The ECG changes will be like STT changes will be present, dynamic changes, and the cardiac enzymes will be negative. And the echo might show a regional motion, might not show a regional wall motion. So stable angina, the chest pain will be morely like exertional. The ECG might show and changes, or may not be showing changes, and the cardiac enzymes will be negative, and the echo won't be showing regional wall motions. So if you look carefully, if you compare STEMI and NSTEMI, the only change is ECG, if it shows ST elevation, the other things will be same things. The chest pain, cardiac enzymes, and echo will be same findings. Only the ECG shows ST elevation. In the NSTEMI, ECG will be having ST depression. If you compare NSTEMI and unstable angina, the rest of the things will be same except cardiac enzymes. So with this toolkit, with this tool gadgets, you can come to a working diagnosis in your clinic setup. So how to work up ACS suspect? You have suspected an ACS patient. Now how are you going to make a suspect and suspect to making a diagnosis? So first is clinical presentation. If a patient has signs and symptoms suggestive of ACS, perform an ECG within 10 minutes of first medical contact. That is prime most important. So with this ECG, you have the ECG in hand, you look for ST elevation or ST depression. So simultaneously order for cardiac enzymes and do an echo. So you will come to a conclusion with a final diagnosis or STEMI, NSTEMI, unstable angina or non-ACS pathology. So should I lyse or should I refer for primary PCI immediately? How should I take call? So the first scenario is the patient, if you think that patient can reach the hospital in the same locality which is having a PCI capable Cath lab, the wire crossing time should be less than 60 minutes. In the second scenario and third scenario, you should take a judgmental call. You should see the patient, you should think all the logistics together. If the PCI is possible in less than 120 minutes, that is within 2 hours, the patient can reach the hospital, PCI capable hospital or not, you should take a judgmental call by yourself. If you say yes, if you think it's yes, the patient can reach, you should immediately refer the patient to the PCI capable center, and we will ensure that the wire crossing time should be less than 90 minutes. If you think the patient cannot reach, you cannot arrange an ambulance, lot of logistic reasons will be there. No second thoughts, you go ahead for thrombolysis. You lyse the patient, that is the aim for the lysis, that is less than 10 minutes, you should give a bolus lytic dose after ruling out all the contraindications. And then you should refer to a PCI capable center. So I have lysed now. Now when should I refer the patient? So these are the red flag signs. If the patient has dynamic STT changes, failed lysis or cardiogenic shock, hemodynamic instability, recurrent chest pain within 1 hour refractive to medical management, any arrhythmias, or prolonged ongoing chest pain more than 15 minutes, are signs of acute heart failure. These are high risk. You label these patients having these symptoms under high risk category, and these patients should get an early invasive strategy, that is coronary angiogram less than 24 hours. So to concise, when to refer? If your working diagnosis is STEMI, you have two options. One is primary PCI, the second is thrombolysis. The patient can reach the hospital within 120 minutes. You refer for primary PCI. If he cannot reach, you thrombolyze and plan to refer. If you make a diagnosis with the NSTEMI, check whether the patient has red flag signs and label them as high risk category. Immediately refer for coronary angiogram. If the patient is NSTEMI without high risk features, you can take a time, manage him and anticoagulate him and then refer. So to concise, STEMI, refer. NSTEMI with high risk features, refer. NSTEMI without high risk features, admit, manage and then refer. So I have lysed. Now there are no red flag signs. Can I manage medically? When should I refer? And how to treat medically? As you all know, the loading doses of aspirin, clopidogrel, high dose statin should be given. Anticoagulation with unfractionated heparin, 5,000 units IV, or low molecular weight heparin of 1 mg per kg subcutaneous. To decrease the workload of the heart, beta blockers and ivermectin can be given. AC inhibitors also be given. To vasodilate the coronary arteries, nitrates, nicorandil, trimetazolam can be given. If the patient has heart failure, you treat with diuretics, potassium serum diuretics, pain and supportive management should be given. So when you're treating an ACS patient, this is an important concept you should know, that is myocardial oxygen double product. So imagine a normal patient at rest is having a heart rate of 70 and systolic BP of 120. If you multiply that, you will get 8,400. That is for a normal patient at rest, he will be having his myocardial oxygen demand of 8,400. So imagine you are in your rounds, in your ICU setup, you are seeing a patient monitor. The patient is having a heart rate of 100 and a systolic BP of 150. So if you multiply that, his oxygen demand at that time will be 15,000. So you have decided to give only beta blocker for that patient. So what will you do? What the beta blocker will do is to reduce the heart rate, that is from 100 to 80, but it won't have effective changes in systolic BP. So if you multiply 80 into 150, his oxygen demand will reduce down from 15,000 to 12,000. So second scenario, you are not giving beta blockers, you have decided to give only AC inhibitors. It reduces the BP, that is 150 to 120, but the myocardial oxygen demand remains the same, that is 1,200. So the third scenario, you give both beta blockers and AC inhibitors. That is, you reduce the heart rate as well as systolic BP. If you multiply that, it is half of the ACS patient's myocardial demand. So you have reduced the effective myocardial oxygen demand for an ACS patient. So you should always give beta blockers and AC inhibitors simultaneously. To reduce the heart rate, prefer beta blockers. If the patient has heart failure, you think beta blocker is contraindicated at that time, you prefer ivermectin, which is SA nodal inhibitor. To reduce the systolic BP, you can use AC inhibitors, ARBs, ARNIs. If you are contraindicated with elevated renal parameters, you can consider calcium channel blockers. So when to avoid beta blockers? In heart failure patients with basal Krebs, CLIP class 2 patients, you should avoid. In inferior MI patients with AV block or suspected complete heart block, you should not use it. And if RFT increased, AC inhibitors are contraindicated. And in inferior MI with suspected RV and posterior wall involvement, nitrates are contraindicated. And if the RFT is increased, any hyperkalemia features are there, potassium sparing diuretics are contraindicated. And if a patient is having a hemodynamic instability, don't prefer morphine. So you have referred the patient. What we do in Cath lab? patients with coming with a working diagnosis of ACS, we subject them through coronary angiogram. With the coronary angiogram, we will see whether there is a clear culprit lesion suitable for PCA. If the patient is having a clear culprit lesion, we do image-guided PCA and fix the lesion. If there is no culprit lesion, if there is an ambiguous lesion, that is, mostly we will come across the term borderline lesion. So in these cases, what we do is we run an OCT run. That is, we will send a camera inside the coronary heart. It will take pictures of the coronary. So it will give like a slices. So the round thing you have seen in the right side corner is then OCT image. So what I want to tell this in this slide is, if a patient presents, if he's having a borderline lesion, we'll do an OCT and we'll see whether there is a plaque erosion or plaque rupture. The plaque has ruptured, we should stent that patient. If he's having only erosion, he can be managed medically. So what should I see in follow-up after an intervention? That is long-term treatment after ACS. We will discharge the patient on cardioprotective medications and start on life. And you should ensure that it has been followed and routinely kept. So lifestyle modifications and cardiac rehabilitation, OPD interviews is must. I will give you 3 targets. You should meet that target always. That is, support healthy lifestyle changes, smoking cessation, healthy diet and regular exercise, reduce the weight and psychological management. The second target is antithrombotic therapy, that is dual antiplatelets for less than 1 year at least, lipid lowering agents, annual influenza vaccines, and most important thing is adherence to these drugs. So third thing is, the target should be, BP target should be less than 130/80, and LDL cholesterol level, they have brought it down from 70 to 55 recently, and HbA1c level should be less than 7. So to concise, make lifestyle changes, adherence to dual antiplatelet therapy, treatment targets, systolic BP should be less than 130/80, LDL should be less than 55, and HbA1c less than 7. So first thing, to concise, to conclude, first always think ACS at the initial assessment. A is an abnormal ECG, C is a clinical context of the patient, S is a stable patient. You come to think invasive strategy. In a STEMI, you have 2 options. If the patient can reach the PCA capable hospital in less than 2 hours, you plan for primary PCA therapy, or you lyse the patient and then refer. If it has very high risk end-STEMI patient, immediately refer. If the high risk patient, end-STEMI patient, yearly angiography within 24 hours is recommended. And then think antithrombotic therapy, that is antiplatelets with aspirin, clopidogrel, anticoagulant, unfractionated heparin, and low molecular weight heparin. Always think revascularization, that is either PCA or CVG, but you should aim for a complete revascularization. You should always consider image-guided PCA, that will be a precision PCA. Stent maloperfusion, dissection, and restenosis rates will be lesser if you do an PCA with OCT guidance. So imaging physiology, that is FFR, should have always an important role in fixing the lesion. So think secondary prevention. After we discharge a patient, dual antiplatelet therapy should be continued at least for 1 year. Lipid lowering agents, smoking cessation, rehabilitation, risk factor management, and psychological management. Thank you.
Thank you.
Thank you for your excellent presentation on acute coronary syndrome, how to approach. Actually, everything explained by step, which will be very useful for the newcomers or the postgraduates. And also you nicely elaborate the oxygen demand of the heart followed by thrombolysis, how to make the oxygen demand very less by giving beta blockers and AC inhibitors. That's also very nice, sir. And you told that nowadays the recent guideline says LDL must be less than 55. That is also very important, the new one for us. And some of the studies says even 35 is better. And some of the studies also LDL is 35 is also better. Thank you for your excellent presentation, sir. Over to my co-chair.
Thank you, sir. It's a short span of time, you well explained the ACS, sir. It is only one question for the benefit of the audience, sir. Some of them clinicians have not having echocardiogram in the primary practice. So normal ECG, repeatedly normal ECG, without echo, how we proceed? Enzymes.
If you think that
Chest pain is there.
first you have an clarity about that cardiac test. You have ensured that patient is having a cardiac test pain next to an ECG. You suspect a small changes in ECG, most probably you will have a proper NSA in your lab. So do proper. The proper is negative. If you think that patient is having a passive test pain, every test is yes, ACC. If your judgment question is like everything cannot fit into an ACC criteria without an echo, you subject the patient to a treatment test.
Okay, thank you.
So it's an ACC or what you're asking is an ACC.
Yes. Atypical chest pain.
That is a clinical judgment with some proper in the area of decision. If the proper is negative, you can subject the patient to treatment test. Or if you having you don't have a treatment in your clinic, you can ask the patient to walk in a flight stairs 3 times. Particularly in this moment, and the SC shows ST depression, it may be.
Sir, another one question for you. How possible primary angioplasty in our Indian setup?
There are a lot of logistic reasons involved. So we might be thinking within what I have told is within 1 to 2 minutes. But we have to convince the patient, we should engage the patient with this and major heart attack, we should arrange an ambulance. There are a lot of logistic reasons involved. Most probably in our setup, it's very, very difficult for the patient to reach within 2 hours to that PCA center. And the wire crossing time and everything, the guidance there, even 0 in recommendations. They have an different facility, but bringing that to our Indian setup is very eager that we are able to achieve the wire crossing time within 90 minutes. So if the patient is well within the town, patient is in the primary town, we can directly send the patient to this around the town, like Koila, some other places. You can accommodate, establish the patient in the center. So even if the traveling time with the neighbor doesn't really happen, we will be using a lot of neighbor systems. Flight treatment is only of the vessel needed via our companies. Not the clock, so that we can patient immediately.
Thank you, sir.
It's a wonderful presentation, Dr. Vijesh. I'm practicing in a periphery called Ambasamudaram. What problem we have always is, always there will be road work, always there will be traffic jam. So in practice, we make it sure that we initially thrombolize and send it for PCI. The one other thing I want to ask you is, the severe chest pain, you have to, before thrombolizing, you have to rule out aortic aneurysm. Because we had so many aneurysm cases and which popped off immediately.
That may be a difficult thing to attend. Most of the, like, if you take 100 patients with a cardiac chest pain, like excruciating pain, that may be 1 or 2 aortic dissections. We stop lysing to treat the aneurysm patients. You may be seeing the 98 other patients.
Clinically, is there any specific point, chest pain with severe back pain? Because I myself had 2-3 cases, severe chest pain, they're rolling on the cot. There you should stop thrombolizing. Thank you.
Thank you, sir, for your concise lecture. Now we request our chairpersons to honor Dr. Vijesh Anand, sir. We request our chairpersons to honor Dr. Vijesh Anand, sir. I now request Dr. Ramaya sir to honor our chairpersons for this session, Dr. Loganadhar sir, Dr. Rajan sir, and Dr. Muhammad Rafi sir.
பண்ணிடலாமா அந்த லேப்டாப்பை?
Thank you, sirs. With great enthusiasm, we bring to your attention an event where knowledge meets questions and the stakes are high. Access 24 quiz after the scientific sessions at 5 p.m. will have you compete for top honors and exciting cash prizes worth rupees 20,000. We challenge all the inquisitive minds to prove their mettle.
We have come to an important segment of the day, the inauguration. Access 24 is a one-of-a-kind event organized by Aruna Cardiac Care. We take great pride in asserting that Access 24 has been a great success so far, with around 350 registrations in its first editions. We have participants from all the southern districts of Tamil Nadu. I once again extend a warm welcome to everyone present here.
Now, I request everyone to rise up for the Tamil Thai Vaalthu.
நீராறும் கடலொடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ் பரத கண்டமிதில் தெக்கணமும் அதிசிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகம் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திரும்பியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. Light is the symbol of positivity and knowledge. I now genially welcome our special guest, Dr. Chenniyappan sir, Dr. Saraswati ma'am, former Dean, Tirunelveli Medical College, Dr. Subramanian sir, Senior Physician, Kadayanallur, Dr. Arunachalam sir, Founder and Chairman, Aruna Cardiac Care, and Mrs. Swarna Arunachalam ma'am, Managing Director, Aruna Cardiac Care, to light the lamp and bring forth radiance.
Thank you, dignitaries. I now invite Dr. Arunachalam Sir, Senior Consultant and Interventional Cardiologist, Founder and Chairman, Aruna Cardiac Care, to deliver the welcome address.
Good morning, everybody. Give a lot of pleasure to see the whole hall is full. This Access 2024 is the first annual conference of Aruna Cardiac Care. நோய் நாடி நோய் முதல் நாடி அது தணிக்கும் வாய் நாடி வாய்ப்பச் செயல். இது எல்லாருக்கும் நல்லா தெரியும். உற்றான் அளவும் பிணியளவும் காலமும் கற்றான் கருதிச் செயல். மருத்துவ நூலை கற்றவன் நோயினுடைய வயது முதலியவற்றையும் நோயுற்றனுடைய வயது முதலியவற்றையும் நோயின் அளவையும் காலத்தையும். This fits for acute coronary syndrome. Time is the muscle. So with that, we started, myself and my wife, Dr. Swarnalata, she's ME PhD, this 2.5 years back with the idea of giving affordable care in cardiology and other sectors. So this was done in December 2021 with 2.5 years. We have a mission of doing ethical practice, trusted care and unparalleled expertise with excellent innovation, commitment to the community and patient-centered approach. We are serving a comprehensive cardiac care, cardiac surgery, interventional cardiology, with 3 cardiologists 24/7 and emergency care with 4 anesthetists critical care serving 24/7 with all the subspecialties, diabetology, neuro, nephro, gastro and pulmonology. We have the first time in South Tamil Nadu, the state-of-art Cath lab, IGS 320G, and we are proud to say that we are the first in Tamil Nadu to have artificial intelligence enabled optical coherence tomography with angio co-registration. And this helps in precision PCI, and we have a cardiothoracic operation theater of a 0.5 HEPA filter which reduces infection recovery. And with God's grace and all of your support and well wishes, we have crossed 3,500 coronary angiograms, 1,250 coronary angioplasties, of which 450 are complex angioplasties, including left main angioplasty, bifurcation angioplasty, calcium arteries. And I'm proud to say that we have done primary angioplasty 350, which is, when you compare with that, 1,000, it accounts 25%. As Vijay said that in country like India, the primary angioplasty reach is somewhere between 10 to 18% only, and crossed 165 CABGs with 1 neuro intervention. And we are proud to say they are first in South Tamil Nadu to produce orbital atherectomy for a calcium lesion. And also we had an operator from US, and then we did the first minimal cardiac surgery. That is just, instead of conventional sternotomy, there will be just between the fourth rib, this much only incision, and will be done for a young fellow who has a severe bleeding PR. And that was the guy. And we have a cardiology team full 24/7, and we have done this is the first conference for the general practitioners and physicians. We already conducted 2 national conferences, cardiovascular advanced therapeutics in imaging in 2022, attended by national faculties, and again second in 2023, and the third is going to come on October exclusively for the cardiologists and senior physicians. And this is the first, and I am proud to have the legendary speaker, Dr. Chennappan sir, one of the he breathes in and out with academics in spite of so much of his things, and we have a lot of achievements, and this is what we got the greatest brand award, Asia award at Dubai, and my managing director, Dr. Swarnalata, received it from that, and we got the Economic Times Excellence Award, and from Health Minister Honorable Ma Subramaniam, we received the Times of India Award. And within our community programs also, we got another award from our guru. And we have done a lot of works, this, especially during the flood. Our institution helped a lot of people by giving the essential commodities, and we conducted more than 120 healthcare camps during the flood time. And we are proud to announce our Commissioner of Tirunelveli launched the non-communicable disease vehicle, which reaches every villages, and we screen the people for diabetes, hypertension, coronary artery disease, and obesity and COPD with simple blood sugar, as set the clinical risk stratification, and also needed ECG and blood sugar. And we have also our ICU ambulance launched in the periphery of Kohipatti to serve the people and have reached the pharmaco-invasive strategy. And also a lot of education is given through YouTube channels and social media platforms, Instagrams, for the benefit of the people. And I'm very privileged to introduce our today's legendary speaker, Dr. Chenniyappan sir. He being a senior consultant cardiologist from Ramakrishna Hospital, Trichy, he doesn't need any introduction, but still it's my duty. He is the honorary director of medical education, Apollo Specialty Hospital, Trichy. He completed MBBS from Stanley. He's a Stanleyan, so spins that spirit. I did MD and DM from Stanley. He's a winner of RV Rajam gold medal for first rank in MD at Madras University, and he is the first rank holder in DM cardiology at Madras Medical University. Got Best Doctor Award 2011 by Dr. MGR Medical University. He is winner of Association of Chest Physicians gold medal, and he worked short tenure as assistant professor in 3 government medical colleges in Chennai till 1989. After that, he started his own dream hospital, and he was doing for since then. He has published more than 100 papers in various national journals and has presided as speaker in various national and international conferences. He is author of a lot of books, especially related to ECG and echocardiogram, and with this next also we will be launching ACC helpline, that is a number which will help all the practitioners in all the 4 districts, and Chenniyappan sir will be launching that in short. And you can send any ECGs or clinical scenarios either related to cardiology or other thing to that number, and our institution 24/7, our 3 cardiologists and other senior critical care specialists will be to your doorstep to help you to get into any dilemmas in management of acute coronary syndrome and other critical care scenarios. Thank you.
Thank you, sir, for the heartwarming welcome. It's a great honor for us to launch the ACC Lifeline, a helpline number for physicians on this occasion. We invite Dr. Chenniyappan sir, Senior Consultant Cardiologist, Ramakrishna Nursing Home, Trichy, to launch the ACC Lifeline.
It's my honor to open this unique informative portal. I think all the best, and people also can utilize this wonderful information giving platform. Thank you, sir. Thank you for the honor.
Thank you, sir. I now request Dr. Arunachalam sir to honor Dr. Chenniyappan sir with a memento. ACC lifeline 93453 44444. Moving on, we have our distinguished Dr. Chenniyappan sir, Senior Consultant Cardiologist, Ramakrishna Nursing Home, Trichy, to talk about ECG in CAD. Over the past 30 years, Dr. Chenniyappan sir has traveled the length and breadth of India, training doctors in the interpretation of ECG. Through the ECG and Echo Club of Trichy, every year, more than 200 young doctors and interns get trained in ECG interpretation. Years of teaching experience has helped Dr. Chenniyappan sir evolve a concise, accurate, and easily graspable method of reading the ECG. It is indeed a great honor to have you here today, sir. This session will be moderated by Dr. A.S. Mohan sir, former head of the Department General Medicine, Tirunelveli Medical College, Dr. Pothirajan sir, senior physician, Dr. Thomas Kingsley sir, associate professor, Thoothukudi Medical College. We invite the chairpersons to take over the stage. Now I request Dr. Chenniyappan sir to take over the stage.
It's not working. Is it working?
So, good morning to everyone. So, first of all, thank Dr. Aruna for inviting us to this CME. So, Dr. Chenniyappan sir doesn't need any introduction. Well-known cardiologist. He's a famous cardiologist. So, worldwide, so he is famous for his echo classes. So, many people from all over India has attended his echo conference. So I have been attending his ECG classes since my PG period in 1991 in Trichy. Also I have attended. So from his class we can diagnose without angiogram. So which artery is affected? Not only main branches, even small branches. So left coronary, right coronary, small branches, which branches is occluded. So can be diagnosed by ECG. So he has delivered many lectures and conducted many workshops in our API medicine updates and other forums in Tirunelveli. Welcome, sir. So proceed, sir.
Thank you, Dr. Mohan. Thank you, chairpersons. I first of all thank my good friend for the last 30-35 years, Dr. Subramaniam first, for inviting me here. To define Subramaniam, his hospitality defined. So personified, you can say hospitality personified. His hospitality is so intense, he will not even allow me to carry my computer bag. So that is his hospitality. So first I thank him for that and thank Dr. Arunachalam for this wonderful opportunity. I thought, being a heavy Murtam day, I thought Subramaniam and Arunachalam alone will be there in the hall. So I am very surprised, pleasantly surprised to see such a huge audience. So usually I don't prefer introductions, sir, because that will create a lot of expectations from the audience. So my job, if I am not able to meet that expectation, it's so huge. So usually I don't prefer to have any introduction. Of course, the introduction has been done, so my responsibility also has become more now. So what I'm going to talk is that the ECG in coronary heart disease, but I have taken up an opposite path of how not to diagnose a ECG from coronary heart disease from ECG, how to not to miss a coronary heart disease from ECG. So you would have heard many lectures how to diagnose coronary heart disease from ECG, but hardly you hear lectures how not to miss. So missing coronary heart disease is more dangerous than actually diagnosing it or treating it something. So that's what my main aspect of my talk will be. So first of all, I want to make you understand what is the basic difference between a coronary angiogram and an electrocardiogram. So if you enter any one of the big hospital and say chest, you need not even say chest pain. You say chest, you will be directly taken to the Cath lab for coronary angiogram. Just say chest, directly coronary angiogram. So what is the difference between coronary angiogram and electrocardiogram? Coronary angiogram is a luminogram. It gives you the lumen of a big epicardial coronary artery. And electrocardiogram gives you the ultimate myocardial perfusion. Coronary angiogram tells you the big arteries are normal, ECG tells you your myocardial cell is receiving blood or not. So the ultimate myocardial perfusion is shown by electrocardiogram. So I am coming from Trichy, so I will always quote Kaveri. So your Kaveri may be normal, but still your plant may not get water because so many branches are there between Kaveri and the plant. The coronary angiogram tells you the Kaveri river is normal. ECG tells you whether the plant is getting water or not. So irrespective of your obstruction in any portion of the coronary artery, ECG will tell you whether the myocardial cell is getting blood supply or not. That is a major difference. That's why today we see with a normal coronary angiograms, you have myocardial infarctions. We have a separate entity today which is called myocardial infarction with non-obstructive coronary artery called INOCA. So even the obstructive coronary arteries may not be there, still you have myocardial infarction. So that is the importance of electrocardiogram. And second, the most important clue the ECG gives you regarding the viability. Your artery may be obstructed. Whether the obstructed artery is supplying a good myocardium or a already dead myocardium is a very important point to know whether you have to revascularize that artery is not. 100% LAD occlusion and it is a scar in the interval, there is no point in opening. There is no point in opening for the patient. That is, there is a lot of points in opening for other things, but there is no point in opening for a patient with a scar. Whereas if that 100% or 99% artery is coupling a healthy myocardium, you should open it. That scar or viability is shown by electrocardiogram. So although you are doing a coronary angiogram, ECG will tell you whether to revascularize or not. And after revascularizing, ECG alone will tell you that whether to revascularize or not. So there are 3 ECG changes of coronary heart disease. The ischemia is shown by T wave. It can be a tall T wave or inverted T wave. The most important aspect is the acute coronary syndrome is injury, ST segment elevation or depression, and a chronic infarction will make the viability of R wave to disappear and make a scar of pathological Q wave to appear. So infarction is QRS, ST segment is injury, and T wave is ischemia. ST segment is always acute. Infarction is always chronic, whereas the T wave change can be acute, subacute, or chronic. All the 3 things can happen on T wave, but ST is always acute. ST injury is always acute. So beautifully, Dr. Vijay has given a very beautiful lecture on ACS, and he has told you what is the ST elevation ACS and non-ST elevation ACS. So basically, both are because of the behavior of the atheromatous plaque. If the plaque gets eroded, then the thrombus, acutely formed thrombus, is the one which produces ACS. It is not the plaque which produces the ACS. It is a rupture or erosion of the plaque which produces ACS. If there is an erosion and the small portion of the plaque is exposed, and the acutely formed thrombus is going to critically occlude a coronary artery and not totally going to occlude a coronary artery. And that clot or the thrombus is going to be rich in platelets. That's why it's called white thrombus. So whenever there is a plaque erosion, there is a white thrombus with a critically occluded coronary artery, and still some flow will be flowing through a small intact lumen to the distal myocardium. And this is non-ST elevation ACS, which may be unstable angina if troponin is negative, non-ST elevation MI if troponin is positive. And how do you recognize that in your electrocardiogram? Whenever the patient comes with acute chest pain and there is an ST segment depression, that tells you the patient has got non-ST elevation ACS. Your pathology is critical and white. So you never thrombolize a patient with ST segment depression. Because the thrombus is not rich in fibrin, the thrombus is not totally occluded on the electrocardiogram. So you never thrombolize a patient with ST segment depression because the thrombus is not rich in platelet and rich in the fibrin, and it is only critically occluding. Contrast to that, if the plaque ruptures, it exposes a large amount, especially the lipid core, to the circulation. Whenever the large amount of plaque is exposed, it's not only the platelet, but also fibrin. The coagulation system gets activated. So you have a huge thrombus, which is totally occluding the coronary artery, and it is rich in fibrin. That's why it's called red thrombus. But it is total occlusion. So red thrombus, total occlusion, no blood flow is going to the distal myocardium. Your job is to open the artery immediately. That's why whenever the patient comes to the ST segment elevation, you must thrombolize or send him for a PCI, or thrombolize and send him for a PCI. So no other investigation will tell you that. Patient comes with a similar type of chest pain presentation. ECG alone will tell you whether it is a non-ST elevation ACS, where your pathology is a critical and white thrombus, I will not thrombolize. Whereas ST segment elevation, I have a red and total occlusion, I will thrombolize and open an artery. So that is the importance of ECG when you take the first ECG when the patient comes. So it not only gives the diagnosis of ACS, it tells you what to be done and what not to be done. So many times people thrombolize in ST, it's like depression even where Kerala registry said, in India, almost 30% of patients receive wrongly the thrombolytic therapy because of the lack of basic understanding of what ECG in acute coronary syndrome means. So when a patient with acute coronary syndrome means you think your responsibility is over by giving a letter. So today I want to change that idea. So each person, whoever it is, he may be a general practitioner, a gynecologist, an orthopedician, or a surgeon, irrespective of hospital, irrespective of your specialty, always have an electrocardiographic machine in your clinic or in your hospital. Any acute chest pain patient, take ECG immediately. When you take ECG, there are only two things. It is not rocket science to diagnose an ACS. ST elevation, ST depression. So these are the two things. Even gynecologists can diagnose acute coronary syndrome, ST elevation, ST depression. So whenever you diagnose that immediately, within 5 minutes you take an ECG, you see a ECG immediately. If the patient has got acute coronary syndrome, don't just give a reference letter. Immediately give soluble aspirin of 325 milligram, 300 milligram of a clopidogrel if the patient is above less than 75, above 75 milligram of bolus, and 40 to 80 milliliter of statin. All these three drugs should be stored everywhere, in any hospital, in any OP. Whatever you are, these drugs should be there. Soluble aspirin, clopidogrel 300 and 40 to 80 milliliter of statin. Immediately you give that as soon as you see the ECG. Then of course, if the patient has got non-ST elevation ACS, the patient is not going to be thrombolized, the treatment is going to be heparin. So you can even give a first dose of heparin if there are no contraindication, if there is a ST segment depression. Then give nitrates only when the heart rate is between 50 to 100, systolic pressure is more than 100, if the patient has not taken sildenafil for the last 24 hours and the patient has got acute RVMI. So 4 caveats are there to give sublingual nitrate. Don't put sublingual nitrate always whenever the patient has got chest pain under the tongue. So immediately motivate the patient to go and arrange a good transport with a facility to an immediate center where you have decided that whether you do a PCI or thrombolysis. How to decide PCI thrombolysis? Vijay beautifully did 120 minutes. It is not 120 minutes to reach the hospital. It is 30 minutes to reach the hospital and 90 minutes door to balloon time in that hospital. So the 120 minutes is divided into not 120 minutes to reach the hospital. It is 30 minutes to reach the hospital and 90 minutes to door to balloon time there. Only when the patient is able to reach that hospital and that hospital is going to do that balloon PCI within 90 minutes, then only PCI is better than thrombolysis. If cannot be done, thrombolyze him immediately, as Dr. Laura beautifully said, thrombolyze within 10 minutes. If the patient is going to take 3 hours to reach a PCI, because we have a wrong concept that any acute myocardial infarction, angiogram is the best, angioplasty is the best, primary PCI is the best, and I cannot do anything about that. So my responsibility is over, giving a reference letter, so on, so cardiologist. Of course, these days reference letters gives a lot of income also, that I don't interfere with that. So just a reference letter give you a lot of income also. But you are responsible to do your patient with the ACS. Then inform that doctor who is in tertiary care unit that he is coming for PCI, he is coming for thrombolysis. So he keeps the cath lab ready, he keeps the ICU ready, so that the patient, as soon as he enters, he goes directly, because you have given a bolus dose, you have given everything, you have decided the patient is eligible for thrombolysis or a PCI, his cath lab is ready, his ICU is ready. So as soon as the patient enters the tertiary hospital, patient directly go to the ICU or directly go to the cath lab for the definite treatment. So whoever you are, what you are going to do, you are going to yearly recognize an ACS, because within 5 minutes you are going to take an ECG with acute chest pain. 2, you decide about the acute coronary syndrome, you are going to give drugs which will immediately open the artery. Which are there? Aspirin, clopidogrel and statin, which starts lysing the clot. And 3rd, you are going to immediately transport the patient And fourth, what you are doing, you are reducing the time delay in the tertiary institution by informing the doctor that this patient is coming. So I think from today, our job in any acute coronary syndrome patient is not to give a reference letter, but to do all these things so that you have enormous. Today, you must understand, the principal and aim of treatment of acute coronary syndrome is not saving a life at all, saving the myocardium. You may save a life, but the patient has got a dead myocardium. After that, the PCA is done, no use at all. So you have to save the life and myocardium. That can be achieved only when you do all that, irrespective of whatever you are. You may be in the tertiary institution. You may be in the medical college. Dr. Mohan is there. Many times I told in our medical college, Tirunelveli Medical College, in the ECG room, in triage or casualty, these drugs should be there. As soon as the ECG is taken, and also the ECG shows acute coronary syndrome, in the ECG room itself, in the triage itself, these drugs to be given before transporting the patient to ICU. Even within the institution, these drugs should be immediately given. Don't give him the entry-coded aspirin. So I am not supposed to teach this here because I had the lecture on ACS. Then from sitting here, I inserted this slide in my lecture to make you understand what is your responsibility in an all-patient acute chest pain is not giving a reference letter, but do something important to save the life of the patient by doing just 4 things. Immediately take an ECG, see the ECG. If it is acute ACS, give the loading dose and inform that, and immediately transport and inform the doctor. That's all. So here you can save a life and save a myocardium. So with this we come to my part of the lecture. I think it's now 11, so we'll try to save some time by going through a little bit. So here, if I show this patient with an acute chest pain, you can see the ST elevation, more than 2 leads. How to recognize ST elevation? ST elevation more than 2 consecutive leads. 2 leads must show ST elevation. And however many leads are showing ST segment depression, still it is ST elevation ACS. If 2 consecutive leads are showing more than 1 millimeter ST elevation in the limb leads and more than 1.5 to 2 millimeters in V2, V3, in other leads more than 1 millimeter. So here you have ST elevation here, so in inferior leads. So what might think, so you think here, you will say acute inferior wall infarction, isn't it? But what I want to think is, because it is ST elevation, I will start with the word of acute. Second, because of the ST elevation, I know it is a total occlusion. And third, I know the thrombus is red thrombus. So the artery is, because inferior wall, it is right coronary artery. So how I describe this ECG is acute total occlusion of right coronary artery with a red thrombus, not inferior wall infarction. So you know this patient has got acute occlusion of right coronary artery, so you have to immediately open up, because at this point in time you have a very good R wave. What does it tell you? Myocardium is injured, but it is viable. So if you open the artery now, you will keep the viable myocardium as it is, and you will not allow the myocardium to be dead. So that's why I wanted to do all this to save this type of patients with ST elevation MI. So now the diseases, this is a very famous statement. I think Subramaniam may remember. This is a very famous statement of our professor, Dr. G. Anand Subramaniam, from whom we learnt the ECG, from whom we learnt the clinical cardiology, all that. So he always say diseases don't read textbooks. It is not as if from today the person's ECG is going to read Shamrath or hear my lecture and come and present to you with exactly like this ST elevation, where the diagnosis is easy, the treatment is easy. But because diseases don't teach, they will present with all sorts of manifestations. So what is the aim of this lecture is not to identify this, but how subtly these changes can present, how not to miss these changes. So that's why we come first, what are the earliest changes in acute coronary syndrome we usually miss, early changes. Because as you can see, when the patient comes like this, now what will be the diagnosis for this ECG? The patient is coming with acute chest pain, he has got ST segment depression. So because he's got ST segment depression, I will start with the word what? Acute. But what is the thrombus here? Critical. What is the type of thrombus here? White. What I will not do here? Yes? What I will not do here? Thrombolysis. What I will not do here will be thrombolysis. Depending upon his risk, we will send him for a medical therapy or an angiogram. So if the patient comes with these two type of ECGs, like a huge elevation and a huge depression, it's so easy to diagnose. But that's why the diseases don't reach books. That's why the earliest sign of an acute coronary syndrome or the subendocardial injury or even a coronary heart disease is this. If you look at the ST segment is gently concave upwards. So with a very gentle concavity upwards, and you will not know where the ST segment is ending and the T wave is beginning. This is a normal ST segment. But the earliest sign of coronary heart disease is called the horizontality of the ST segment. If you look at here, the ST is horizontal and hugs the baseline more than 3 squares, and you have a very sharp STT junction, and this is the sign of earliest coronary heart disease. When the patient comes to acute chest pain, this horizontal ST tells you this is going to develop a ST segment depression in the next ECGs. Or a patient with a high risk, diabetic, smokers, hypertensives, you routinely take an ECG and that ECG shows this horizontal ST segment with a sharp STT junction, his coronary heart disease has been started. But superficially it looks normal. But the subtle sign tells you that you have either an acute coronary syndrome with acute chest pain is coming, or in a chronic situation, he has already developed an occlusion in the coronary artery. So that's why it is very, very important to concentrate on this very subtle sign. If you go back and see the ST segment, you can easily compare. See the normal ST segment. It goes like this and doesn't hug the baseline at all. When the ECG hugs the baseline for more than 3 small squares, it is the earliest sign of coronary heart disease. That's why it is very, very important to, for example, if I shown this ECG yesterday, you should have normal, in the ECG is normal. But today, if you concentrate that subtle sign of horizontal ST segment, you know the coronary heart disease has been started. So these are the differences between two ST segments. You can beautifully say how beautifully the ST segment goes up in a normal situation, whereas how the ECG hugs the baseline and becomes a very sharp STT junction, that this is a sign you should not miss in coronary heart disease. So this will be the earliest sign of coronary heart disease. So the caveats are sometimes in a severe bradycardia and hypocalcemia, you may have to have this type of long ST segments. So make sure that clinically correlate the ECG, always the ECG interpretation with the clinical knowledge. Don't ever interpret an ECG without the clinical knowledge. If you want to be a good electrocardiographer, you must be a basically good clinician first. Then only the ECG comes. Then of course, now we can see that here I have an acute inferior valve infarction. So what I see is that, so here in all acute inferior valve infarctions, I want to know whether there is an RV infarction. That's a very crucial point, because whenever an acute inferior valve infarct patient has got a RV infarct, he has got a proximal right coronary heart disease, because the first branch of the right coronary artery is RV branch. So if RV is involved, the block is proximal to the right coronary, that means a proximal RCA. If a same acute inferior valve infarct patient does not have an RV infarct, he's got a distal right coronary lesion, his prognosis is good when compared to a patient who's got a proximal RCA plus an inferior valve myocardial infarction. Most of these patients, we have to do a right-sided leads to diagnose a RV infarct. So you have to do a right-sided leads to diagnose a RV infarct. But what I'm going to tell you is that whenever this patient has got this type of ST segment elevation, it is very easy to diagnose an ST elevation MI. Just like I told you, what is the earliest sign of the ST depression, what is the earliest sign of ST elevation? Even before the patient comes like this, it is easy to diagnose. But how to diagnose before this? Patient may come to you with half an hour chest pain. It takes some time for this ECG change to develop, but the patient comes with a half an hour chest pain. You take an ECG and the ECG may be normal. Once again, you have to concentrate on this concavity. If the instead of concavity upwards or outward, if it becomes convex outward, it is the earliest sign of ST elevation. After 2 hours ECG, you will show huge ST elevation like this. But once again, a superficial ECG will look normal. Like this, you see, patient is coming with acute chest pain. You see ECG and V1 to V2 has got ST segment. Only 2 leads are showing ST segment depression. You think it is non-ST elevation ACS. Because only 2 leads are showing ST elevation ACS, you will not thrombolyze this patient. Low risk, you will start giving heparin and aspirin and so on. Unless you concentrate on V5 and V6. Look at the ST of V4. Look at the ST of V5 and V6. What is that important finding you find? you find that concavity is lost and you have a convexity outwards. And look at inferior leads, you see that ST segment, you see that coving of the ST, you see the loss of that concavity in inferior leads. So what is happening really in this patient is, yes, he's developing an anterolateral STEMI, inferior STEMI, and also the posterior STEMI, which is producing reciprocal depression in V1 and V2. So the V1 and V2 is not an anterior lesion, it is a reciprocal or posterior lesion. Unless you find this type of convexity outwards, this is called the slope elevation, where the convexity is outwards. So most often you miss this patient and think this is non-ST ACS and give heparin, and what are the walls are going to be involved? It is a lateral wall, inferior wall, posterior wall is going to be scarred if you don't give a thrombolysis or a PC in this patient, if you are misdiagnosing this as non-coronary ACS. So these are the two important signs. So what you have to see is the concavity. If the concavity is nicely there and it is going upwards, most often you are dealing with a non-coronary chest pain. Whereas this concavity becomes horizontal or the convexity becomes upwards, that is the earliest sign of acute coronary syndrome. So this is the how you have to find out the early signs of coronary heart disease. So here it is most often non-coronary, there it is coronary. Then I told you in inferior wall infarction, we always take the right sided leads here. If the V4R shows a ST segment elevation of more than 1 millimeter, we diagnose RV infarct. What is the importance of RV infarct? It tells you it's a proximal right coronary lesion. And the RV infarct may go to shock because of the RV is involved, and the treatment of shock is fluids. And prognosis is poor because you have an RV infarct. But many times what happens is when the patient comes with inferior wall infarct, you may not have the right sided leads. You have to spend some time for taking right sided leads. So when the patient has got only DCG, without right sided leads, how to diagnose an RV infarct? Without right sided leads. So for that, what you have to concentrate is the ST segment depression between V1 and V2. Patient has got a right ventricular infarction, inferior wall infarctions, and look at the anterior leads. You can see the ST segment depression is very obvious in V2, and the ST segment depression is not at all there in V1. So this is called discordant ST segment depression. Here it is, what is happening is this patient has got three things. One is he's got inferior wall, and because the anterior V2, V3 showing ST segment depression, it is a reciprocal or posterior wall. So he's got a posterior wall infarction. And third, I want to know whether there is an RV infarct. For that, I have to spend another 15 minutes to take the right side leads. But if I am able to say from this ECG itself an RV infarct, I know with a single ECG, I'm also diagnosing the third infarct, RV infarct. So if you look at V1, V1 is not only an anterior lead, but it is also a right-sided lead. So V1 is anterior and right-sided lead. The posterior wall tend to depress ST because it is an anterior lead, posterior wall ST elevation, so V1 will show ST segment depression. But RV infarct will do what? It will tend to elevate ST in V1. So V1 is confused. RV infarct is tend to elevate the ST, posterior wall is tend to depress the ST. Net result, V1 is become neutral. I will not stand to posterior wall, I will not stand to anterior wall, RV infarct. So V1 ST is normal. Whereas when you come to V2, it becomes a purely an anterior wall or anterior lead. It shows faithfully the reciprocal changes and it is not be involved in RV infarct. So V2 will show ST segment depression. So whenever in a 12-lead ECG we have this discordant depression between V1 and V2, you know three things. One is inferior wall. Second is because it is a posterior wall, and because of the discordant ST segment depression here, you know it is an RV infarct here. So if you take a right-sided lead in this patient, it will beautifully show the ST elevation in V4R. So even in the absence of the right-sided leads, the subtle change of this reciprocal or discordant ST segment depression will tell you the patient has got right ventricular infarct. So it's a high-risk inferior wall infarct. Why? 3 walls are involved and I have a proximal right coronary lesion. Single ECG, within 5 minutes you can make all this diagnosis. So it is, many of the time we think inferior wall infarction is benign. But this inferior wall infarction is very dangerous. RV, posterior and also inferior. So it's a high risk inferior wall infarction. Your approach to the ECG is very, very aggressive. So without right leads, how to recognize an RV infarct is this, the discordant ST segment depression between V1 and V2. So when you like this, when this patient has got acute chest pain, a gross ST segment depression V1 to V3, so naturally you will think it is non-ST elevation. Yes, critical occlusion, white thrombus, so I will do risk stratification to decide medical treatment or not. But if you carefully see that inferior wall, there is a small elevation in inferior wall. So many times in inferior wall, your reciprocal changes of the posterior wall ST elevation is more obvious than the elevation in the inferior wall. Your primary ST elevation is much less when compared to the huge reciprocal depression of the posterior wall. So that's why in all anterior segment ST depression, carefully see the inferior wall. So inferior wall is showing some sort of ST elevation of more than 1 millimeter here. So this will qualify for STEMI and for a PCI and thrombolysis, whereas if you miss that, you will diagnose as non-coronary ACS, non-ST elevation ACS, and do not attempt full revascularization by PCI or thrombolysis. So that's why, once again, a subtle sign is a inferior wall ST elevation. So all anterior ST segment depression, look at the inferior wall and don't miss a STEMI primarily, which is actually misleading you as non-STEMI by the significant anterior ST segment depression. So that's why when you want to be different, you must look ECG different. So whenever there's inferior wall infarct, everybody will be looking at the inferior wall. You don't look at the inferior wall, look at the anterior wall. Anterior wall tell you a lot of things. When there is a discordant ST segment depression, it tells you RV infarct. When ST segment depression is there, V1 to V3, it tells you posterior wall infarction. So whenever there is an anterior segment ST depression, many times the reciprocal changes will be more obvious than ST elevation. Always look at inferior leads. That's why in inferior wall infarction, look at the anterior wall. In anterior wall ST changes, look at the inferior wall. So please make sure you don't miss an anterior wall elevation. Crucial decision regarding thrombolysis should be made. That's why it is there always. Then I told you about RV infarct with a discordant ST segment depression. So the lesson is inferior wall infarct, always look at the anterior wall infarcts. Now this patient is almost 59 years and coming to you with some sort of chest pain, and what you find here is not ST elevation or ST segment depression, nothing. This ECG looks beautifully normal, isn't it? Unless you concentrate on this RR interval. You can see the RR interval is quickening there, slowing down here, quickening here and slowing down there. What is that? It's called sinus arrhythmia. A sinus arrhythmia in adult is abnormal. Sinus arrhythmia in children is usual and physiological. So sinus arrhythmia in children is abolished by AST. Whereas in sinus arrhythmia is in adult, you have to think of right coronary lesion, because the right coronary most often supplies sinus node. When the sinus node becomes ischemic, it fires irregularly. And second is sick sinus syndrome, and third is earliest sign of digoxin toxicity is sinus arrhythmia. So the presence of sinus arrhythmia in adult is abnormal. The absence of sinus arrhythmia in children is abnormal, because a large AST in children will abolish sinus arrhythmia. So whenever they have a sinus arrhythmia in elderly, try to suspect a right coronary disease. Because of that, the sinus node is ischemic, and trying to give you the change in the RR interval. And three conditions which can produce sinus arrhythmia in adult will be right coronary lesion, earliest sign of digoxin toxicity, and of course sick sinus syndrome. Now once again this patient comes with acute chest pain. Once again 68-year-old female comes with acute chest pain. Your ECG is totally normal. But you will be surprised, this patient has got acute coronary syndrome. This patient has got acute coronary syndrome. So you will be surprised to know this patient has got acute coronary syndrome. Many times I told you, look at the ST segment T wave and the QRS, but we forget there is one more wave after the T wave, which is called the U wave. U wave also will help you to diagnose coronary heart disease. Most often we don't look at all, we forget the U wave. If you carefully see the V4, V5 and V6, you have the positive T wave and you see the U wave which is inverted. You can see that here that U wave is inverted. The U wave inversion is a very important and subtle sign of a coronary heart disease, because as you can see that here, I have expanded V4 and V5 and V6, and you can see that after the T wave, you have the in wave, which is usually the U wave with a go with the T wave. The T wave is upright, U wave is upright. T wave is tall, U wave is seen prominently. So U wave faithfully follows the T wave. Whenever the U wave becomes unfaithful, you are in danger. So many times the inverted U wave is a very subtle sign of coronary heart disease, but make sure that you don't miss that. So whenever a negative U wave is highly specific for the presence of coronary heart disease and may be the earliest marker of unstable angina and evolving myocardial infarction, and the U wave inversion has been shown even in earliest sign of left main coronary artery lesions. So that's why any acute chest pain patient, I tell you, Q wave, T wave, ST segment. But look beyond that. Even a U wave beyond the T wave will give a very important clue regarding the acute coronary syndrome. And it is said that LAD or LMC occlusion and the presence of left ventricular dysfunction. So we can see how much of information can give that inverted U wave is. It is a CAD, it is an acute coronary syndrome, it is a LAD, LMCA, and LV dysfunction. All these things happens with a very subtle change of this. After the T wave, the U wave gets inverted, and that is the important sign of an acute coronary syndrome. And of course, before we move, that three important signs I've told you. The flat ST segment is the earliest sign of subendocardial injury or non-ST elevation ACS is the flat ST segment. Whereas the earliest sign of ST elevation ACS is coving ST segment, that coving of the ST segment. And of course, don't miss the inverted U wave. Right, so these are the earliest signs we likely to miss. Then the problem is we have a bundle branch block, which may interfere with the diagnosis of infarction, especially left bundle branch block. Because in a left bundle branch block, you have a lot of changes which will mimic or mask the associated coronary heart disease. So this is an ECG definition of ST elevation ACS. If the patient has got you have to demonstrate ST elevation in 2 consecutive leads. I told you about 2 consecutive leads. If the patient is less than 40 years and male, in V2, V3 it should be equal or more than 2.5 millimeter. If it is a male, equal or more than 40 years, it should be more 2 millimeter. Whereas if it is a less than 40 years, other leads, it is only 1 millimeter, equal or more than 1 millimeter, only V2, V3 changes. Whereas in females, V2, V3, irrespective of the age, should be equal or more than 1.5 in V2, V3, and all the other leads should show equal or more than 1 millimeter in 2 consecutive leads, supplied by the same coronary artery. Then only your STEMI is there. And of course, I come to that when there is a lot of confusion, acute chest pain, left bundle branch block, I should thrombolize or not. So because many of the guidelines have said, acute infarct, acute LBB may indicate a STEMI. And of course, I have shown you a lot of examples of how to not to miss a posterior ST elevation, which will mimic a gross ST segment depression in anterior chest leads. So that's also ST elevation ACS. So this is a classical left bundle branch block. So left bundle branch block, the discordance is the rule. Discordance means, because in left bundle branch block, the depolarization is delayed. So what happens is that whenever your QRS is upright, the ST segment, the T wave will be opposite, because the depolarization delayed, the repolarization will happen from endocardium to epicardium. So this will produce a downsloping ST segment, a depression of the J point, and asymmetrical T wave inversion. So whenever the QRS is upright, ST and T wave are down. Whenever the QRS is down, the ST and T wave are up. So discordance is the rule for a typical left bundle branch block. But when this happens, so this is a typical left bundle branch block, QRS is down, T wave is up. QRS is up, ST segment and the T wave is down. But this changes in what is known as the left bundle branch block put forth by Scarbosa criteria. The Scarbosa criteria told us how to diagnose an acute coronary syndrome, especially interval STEMI, in the presence of a left bundle branch block. For example, in V5, V6, I am supposed to have a downsloping ST and the T wave inversion. Instead of what V5, V6 shows an ST and the T wave going along with the QRS, which is called concordance. This concordance in V5, V6, ST is there along with the QRS, T wave is also going with the concordance. This is called a 5-point. Whereas I told you in a classical left bundle branch block, the V2 itself will show an ST segment elevation. You can see that normal left bundle branch block itself, V2 will show up to 5 millimeter ST segment elevation. Here once again it is discordant in a complicated, uncomplicated LBB. QRS is down, my ST is elevated. Whereas when you have an ST segment depression in V2, where you expect the ST segment elevation, where the QRS is down, the ST is also going down concordant with the QRS. The second concordance is V2. It's got 3 points. And third, I told you, in V2, the ST elevation LBB should be up to 5 millimeter. If your ST elevation in V2 is more than 5 millimeter, this is called excessive discordance. So, 2 concordance and 1 excessive discordance got 2 points. So when you add these 3 points, if the patient has got more than 3 points, that means he's got a very high sensitivity to diagnose an associated interval infarction, especially STEMI, where you can boldly thrombolize that patient when compared to a classical LBB, where you have to go for other investigation to decide whether it's ST elevation ACS is not. This is called the Scarboso criteria. So we look at the ECG here. Please remember how a classical uncomplicated LBB looks like. So then only you can appreciate the changes I am going to show you. You can look at that classical LBB, downsloping ST, J point is depressed, and ST and D wave was down. Look at this patient which is coming to you with acute chest pain. Look at V5 and V6. Look at V5 and V6. You can see that here. My ST is going up, my T wave is going up. I no longer have that, the downsloping ST and the T wave inversion. This is a typical patient with the LBB and STEMI, and this patient, once again a subtle sign. You look superficially LBB, nice. V5, V6 downsloping ST, but V6, you see that V6, it has got a beautiful ST which is going up, and also the T wave is up here. This tells me this patient is not a classical and pure LBB. This patient has got associated STEMI, so I'm bold enough here to thrombolize this patient rather than a patient comes with a classical LBB. If the Scarbus, that means he has got a 5 points here. Straight away concordance in V5, V6 is 5 points. That means it's more than 3 points. So definitely I can thrombolize patient. So apply the Scarboso criteria whenever you have an ST segment, compare the ST segment with the QRS and so. Now I'm going to, so this is a concordance in the anterolateral leads. Whereas now you look at V2 here. Now in V2, an uncomplicated LBB should show what? ST segment elevation. But what's happening here? In V2, I have the ST which is going along with the QT which is down. So this is a second concordance. So this has got the 3 points here. So whenever your ST is going down with the QRS here, so this is a second concordance. So this has got the 3 points. Once again, it will help you to diagnose, acute coronary syndrome in the presence of left bundle branch block. So this has got 3 points. So this is how you can diagnose the acute coronary syndrome in the presence of LBB with 2 important concordances. ST going along with the QRS and T wave with the V5, V6, or the ST segment depression happening along with the V2. Then of course we have the, then the patient may have a LBB. So now what's happening here, V5, V6, I have that flat ST segment. What is the classical ST segment should be in LBB? Downsloping. You have a J point which is depressed. Here you see that horizontality of the ST segment I told you, with the LBB. You have the horizontal ST. What is happening to the T wave now? It is going along with the QRS. So here it is called homophasic aesthetic changes in LBB. So LBB, the T wave also becomes along with the direction of QRS. This once again a sign of coronary heart disease in the presence of left bundle branch block. So ST segment should be down like this, whereas it has become horizontal and the T wave is like this. It may not come to you with acute coronary syndrome. A patient with a chronic coronary heart disease may have this ECG. And you all have confusion whether this is a pure LBB or associated coronary heart disease is there or not. You will do a coronary angiogram and all the things. The ECG tells you it's got a coronary angiogram definitely. The coronary heart disease definitely. Because even without angiogram, we can say, why? Flat ST, homophasic T tells you this patient is not pure LBB. He has got definitely coronary heart disease, he has got a coronary occlusion which has produced horizontal ST and a homophasic ST changes. So that is once again a sign to diagnose coronary heart disease in the presence of LBB. Then this patient has come with acute chest pain or some chest pain long ago, but you think that you can beautifully you look here, oh, classical LBB, because I have a downsloping ST and I have a discordance and I have a discordance here, the ST is elevated V2. We think there is no acute coronary syndrome. This patient does not have a coronary heart disease because he's got a pure LBB. unless you concentrate on a very small Q wave is got V5 and V6. In LBB, you will never have a Q wave in LBB. In LBB, the septal activation comes from left to right, not come from left to right, it goes from right to left. So no Q waves in LBB. So if you have even a small Q wave in the presence of an LBB in front of the R wave, it indicates an old myocardial infarction. This Q wave need not be pathological. Pathological Q wave is deep and broad. Even a small Q wave in front of the R wave of LBB tells you that patient has got old myocardial infarction, the scar there. So that's why it's a very important, once again, a subtle sign. Superficially, it looks like a classical LBB. You think there is no coronary artery disease there because whatever the sign I told you is not there. The ST is down, AJ point is down, asymmetrical T waves are there. You think there's no coronary artery disease. But this patient has got a old myocardial infarction. We're just looking at the Q wave in V5, V6. So this is what I'm trying to show you. To expand it means you see that Q wave there. In a classical LBB, you will never see any Q wave. The first wave, it should be the R wave. In a classical LBB, because the septal activation is coming from right to left, so that initial activation in uncommon LBB cannot produce a Q wave unless there is a scar there. So that is the infarct. So there are a lot of other signs to diagnose the infarct with LBB. I'm going to show you some of the rarer signs. Another patient with LBB, once again, comes with acute chest pain. Once again, I don't have these classical, you can see the secondary ST changes are there. The discordant ST elevation is not huge. I don't think this patient has got acute coronary syndrome or coronary heart disease unless you concentrate on this S wave. You can see that slur in the S wave in V2 and V3. This slur in the S wave in the LBB is once again a sign of coronary heart disease, and this is called Cabrera sign. So whenever you have the LBB, concentrate on these signs, a small Q wave, concordant ST, flat ST, whether I have a slur in the R wave in V2 and V3, this is called Cabrera sign. The Cabrera sign is very important to diagnose acute myocardial infarction in the presence of lobar branch block, consists of notching of the upslope of S wave in V3 and V4. It has got a low sensitivity, but has got a very good specificity. When this sign is there, definitely coronary heart disease is there. The absence of this sign does not rule out coronary heart disease. We always have confusion about sensitivity and specificity. I make it very simple. If the sign is there, what is high specificity? When the sign is there, coronary heart disease is most often there. The sign is not there, does not rule out coronary heart disease. That is a low sensitivity. So that's what this sign means, a Cabrera sign of slur of S wave in V2 and V3 and so on. Once again, this patient comes with acute chest pain. I don't have the Cabrera sign. I don't have the classical ST segment and the T wave. I don't have the Q wave at all, but I look at the L1. L1, I have the notched R wave. V2, V3, I had the notched S wave. This patient has got notched R wave in L1, and this is called the Chapman sign. Of L1 and AVL, notched R wave is called the Chapman sign. The Chapman sign indicates once again acute myocardial infarction in the presence of LBB, and it's happening in L1, AVL and V5, V6. Once again, the specificity is 90%. That means when this sign is there, most often you have coronary heart disease in the presence of LBB. The absence of this sign does not rule out a coronary heart disease. So how not to miss a coronary heart disease in left bundle branch block? So concordant ST elevation in V5, V6, coronary heart disease, 5 points. Concordant ST segment depression in V2, once again concordance, 3 points. Excessive discordance of more than 5 millimeter V2, excessive discordance 2 points. And homophasic ST changes, ST is horizontal and the T wave is going along with the QRS, is once again homophasic ST changes. Any Q in V5, V6 in LBB indicates an acute infarct, chronic infarct. Notch in the R wave is L1 AVL is Chapman sign. Notch in the S wave in V2, V3 is Cabrera sign. So we have so much of signs. So always we say it is very difficult to diagnose coronary heart disease. I must say it is very easy to diagnose coronary heart disease in LBB because we have so many signs to diagnose coronary heart disease at the earliest in left bundle branch block. So now we come to the right bundle branch block. What is the importance? So when you look at the right bundle branch, it is the most vulnerable bundle because it is a thin bundle. And the most important point you have to answer is it is supplied by the proximal branches of the left anterdescending artery, which is the most important, and also the widow-making artery. LAD is a widow-making artery. So that's why you can see that here, whenever the RBB is involved, when you have acute right bundle branch block with the ST elevation, it always means you have a proximal LAD. Whenever you have an acute LBB with ST elevation, it means a proximal LAD. So now that proximal LAD lesion will have a QR and not RSR. Usually a classical RBB will be initial R wave, then S wave, then the R wave. So it's called triphasic pattern. But when it comes with the infarct, that initial small R wave will disappear. So whenever you have ST elevation anterior chest leads with the acute onset of right bundle branch block with a QR pattern, so this will tell you immediately this patient has got a proximal LAD. This patient must go early coronary angiogram if it is possible, because this patient's prognosis is going to be poor. Whenever there is a conduction system is involved here, he has got a proximal LAD, means huge myocardium is at risk. So this patient has got very high risk antral infarction. So you must go for early coronary angiogram. So that is the importance of RBB in antral infarction. Then of course I told you the classical RBB. You can see that here. The classical RBB is what? Small R wave, S wave, and also the terminal R wave. So it's called triphasic pattern. The loss of that initial R itself tells you the patient may have a septal infarct. Because that R wave is because of the septal depolarization coming from left to right. So that septal depolarization, that is that initial R wave in V1 and the initial Q wave in V5, V6 is because of the septal activation going from left to right. If you have the loss of that Q wave in V5, V6, even normal conduction, and also the loss of initial R wave in V1 tells you old septal MI. Even in the absence of this classical pathological Q wave. So you can look at this ECG versus this ECG. You can see that here, this ECG versus this ECG. Can you appreciate that difference? You can see that initial R wave is absent here, and it is Q here. And also, if you look at V5, V6, I don't have that initial R wave of septal depolarization. I have the initial R wave not in V1. That small R wave, that small Q wave, the absence tells you there is a septal MI. That's why it's called subtle sign. So most often we don't look at the subtle signs, that's all. So the next importance of RBB is in inferior valve infarction. So here we have diagnosed an old inferior valve myocardial infarction. Sometimes it can be LVB or LAFB also. So we don't think there is an inferior because the initial R wave is there. So this is a classical left antrovesicular block. The patient has got a right bundle branch block. So most often we think it's a bifascicular block and go into the arm of therapy of how to deal with a bifascicular block, syncope and so on. But whether this patient has got a coronary heart disease or not, this patient has got a coronary heart disease. This patient has got a post-valve myocardial infarction. It's already has an infarction. How? Classical RBB, once again, what is the rule of bundle branch block? Discordance. What is discordance? Terminal R wave is there. My ST segment, the T wave should be opposite to the terminal R wave. But look at here, what is happening to my ST segment and the T wave in the presence of RBB? Just like I told you, the homophasic STT of left bundle branch block in anterolateral leads. If you have a homophasic STT changes in V1, it tells you coronary heart disease. Second, normally the initial R wave is so narrow and very small. That initial R wave is not because of infarct, it is because of the septal depolarization, a small portion. But whenever that initial R wave becomes tall and broad, whenever that initial R wave becomes tall and broad, it represents the posterior Q wave. The posterior Q wave, your initial R wave. So please remember, the loss of initial R wave is septal infarct. But that exaggeration of that initial R wave is the posterior Q wave. So posterior Q wave will present as a broad R wave in V1. Your ST and T wave will be the same direction, because posterior, you must imagine, I have a Q wave, I have depressed ST segment and the T wave inversion. When you ulta that, what will happen? That Q wave becomes an R wave, the ST segment becomes a homophasic ST, and the inverted T wave becomes upright T wave here. So whenever there is this type of right bundle branch block with the homophasic ST changes there and the initial R wave is very big, this represents very difficult to diagnose post-wall infarction in the presence of RBB. Both will produce tall R wave in V1. When combination is there, this is a subtle point. So this is my crude diagram to tell you how to diagnose a pure post-wall infarction, how to diagnose a pure right bundle branch block, and how to diagnose the combination. So when you have a pure right bundle branch block, what is going to happen is I have that initial R wave which is very sharp and small and terminal R wave. When I have a pure post-wall infarction, I will not get the QRS widening. My R wave alone is tall without QRS widening. It's a pure post-wall infarction. My ST segment and the T wave will be there. But when they are combined, what will happen to this R wave? This R wave becomes taller and broader, and my ST segment, the T wave, will go with the direction of the QRS. Then I can diagnose associated post-wall. Everybody will diagnose RBB only. Because here, there is no typical inferior infarction. If there's inferior infarction, everybody look for post-wall MI. But there's a pure post-wall MI in the absence of inferior MI. So this is the subtle sign. Everybody will diagnose RBB. But if you diagnose RBB with post-wall MI, you are something different. You are something higher among your colleagues. This is the importance of ECG knowledge. ECG knowledge not only helps the patient, it helps ourselves also. ECG knowledge with this type of diagnosing subtle times make your image higher and higher among your colleagues. So at least for that, look at the ECG and learn the ECG. So these are the two important things I told you, a classical RBB and an RBB with a post-wall myocardial infarction. So you can look at that initial R wave, how it becomes more taller and broader, and also look at the ST segment, the T wave, which is going exactly opposite of the classical right bundle branch block. So that's what I told you. Whenever you have that initial R wave which is absent in V1 and V1, and also the absence of R wave, Q wave in V5, V6. So I told you this is a classical old septal MI where that initial R wave is absent because the septum is infarcted. So that's what the RBB is about. So this is the loss of initial R wave. So that's about, so what is the importance of RBB and CAD? Acute interval infarction with RBB, it is proximal left antidescending artery. Loss of initial R wave in V1 can be the ISMI, and that initial R wave becomes broader and taller than it is post-wall MI. Right, then we come to how to diagnose infarct with the presence of a vesicular block. The vesicular blocks, as you know, it happens left antrovesicular block or left posterior block. So most often the left antrovesicular block, you will have the classical initial R wave, small R wave and a deep S wave. In left antrovesicular block, you will have a left axis deviation where the AVL has the tallest R wave, and you have the small R and deep S in all the inferior leads. If your all inferior leads looks exactly the similar, small R and DPS, small R and DPS, this is LAFB, left antrovesicular block. In no other ECG, all your inferior leads will exactly mimic each other as far as the QRS is concerned. Small R, DPS, small R, DPS is LAFB. But the problem here is, LAFB will produce initial R wave, my inferior wall infarction will produce initial Q wave. Then how to diagnose when LAFB is there, inferior wall infarction is there. So patient has got a liberty to have both. You can have LAFB, you can also have inferior wall infarction because LAFB is going to mask your inferior wall infarction. Because for that what we see is, we look what is known as initial incidence. If you look at this L2, L3 AVF, there is a small q and an R and then S. A small q, R and S, and your small q and R and S. So in a pure LAFB, you will have only that initial R wave. But here you can see that what is known as the initial incidence, where the initial R wave is slurred. The initial R wave is, because there is an infarct scar is there, that initial R wave becomes broad and slurred and notched. Then it becomes not only LAFB, it becomes an LAFB with the inferior wall infarction. You can see the classical LAFB very sharp R wave here, but when you look at this, you can see that Q wave and the R wave and the S wave, very subtle sign, but a very important sign, because otherwise you will diagnose only pure LAFB, and without looking at the patient with the coronary heart disease, you may not produce any change in the treatment plan for coronary heart disease. we'll be treating just as a age-related LAFB. So now we come to how to diagnose coronary heart disease in the presence of ventricular premature depolarizations. Most often we think the ventricular premature depolarizations are nuisance. But I'll tell you, ventricular depolarizations are valuable pointer of diseases. They give you valuable clue regarding the presence of infarction. When you look at a very classical ventricular premature depolarization, just like I told you bundle branch block, VPD is going to mimic a bundle branch block. It has got a white QRS. Whenever there's a white QRS, your ST segment and T wave should be opposite, isn't it? Whenever there's a white QRS, your ST and T wave should be opposite to the QRS, which is a discordance. So discordance is a rule in VPD. In any ventricular premature depolarization, when your QRS is up, the ST and T wave are down. When the QRS is down, your T wave is up. So discordance is just like we told about bundle branch block. Discordance is the rule for VPD. So whenever this discordance disappears, we must suspect associated coronary heart disease. Look at here, when you look at the V4 and V5 and V6, can you see the difference of that ST segment and the T wave with a classical VPD? You can see that ST is depressed here. You see the T wave which is going. Whenever the T wave becomes unfaithful to QRS, it is a danger. In a bundle branch block also, even normal conduction also. Unfaithful means in a normal conduction, T wave is inverted. In bundle branch block, it is not inverted, it is going with the QRS. So that means whenever the T wave is unfaithful, it is dangerous. So you can look at in the lateral leads, your ST is not down, it is horizontal, and my T wave goes with the QRS. So this here, although my normal sinus beat here is not showing any evidence of coronary heart disease, the VPD at this point here tells me there is an ischemia in the anterolateral wall because of the flat ST and the concordant T wave in this particular area. When compared to the other areas, you can see other areas. You can classical STT changes, isn't it? Downsloping ST T wave inversion. But only in the lateral lead, I have that concordance is there. Here, my VPD is helping me to diagnose a coronary heart disease even without doing a treadmill test here. So without doing any advanced angiogram here. So similarly, I know this patient has a coronary heart disease and start investigating tests. This is called homophasic STT changes in the presence of ventricular premature depolarization. So we've shown you this. So whenever the patient has got a downsloping ST and the T wave inversion, which is a classical VPD, but whenever the patient has got horizontal ST and an upslip and the T wave going with the direction of QRS is called homophasic STT changes, and this unmasked ischemia, even in the absence of the changes. This is what I told you. Even your sinus beats are not showing anything here. Your sinus beats, your ST segment, the T wave are normal in sinus beats, but your VPD is exposed that. Then we come to this ECG here. Here you can see my AVF. AVF, my L3, AVF, my QRS is normal here. But look at my VPD. VPD has got a Q wave. Whenever your VPD has got a Q wave, just like I told you LBB, in the LBB, Q wave represents infarction. In a VPD also, you will not have the Q wave at all. Whenever VPD shows a Q wave in front of the R wave, it means a scar in that area. Although you do not have the scar shown by the sinus beat there. So here the VPD showing or exposing a scar in the inferior wall. So look for the Q wave in the VPD. Then this is how the VPD will look like. Normal VPD, less like left bundle branch block, will not have any Q wave in front. But we have a Q wave in front in the presence of LBB. It means, yeah, a scar there. Then not only look at the VPDs. Here I have a VPD here. Beautiful VPD. I have a downsloping ST. So classical STT changes here. So I think this VPD is not showing coronary heart disease, but this CCG is showing coronary heart disease. This VPD once again has helped me to diagnose coronary heart disease here. So what I see is not the QRS of the VPD, I see the next sinus beat. The next sinus beat has got the T wave inversion when compared to the other sinus beat. So sinus beat which immediately follows the VPD has got the T wave inversion. This is called post-extrasystolic T wave inversion. Why this is happening? Because after the VPD you have a long compensatory pause. The long compensatory pause means long diastole. Long diastole means ventricle has got full of blood. For the next sinus beat has to contract vigorously to pump the more stroke volume, which means its demand is enormously increased because it has to pump more blood. If you have a compromised coronary supply, demand-supply mismatch is going to happen to that beat. And that beat will show the T-wave inversion when compared to the next sinus beat, which is T-wave normal. So this post-systolic T-wave inversion is once again a very subtle sign of coronary heart disease. So we not only look at the VPD, we look at the post-extrasystolic sinus beat. And that is called and the Levin called this as the poor man's exercise test. Because Levin thought, for this to have coronary heart disease, I have to do a treadmill for this patient, ask him to spend another 2,000, 2,500 rupees. But what the VPD has done, it has come in and showed post-systolic T-wave inversion, tells you, oh, you don't want to do treadmill here. I already have a coronary heart disease. Why you want to do treadmill test in this patient, and saves 2,500 rupees for the patient. So that's why the Levin called this as a poor man's exercise test. So look at the post-extrasystolic sinus beat for the front T-wave inversion, or the diminishing the amplitude of the T-wave, or increasing the amplitude of the T-wave. So this phenomenon is usually related to the myocardial disease and hypertensive heart disease and coronary insufficiency, and correlates well with abnormal response on exercise test. So that's why the Levin called this as a poor man's exercise test. So when you do a treadmill test and you have, although you don't have any ST depressions here, but you have this type of malignant VPDs. You can see the VPDs coming in succession of 3 beats, which is called a run. It means your myocardium is highly irritable when you have the exercise test. When you have a sympathetic activity, that means the ischemia itself is not manifesting as ST segment depression, it is manifesting as irritability of the myocardium, increased irritability of the myocardium. So here also, although I don't have the ST changes in the ECG, because the patient has got a malignant VPD on exercise test, this is also a subtle sign of coronary heart disease. We must send them for a coronary angiogram. So this is a run on exercise test. So just for the completion's sake, I want to just also, I told you a lot of signs which are subtle signs, but I am going to tell you the most dangerous ECGs. Now, these ECGs, this patient should go for early coronary angiogram. What are they? Whenever I have an anteroval myocardial infarction, I must concentrate today on V1 and AVR. If I have an anteroval myocardial infarction, my V1 shows ST elevation of more than 2.5 millimeter and the AVR shows ST elevation. This is a proximal left-handed descending artery lesion. So most often, although the ST segment is not huge, but the most dangerous ECG here. Because here the basal septum is involved. So always in anteroval infarction, look at V1 and the AVR. If they are elevated, it is proximal LAD. Once again, you could look at here that when the patient has got anteroval infarction, many of you may have this sign, a well-known sign looking at lead AVR. Whenever in the presence of anterior segment depression, if you have elevation in AVR, it is a left main critical occlusion. So we always read ECG as a 11 lead ECG. We don't look at the AVR at all, but the AVR is the most crucial lead today. So many lesions, coronary heart disease is exposed by AVR. So in the presence of anterior segment depression, AVR elevation without much of V1 elevation. Now proximal LAD, V1 elevation is more than AVR elevation. In LMCA, AVR elevation is more than the V1 elevation. And this patient went immediately for coronary angiogram to make you understand the angiogram of this patient, which showed a critical occlusion of left main lesion. But this ECG superficially doesn't look as significant at all, a mild ST segment depression. So you think this, okay, when you give sublingual nitrate, this ST segment depression will disappear, patient will have no chest pain, you will send him home. But this patient directly should go to Cath lab. Question of time, he is going to have a massive STEMI of left main lesion. Then of course, this is well-known sign of valence. Whenever you have acute chest pain of yesterday, when he comes today, he does not have chest pain. But the ECG shows deep T-wave inversion V2, V3, V4. Patient is stable, no chest pain, he had chest pain yesterday. This is called valence sign. Once again, critical occlusion of proximal LAD. It is an aborted STEMI. Yesterday you would have had a ST elevation and spontaneous reperfusion has happened, opened some amount of artery, resulting in the saving of the myocardium, but telltale sign of critical ischemia is there, Once again, this patient should go for early coronary angiogram. And I'll skip this. And this is another very important sign. So whenever you have the acute chest pain, the patient has got a downsloping ST and a very tall T wave. So down the very typical pattern, this is called the D Winter sign. So D Winter sign is ST segment depression with a very tall T wave. It is a STEMI equivalent. It is an almost total occlusion of a lady. So whenever you have this D Winter sign, the patient should go for early coronary angiogram, and it presents in 2% of anteroval MI, and this is a classical D Winter sign. Can also happen in summer. So it's called D Winter sign. The downsloping ST with a very tall T wave, acute chest pain, the patient should early coronary angiogram is a must in these patients. So we have seen subtle but significant ECG changes. So to see these changes is very common. It is not STEMI or non-STEMI. You are not missing STEMI or not STEMI. You are missing a coronary occlusion. You are missing a coronary artery disease if you are not concentrating on the subtle signs. So subtle signs are apparent. With a well-prepared mind can be detected. I hope many of you will detect these signs in your life later on. And these subtle signs are detected and upward interventions are done. Major STEMI, non-STEMI, and sudden deaths can be prevented. So, to give a takeaway messages are, I have given you many subtle ECG signs. When you recognize those signs and do appropriate intervention, you will save many lives. And not only life, as I told you, the most important aspect of ACS treatment is not saving a life alone. It is a saving the myocardium. That means the early treatment and also early correct treatment. I am giving early treatment, but I am thrombolizing ST segment depression. No use, isn't it? Early correct treatment that will save myocardium, and sooner the intervention will save the myocardium. So often missed by others. If somebody has gone for some marriage today, and he will not know all these signs, he will be missed by others, but you have attended this class today, definitely you will make sure that these signs are diagnosed by you, and you save lot of patients, not only the lives, and lot of myocardium also. So often missed by others. So this is what I told you. When you pick these signs among your colleagues who are not capable of diagnosing this, you become so special among your colleagues. But the last thing, if you miss these signs after this, it will make me so sad. Thank you for your patient listening.
So thank you, sir, for your excellent presentation about the various changes in ECG in CAD, in various wall and with conduction defects. So any question from the audience? So this is only interactive session. So audience can ask any question.
Well, I always remember when I was doing postgraduate in Madurai Medical College, we used to have that clamor for attending your classes, sir. And sir has that knack of, he used to finish that with the bikini picture, what is revealing and what is not revealing. That is the subtleties we should take care of. What is obvious there, we'll all see, but we used to miss the things which are subtle, but which makes the decision maker all the more tougher. So thank you for revealing so much, sir. So any questions from the audience? There are no further questions. I think we'll close the session. Sir.
Thank you, sir. Thank you, sir, for the methodical and systematic talk. We now invite Dr. Madana Gopal, sir, Senior Physician, Kovilpatti, to honor the chairpersons, Dr. A.S. Mohan, sir, Dr. Pathirajan, sir, and Dr. Thomas, sir. Thank you, sirs. We shall now break for tea for 15 minutes and resume the next session by 12 p.m. Refreshments have been arranged outside for everyone. Thank you.
We now request Dr. Arunachalam sir to honor Dr. Chenniyappan sir with a memento. Thank you, sir. I request everyone to kindly be seated. We are about to begin the next session. I repeat, we request everyone to be seated as we are about to begin the next session. We request the audience to be seated. We are about to begin the next session.
I request all audience to be seated. We are about to start the next session. I repeat, I request all the audience to be seated. We are about to start the next session. Thank you.
Uh, 934534444 ACC lifeline number. It is a 24/7 helpline number exclusive for doctors. Now we have Dr. Chenniyappan sir to talk on echo basics and what to see in a report. This session will be moderated by Dr. Shanmugam sir, senior physician, Dr. Madana Gopal sir, senior physician, and Dr. Govindrajan sir, senior physician. We welcome Dr. Shanmugam sir, Dr. Madana Gopal sir, and Dr. Govindrajan sir to moderate the session. The moderators for this session will be Dr. Shanmugam sir, Dr. Madana Gopal sir, and Dr. Govindrajan sir. We welcome them onto the stage.
Thank you, sir. And we are going to have the next genre in the cardiology. So having seen something about the electrocardiogram, we see something about echocardiogram. The difference between the previous lecture and this lecture is going to be, the previous lecture you are going to see and diagnose, but in this somebody is going to see and you are going to diagnose. So you are not going to see and diagnose. So somebody else is going to see and you are going to see the diagnosis. For that, you must know, although many of you may not be doing echocardiography, what I thought is how to read an echo report. That's what I'm going to concentrate. When echo report comes, you send the patient for echocardiogram, echo report comes, what to be seen in that report and what exactly must do to that patient. So this is my plan. And why do we need to know? Sir, echocardiography is not in my domain. This is a domain in the cardiologist. So why should I do echo? Why should I read an echo report? So if echo is needed, I refer to a cardiologist. That's all. So once again, that is the idea I want to change. That is the idea I wanted to change. The last lecture is, in any acute chest pain, don't think you are not have got no role. Similarly, when you have an echocardiography, you have definitely some role to play and advise the patient accordingly. So if I answer this question, so how we see the echo report? We see the last line. Echo is essentially normal. Okay, give it to the patient and go. We don't even go into the reports, what they are given, what centimeters they are given, what pressures they are given. We see the last line. Echo normal, echo abnormal, send to cardiologist. That's what we are doing, isn't it? So echo normal, go, no problem. Echo something is abnormal, MEP, refer to cardiologist. So don't do like that. Some of the things you need not refer to cardiologist. Because many cardiologists are very angry with me. Because many of your lectures make the people not to be referred to cardiologist. So of course, cardiologists are busy with balloons, so they don't bother about echoes. So that doesn't matter at all. So that's what I'm not to do. There are certain things from echo report you can keep your patient and treat, and not necessarily send the patient to a cardiologist. Second, for that you need a basic echo knowledge. So it's very difficult to give echo knowledge within a span of 1 hour or so. I'm trying to do my best. So if the patient requires, if this echo knowledge will help you to decide whether I should send it to interventional cardiologist or a cardiac surgeon, or keep the patient myself and treat him. So that sort of confidence you must have at the end of this lecture, if I have done a good job. So that's a caveat. So the next thing is the basic knowledge helps you to choose the type of treatment, not only having decided to give the treatment, echo knowledge will tell you what type of treatment you have to give to the patient. So for referral, treating and how to treat, all this the echo knowledge will help you. Second is, first of all, you must know what is echo. We have seen the electrocardiogram, which is a 100 years old investigation, whereas echocardiogram is a 50-year-old investigation. These two investigations give two different properties of the heart. As you know, heart is a pump. It is like a motor pump pumping water. This pump is pumping blood. Motor pump cannot pump water without you are putting the switch and the current goes to the pump. So the electrocardiogram gives you the electrical properties of the heart. The electrocardiogram tells you where this current to the heart is produced, how much it is produced, and what pathway it is traveling, and what speed with which it is traveling, whether it is reaching the appropriate place at the right time, and that appropriate place is responding to this current correctly. So that is what you get. This electrocardiogram is an electrical information of the heart. This tells you after putting the switch whether current goes to the pump. That's what the ECG is about. Having gone to the pump, whether the pump works better or not, or the pump works normal or not, is the idea given by your echocardiogram. So electrocardiogram is current, echocardiogram is pump. To say the heart is normal, you have to have both. You cannot say because the ECG is normal, I will not do echo. Because echo is normal, I will not do echo, ECG. There are two independent properties of the heart. To say the heart normal, you have to demonstrate electrically it is normal, mechanically it is normal. So the mechanical information is given by echocardiogram. We have seen some electrical information in the last lecture. In this lecture, we are going to see about the mechanical information given by echocardiogram. So it is the most frequently used electrocardiogram techniques. Most of the people have forgotten stethoscope now. Carrying a stethoscope is old-fashioned today. So if you carry stethoscope, it is old-fashioned. Many times it helps us to go into some hospitals without tipping the security. So many times we use a stethoscope to go into the hospital without tipping the security. So that's what we use. Even we auscultate the patient, we think of something, which mall to go, which movie to go. How many people are really auscultating, getting the heart sounds, and then for the patient satisfaction, puts a stethoscope here and there and say you are normal and go. Like this is what we are doing, isn't it? So that's why this has replaced the stethoscope. People say chest pain, you go and have an echo, come, then we see. Why you auscultate, bake your mind, and make a clinical diagnosis and then do an echo. So it has come so much that it has almost replaced the stethoscope. But stethoscope is supreme. You cannot make echo diagnosis, ECG diagnosis without basic clinical examination, clinical findings. I keep on insisting that. Whatever the technology which is coming in should refine your clinical knowledge, but not replace it. So that's the most important thing I want to say. Still, clinical knowledge is the best, and that's why it is readily available investigation, repeatable, how many times you can repeat. It is reproducible, non-invasive, safe and cost-effective investigation, only next to electrocardiogram. The most cost-effective investigation in the world is electrocardiogram. For 200 patients, the rupees the patient pays, you saw what enormous information it gave. Isn't it? In the acute chest pain, it tells you what to be done and what not to be done. So all this is cost effective. So this is what I told you. It is better performed by not a technician. The person who examines clinically must do an echocardiogram. So that means a person who does echocardiogram must clinically examine the patient. Many times, unfortunately, many situations, now technicians have taken over the echocardiogram and not the clinicians. That's why many of the diagnoses are missed, because echocardiographer does small routine some views and give a report, and clinically there is something which is not consistent with echo. So the echo is, I told you, 1955, 1954, Adler and Hertz. So echo came us from a very small country, Sweden. The smallest, one of the smallest countries in the world gave us the biggest investigation of an echocardiography. Although they found echo, but it is the Fig and Bam in 1965 brought into the clinical application of echo by diagnosing pericardial effusion. The first echo diagnosis was made is pericardial effusion. So that's what the story of echo. And you see the old ECG machine, echo machine here. This is the first echo machine. And this is the 1954 echo machine. This is Adler and Hertz there in Sweden.
So this is the first echo machine. And today you see the modern echo machine. The sight of the machine itself will intimidate you. Because you have so much of buttons, so much of knobs, so much of things. The sight of ECG echo machine itself will tell you, this is not my area, run away from it, right? We have so much of knobs, so much of controls, so much of things, but it gives enormous information. Now the echo has gone beyond the simple echocardiography. It started as a small plant, and now it has gone a very big tree. We can see so many things with echocardiogram. Today it is not only echocardiogram of a particular echocardiogram of a patient, and it can give you so many things. It can give you hemodynamic information. It can give you 3D. You can go into the vessel and see. It can give you better echo images, and it can, even before birth, we can do echocardiogram and say what is the heart of the fetus is. And of course, on exercise we can do echo during the operation, during the intervention. We can do a transesophageal echo and guide the interventional cardiologist and surgeon whether he's doing a right job or not. And all this is happening, and all this is happening for echo. So much advances. No longer the patient has to come to the echo lab. Now echo goes wherever the patient is. Now it is so miniaturize, the patient may be having tubes in all his holes. He's having tubes in all his holes, but unconscious, but still you can do an echocardiograph bedside. Today it has come to mobile phone. It is come to a mobile phone. Now just what we do is keep this, auscultate, and immediately open this and put the echo and see and whether the clinical diagnosis is right or not. So much of advances are happening in echocardiography. And echocardiography is what? In echocardiography, just like we say echo, what we do in echocardiography is to send some echo signals from this transducer into the patient's heart, and the patient's heart, various structures of the patient's heart emit the ultrasound. This echo probe gets that ultrasound back and converts the echo image like this on our echo screen of various chambers and various functions of the heart. That's why it's called echocardiogram. We send in ultrasound signals and receive ultrasound signals and convert that into an image. That's what the echocardiogram is about. So what is an ultrasound? What is the difference between regular sound and ultrasound? Human ear can hear only up to 20 hertz to 20 kilohertz. Anything beyond this is called ultrasound. The ultrasound go to millions, 1 million to 20 million hertz, the ultrasound. And of course, that is, the million units are called megahertz, 1 to 20 megahertz. That's why some of you have seen the transducers, they say 3 megahertz transducer, 2 megahertz transducer, 5 megahertz. What does it mean? That transducer is capable of giving so much of millions of ultrasound waves into the heart. So millions of units of ultrasound waves. That's why it's called megahertz, is millions of units. That's why we have different type of transducer depending upon how much of millions of ultrasound this transducer is going to send into the heart. Why we select ultrasound? Why not regular sound? So, for example, I am shouting here. Somebody people from the other room can hear me. Normal sound travels through the corners and go to the, it can go to the other room and go to the hall and so on. Whereas ultrasound travels like an electrical beam. It travels in straight line and comes in straight line. It doesn't travel like this. That's why we utilize this property. We send in the ultrasound to the heart, different structures of the heart emits ultrasound. In a straight line, we receive that ultrasound and convert that into image. That's why we use ultrasound in imaging, because it can travel like an electric magnetic beam. It can travel in a straight line and come back in a straight line. And the second most important point why we use ultrasound is even a small structure like your blood cells can emit ultrasound. So when the blood cells emit ultrasound, if I make the blood cells emit ultrasound, I know where the blood cell is traveling, in which direction it is traveling, how much speed it is traveling, whether it is traveling in abnormal direction, abnormal velocity, abnormal flow, all this I can decide, because even a small blood cell can emit ultrasound. So these are the two reasons why we use ultrasound. It can start it in a straight line. So basically your echo machine is nothing but it has got a transducer, which is the most important part of transducer is called piezoelectric crystal. So this is a piezoelectric crystal. The transmitter in your echo machine gives the electrical signals to this piezoelectric crystal. The beauty of the piezoelectric crystal is convert this electrical energy into ultrasound energy. That's what the piezoelectric crystal does. Once it converts the ultrasound energy, it sends into the heart. So each layer of your heart emits ultrasound. Each layer of the heart, as it goes down, it emits ultrasound. And the ultrasound is received by piezoelectric crystal, once again converted into electrical signals again. So it receives ultrasound and converts again into electrical signals, and it is received by a portion of your machine, and that receiver amplifies this returning signals and put in as an image on your echocardiographic screen. So the piezoelectric crystal is the most important point which is inside the transducer. So it receives current from the machine, sends in ultrasound, receives ultrasound. This gives information to the machine. The machine converts this ultrasound into an image. So this is how our echocardiographic machine. So these are the 4 parts of our echocardiographic machine, for which they charge you 30 lakhs. So this is the 4 modes of the echocardiography: 2-dimensional, motion mode, Doppler, and color Doppler. These are basic modes of echocardiography. Each one is different. It's not as if one is, if you do one thing, you cannot do other thing. Everything is, it's a comprehensive echo evaluation needs these 4 modes of echocardiography. See, the problem with the echocardiography, the problem with the ultrasound radiologist, it's always nice to have a life of a radiologist, isn't it? So that's why the radiology seats are going in crores, because it's very nice to have a radiologist, because the radiology has got an organ which is just behind the skin, just below the skin, a huge organ which is not mobile. So it's very easy to image that. But my heart is inside my lungs and bone. Lungs and bone will not allow my ultrasound to go to the heart and come back to the heart, come back to the machine. So I have 2 enemies in between my transducer and the heart, which is bone and the air by the lungs. So that's why the life of echocardiographer is difficult, because it is not a huge organ which is just below the skin, which is not moving. My heart is also moving. So that is inside my lungs and inside my bones. So that's why I have to have a very small apertures in which I can see the heart without the interference of the bone and the lung. That's why my echocardiograph transducer has got a very small footprint. If you see the echocardiograph transducer, the footprint means that the end of the transducer has got small. When you get the regular ultrasound, it's big. Because as I told you, radiologists need not do anything. They just keep it there. The liver is there, the uterus is there. That is not moving and sitting behind the skin without any interference. Whereas we have to find this echocardiography. These are called echocardiographic windows, where we put in this small footprint echocardiographic transducer in an area in the intercostal spaces where my heart can be seen, or the ultrasound can reach the heart without the interference of bone and air. That's why we have lot of windows. One we call a parasternal window. Second is called the apical window. The parasternal window itself can have a long axis and short axis. Then we get the heart from the below, subcostal window, and we can look the heart from above. It's called suprasternal window. So these are the windows, but you can see that transducer of my heart, very small footprint, so that I can place that footprint inside that intercostal space where I can see the heart. So with this maneuvers of this particular windows and the maneuvers of the transducer, I get various views of the heart. It can be parasternal long axis, short axis, where the long axis, the heart looks longitudinal. In short axis, it looks circular. We have different cuts of the short axis. Then we look at all the 4 chambers from the apical view. We can look at 2 chambers from the apical view. We can look at the short axis at the aortic root. We get the subcostal view here, and we get the suprasternal value here. So with these maneuvers, we get so much of views. Don't bother about that, but please remember how the views are obtained by an echocardiographic performer. So because of this, because by seeing all this, in each view, I see a particular structure. Why I am doing so many views? In particular view, I see some structures. In a particular view, I see some structures. One structure which is seen in one view may not be seen in the other structures. So I have to perform all the views to see entire heart. Right from the aorta to the apex, I have to see the entire heart, right heart, left heart, atrium, ventricle, all the valves, everything I have to see by maneuvering this transducer, so that I get different cuts and different views, so that I can get the entire portion of the heart. So we can see, you need not concentrate on that. So whenever I do a person long axis view, I can look at the mitral valve, aortic valve, and also evidence of coronary heart disease. My personal long axis view is like this. So I see the mitral valve, aortic valve, and whether the IVS is moving or post wall is moving to diagnose coronary heart disease. When I go to the personal short axis view, I get 4 cuts where I can diagnose congenital heart disease, mitral valve disease, coronary heart disease, and cardiomyopathies. The apical 4-chamber view, where we see all the 4 chambers here, we can look at the mitral valve, tricuspid valve, and how the heart is moving, whether function is all right or not, all this 4-chamber view. And the apical 2-chamber view, we look at for coronary heart disease. All the long axis views means like this, the apical long axis, apical 4-chamber, apical 2-chamber, all these views used for Doppler. So the difference between a Doppler and echocardiography subsequently come, and these 4 chambers are used. And of course, this is about 2D examination. This is called 2-dimensional echo. So 2-dimensional echo gives you what it gives you in a single frame. For example, if you freeze it a single frame, it will give you a lot of structures. It gives you LA, left ventricle, IVS, RV, but on a single frame only. For example, you freeze it in systole you will see all the structures. If you freeze it in diastole, you will see all the structures. So the 2D echo gives you multiple structures in a single portion of cardiac cycle. That is 2D echocardiography. In a single view, I see everything. Either in diastole or in systole only. In a freeze and frame, I will look at in only one phase of cardiac cycle. Whereas when I do motion mode examination, I look at a single structure in multiple cycles. I can look at only mitral valve. I can look at only aortic valve. But what I see, because I am seeing a single structure, I see it in systole and diastole, systole and diastole, systole and diastole. So the M mode makes me to understand what is the dimension in systole, what is the dimension in systole, how the mitral valve is moving in diastole, how the mitral valve is doing in systole. So multiple cycle I see, but the problem in M mode is what? I see single structure, but multiple cycles. Whereas 2D echo, multiple structures, single cycles. That's why both have to be done. Because it is very difficult to get M mode cut without 2D. For example, once I do a 2D, if I want to do what is happening to the mitral valve in systole and diastole, I put an M mode line here and put the cursor on the M mode line here and push the M mode button. I get this mitral valve alone in systole, diastole like this. If I want to have the ventricle in systole and diastole, I put a M mode line here, then I get the ventricle in systole, diastole and diastole. So majority of measurements we do in M mode. Why we do M mode? Because M mode's frame rate is very high, because it is looking at only one structure. I get very clear cut lines. Whereas 2D the lines are fuzzy because it is seeing multiple structures. Whereas M mode is seeing a single structure and multiple cycle. The second advantage of M mode is I can simultaneously see a single structure in both in systole and both in diastole. So that will give me how this structure is actually moving in the 2 cycles simultaneously. At the same time, M mode I cannot do blindly. I have to do 2D, then I have to get the M mode line, and the M mode line I have to put it in the M mode line. For example, I look at the aorta, I put the M mode line at the aorta, so I measure aorta and the left atrium. Then I move the cursor to the mitral valve, I measure the mitral valve in systole and diastole. Move the cursor at the left ventricular level, I get the left ventricle in systole and diastole, so I get end diastole dimension, end systole dimension. So in this way, we do 2D and then an M mode cut. So the M mode cut will give you a very good, this is what we have done. So you can see this is a 2D. 2D you can see the lines. They are so fuzzy, isn't it? The clear cut lines are there, so I cannot measure. Because one more thing is, here the mitral valve is closed and the aortic valve is open. In what phase the patient is in? What phase of cardiac cycle the patient is in? Mitral valve closed, aortic valve open. Yes? He is in systole or diastole? Systole. See, he is in systole. The aortic valve open, his ventricle is contracting. In systole, the mitral valve is closed, the aortic valve is open. The flow is going to go from the ventricle to the aorta. So when I freeze it only in systole. I do not know what's happening in diastole. So what I do is, as I do, I cut here the aortic valve. So I get the aortic valve like this in a mode. You can see the aortic valve is opening and closing, aortic valve is opening and closing. So I know what is the aortic root dimension, how much my aortic valve is opening, what is the dimension of the left atrium. So here only I measure. Why I measure in M mode? Because it's a single clean line. Similarly, when I move that cursor towards my left ventricle, what is happening? I get very clear-cut left ventricle septum in diastole, systole, diastole, systole. Diastole, you can see the line, so clear lines. So I measure the end systolic dimension, end systolic and end diastolic dimension. So with this I know what is my end diastolic volume, end diastolic dimension. So from there I calculate ejection fraction. So this is how we utilize these two properties of the ultrasound, because I want to do measurement in M mode. Why I want to measurement in M mode? Single structure, many cycles, my frame rate is high, I get a very good line. But the problem is I cannot do plain M mode, so I have to have a 2D, look at that structure and then get the cut at that mitral valve level or the left ventricle level to get at that structure in M mode. So we do all the measurements in M mode. So what is my aortic valve opening? What is my aortic root dimension? What is my LA dimension? What is my end systolic dimension? What is my end diastolic dimension? What is my IVS thickness? What is my post wall thickness? Everything is done only in M mode. So we utilize M mode we get the M mode from the 2D and try to calculate all the values. So this is the concept of doing M mode and the echocardiography. So first we do the echocardiography. We look at the various cuts to see the various structures of the heart. I told you each view is going to give you different structures and give me idea about different diseases. Then I do M mode to measure everything. So now I have an anatomical detail. Here I can see my heart is contracting and relaxing, the valve is opening and closing, but I do not know whether the valve is leaking or not, whether the valve is obstructed or not. It seems to be opening nicely and closing. Whether there is a leakage in this valve, whether there is obstruction in the valve, what is my intracardiac pressure, what is my left atrial pressure, what is my right ventricular pressure, what is my PA pressure, all these things I will not have information if I have only 2D and M mode. So this gave me anatomical information. Then I must have a physiological information. So here what happens in 2D and M mode, we made the ultrasound to be emitted by the walls and valves of the heart. Here what is happening? The ultrasound is emitted by what? The walls of the heart and the valves. So they emit ultrasound, so I see only the anatomical structure of the heart. But only when I see the blood flow going through these valves and through these chambers, I will get a physiological information. So for that, the people have developed what is not that Doppler principle. So this is the Christian Doppler, who developed actually for the physics, this Doppler, and the Doppler, as you know, is utilized in many areas of the industry. So it just said only one thing. The velocity of the moving object depends upon whether it is coming towards you or going away from you. So people beautifully give an example of you are standing in the railway station and a train is coming whistling from far off. The whistle is very low in amplitude. As the train comes near you, the whistle becomes the maximum, and when it is crossing you, it is the maximum. As it goes away, the whistle intensity comes less and less. That's what that Doppler is about. If a moving object is coming towards the transducer, it will have a particular velocity. If the object is moving away from the transducer, it has got a particular velocity and the direction. So I know whether my red cells are coming towards my transducer or going away from my transducer. With what velocity is coming, the one is direction. Another is what velocity with which it is coming, and whether it is coming with a normal flow or a turbulent flow, whether it is coming in a uniform flow or it is coming with a great velocity flow. All this I can develop only when I have a Doppler. So Doppler gives me physiological information inside my heart. So having seen anatomy through 2D and M mode, I am going to have a Doppler. So what is the difference between 2D and Doppler? In 2D, I made the ultrasound to be emitted by the walls of the heart and also the valve of the heart. Whereas in Doppler, I make the blood cells to emit ultrasound. So I make a filter so that I no longer get the Doppler from the walls and valves. I get only the small moving structures is going to give me the Doppler signals. So by doing that, I know how the blood cells are moving in the heart, inside the heart. So what velocity they are moving, what direction they are moving. As I told you, if they come towards the transducer, it will have a particular pattern. If the blood cells are going away from my transducer, it will have a particular pattern, because the velocity of the moving object depends upon whether it is coming towards you or going anywhere. From that I know, in this area, the blood is going away from the transducer. Is it physiological or pathological? Isn't it? Then I know velocity. In this, across this valve, this is the maximum velocity. Whenever the flow is coming through the narrow orifice, it will have a great velocity. A simple example is, when you have a bathtub and you have a tap, if you open the tap and does not do anything, it is a uniform flow. When you obstruct 3/4 of the tap, you know how much with speed that 1/4 of the tap is giving you that very high velocity flow, isn't it? Similarly, when the flow goes through the narrow orifice, it has got a great velocity. So whenever a velocity is happening at a particular point, I know at that point that something is happening, something has become narrowed, and the blood flow is going through the narrow orifice. It may be an obstruction of the valve, it can be a leakage of the valve, it can be a hole in the valve, hole in the heart. So anything abnormal will give me enormous increase in velocity. So in this way, I know the direction of the flow, I know what velocity is the flow, and whether the velocity is abnormal, I know what is the problem there, there's obstruction, leakage or so. So this is the difference between 2D and Doppler. 2D, my structures are emitting ultrasound, whereas Doppler, my blood cells are emitting ultrasound. So that's why it is very, very important to use both these methods. It is once again, I told you, it is very, very difficult to do blind Doppler. For example, how can I do blind Doppler without knowing where the blood is moving? Just like I told you about, it is very difficult to do blind M mode. Just putting a transducer, how to get a M mode cut off mitral valve, M mode cut off the valve, I must have a 2D guidance. Similarly, to get the Doppler signal, I need a guidance. The guidance is given by what is known as color Doppler. The color Doppler is nothing but, for example, in a given particular sectoral window, I have multiple points. Multiple points are called sample volumes. In this, I have multiple points. These multiple points are continuously examining whether flow is coming towards me or going away from me. Coming towards me, going away from me. Coming towards me or going away from me. So in the sector, in that particular sector, when I put on color Doppler, these multiple points are estimating whether blood is coming towards me, going away from me. Then they give a color. If the blood cells are coming towards me, it will give a red color. If the blood cells are going away from me, it will give a blue color. If the velocity is normal, it will give a uniform red color. And the velocity is going away is normal, it will give a uniform blue color. So when the velocity is normal in direction and normal in velocity, it is a uniform red and uniform blue. So in this way, I know exactly where the abnormality is happening. Then I apply the Doppler there. Then just like I applied the M mode cut, I apply the Doppler signal there and get the velocity from the Doppler spectrum. So I have to get the Doppler spectrum from the color Doppler. So this is what the red is about and the blue is about. So red is towards, blue is away. BART, B-A-R-T. Blue is away, red is towards. For example, you can see this is the right atrium and this is the tricuspid valve and this is the right ventricle. The flow is going from the right atrium across the tricuspid valve into the right ventricle. So across the tricuspid valve, it's a uniform red. If it is going to be high velocity, I tell you what is there. When it is a uniform red, that means it is going with a normal velocity. The same blood turns around in the RVOT and goes away from the transducer in pulmonary artery. So it turns away, because this flow is going away from a transducer, it is a blue color. So the red and blue does not tell you it is oxygenated blood or deoxygenated blood. So don't think this is a oxygenated deoxygenated. It tells you the direction of flow. It's the velocity of the flow. So here the same right ventricular flow at one point in time becomes red because it is coming towards the transducer. Then it turns and goes away from the transducer, the pulmonary artery. So it is a uniform. So because here I don't have the multiple colors or the high, when it's a uniform red and blue, I am clear, just seeing the image will tell me that I don't have a tricuspid stenosis, I don't have the pulmonary stenosis. If it is a pulmonary stenosis and tricuspid stenosis, it is going to come through a narrow orifice. I will not have the uniform red and blue. This color will change if I am going to have a high velocity. If the color is going to change with the high velocity, I know at that point there is a turbulence. Why turbulence is happening? Something is going through the narrow orifice. It can be a tricuspid stenosis, it can be a pulmonary stenosis, it can be mitral regurgitation. In this, what the color will do is, it will come to multiple colors. Instead of this uniform blue and red, it will come a multiple colors. So you can see that here, when you do a echocardiography, just the valves are moving and the heart is moving. You do not know what is happening inside. But when you do put on the color Doppler, you know, the flow is going away from this apical long axis. The flow is going away from the left atrium across my tricuspid valve with a uniform red color, and the flow is going through the LVOT and across this aortic valve, and through the aortic valve it is going away from the transducer. So here you see that across my mitral valve there is no significant change in the color. Across my aortic valve there is no significant change in color. So that rules out a mitral stenosis and aortic stenosis. So this is what we see the flow. Once we see the flow, we'll actually put the transducer there or a sample volume there. For example, I want to get what is my mitral velocity. Just like I put the cursor on the M mode, I put a cursor across this mitral flow and get the velocity spectrum and measure what is my mitral velocity, aortic velocity, and so on. Now this is what. So here you can see suddenly I see in systole I get a multiple color flow inside my left atrium. In systole I am not supposed to get any flow from the ventricle to the atrium, isn't it? When the systole is there and the mitral valve is closed, I am not supposed to get any flow from the ventricle back into the atrium. But here I get a significant flow from the ventricle to the atrium, and the significant flow is doing what? Multiple colors. It's called mosaic. So whenever you have a mosaic, you know there is abnormality there. There the flow is going through the narrow orifice with a very high velocity. It is a turbulent flow. What we saw in the previous one is a uniform flow, laminar flow, uniform red and uniform blue. Whereas here you get a turbulent flow. So I know where the mitral regurgitation is happening. So what I do is I put a Doppler line here and get this mitral regurgitation velocity. How much is my velocity? How much severe is my mitral regurgitation? Whether it will need an intervention or not. All these things I decide. After getting where the abnormality shown by the color Doppler, I get the velocity measured by spectrum. So what I do is, from that line, from this particular line, you can see that Doppler line here. I get the Doppler line, this is the velocity spectrum. Just like I told you, but the Doppler spectrum has to be obtained with the aid of color Doppler. So that here is the abnormality, here I get the spectrum, and the spectrum is so much, whether it's normal or abnormal. If it is abnormal, how severe it is. Depending upon how much increase in velocity, a small increase in velocity, mild lesion, significant increase in velocity, severe lesion. Then we can decide what to be done. So this is how the entire thing works. So basically, the 2D gives me the anatomical details, whether valve is normal or abnormal, ventricles are dilated or not, whether the valves are opening and closing. So it gives me anatomical detail. Once I put the color, it gives me physiological abnormality or physiological change. So this is where I get the turbulent flow. So this is where I get the abnormality. So what I do, then put the Doppler line across this to get the spectrum. So from the spectrum, I analyze what is the amount of abnormality, what severe abnormality I have, and what to be done. So these three things go together. M mode, first 2D, then I do M mode to measure the anatomical lines or anatomical dimensions of the ventricle. Then I put a color Doppler, see every valve. What is across aortic valve, mitral valve, pulmonary valve. Everything is red and blue, beautiful, no problem. So I get velocities and everything, something I have multiple colors are coming. I know that is the area where I have the problem. Then put the Doppler here and get this spectrum to decide about the severity and decide the management. So this is in nutshell what is the echocardiography is entirely about. So with that, we know the anatomical details are given by 2D and physiological information is given by Doppler and color Doppler. So everything should be go together. From 2D to M mode, from color Doppler to Doppler. So we do the measurements in M mode, we do the measurements in Doppler spectrum. So this is how we day in day out do the echocardiography M mode. Right. Have we understood what is it? What is a 2D? What is a Doppler? We have now, is it? So these are the 4 methods and why we do 4 methods. And second, it is not as if possessing an echo machine is an indication to do echo. Many times possessing an echo machine is an indication to do an echo. You must have correct indication to do an echo. So echo can be done before you send the patient for echo. These things are mandatory. First, clinically examine the patient, get the history, arrive at a clinical diagnosis. Please do not send the patient for echo without your clinical diagnosis. It may be wrong or right, don't bother. But clinically what you can make out, you must send the clinical diagnosis. Do the basic investigation, like for example, simple anemia can produce so much of problem intraocular. The high velocity, it can happen. It's not because of the valve problem, it is because of the anemia problem. Because of the anemia, there is a high velocity happening inside the heart. You will diagnose valvular lesion. Because if you don't look at the hemoglobin, it may be 5. Everything the cause is the problem. So basic other details you must also know. Select a reliable lab. That I do not know how to select. So you must know which lab will give you a reliable report. Because echo is operator dependent. Echo is operator dependent. The person who does must give you correct information so that you can make correct decisions. And of course, write a clear question. This is the point I am sending for echo. I have a murmur, systolic murmur. Here I am suspecting aortic stenosis. Here I have a murmur, I am suspecting mitral regurgitation. Here VSD is I am suspecting. So clear cut, clinical. So that person may clearly look for. Instead of writing echo, you will keep on searching what it is there. Whereas you have written, I have a systolic murmur, my diagnosis aortic stenosis, you will carefully look at the aortic valve and give you the details, what is the aortic valve stenosis is about, what to be done about it. And of course, it is a simple test, not open heart surgery. Please educate the patient when you are sending echo. They will think the echo is open heart surgery and go with a lot of tension. And the heart rate increase itself will increase the velocity. Increase in heart rate itself will increase the velocity. Increase in BP itself will change the gradients inside my heart. So please educate the patient. It's just a simple test. They will put some transducer and get the images, and it's not going to be open heart surgery. So many patients lie on the echo table with a very much anxious because they think their heart is going to be opened. So that also will actually change our intracardiac dynamics, so it will change. So first is evaluation of symptoms. If you have a symptom like chest pain, dyspnea, patient has got an edema, patient has got a syncope, or a patient has got unexplained fever. So these are the situations where you have a symptom and the echo is going to give you the reason for that particular symptom. Why the chest pain is happening. If the chest pain is there, as Dr. Vijay said, there is a wall motion abnormality, the chest pain is due to coronary heart disease. Like that, if the fever is there and the patient has got a vegetation, it is due to endocarditis. So when the patient has got a dyspnea and the patient got LV dysfunction, it is due to LV dysfunction. So evaluation of symptoms is the first most important indication to send, especially for the syncope. The patient is coming with the exceptional syncope, is there a valvular lesion or it's a hypertrophic cardiomyopathy, whether it's a structural lesion causing the syncope. If the structure is normal, the syncope cause is electrical. It may be an arrhythmia which is causing syncope, if provided your echo is normal. So that will rule out a mechanical reason for your syncope, and you have to search for the electrical causes such as arrhythmia. The first one is evaluation of symptoms and palpitation, especially whether it is a volume overload ventricle or a cardiac muscle disease and so on. Second, of course, if you are still a good doctor, still you are using the stethoscope, and still after using stethoscope you are going to use the thing between two earpieces. It is not the stethoscope alone matters. It is to be used between two earpieces. What is in between two earpieces you must use when you auscultate. So when you are using all that and you are detecting some signs, then the echo is necessary. So for example, you have a murmur and you have a rub. For example, you have a rub or a murmur. Second, abnormal heart sounds. For example, you have additional sounds like ejection click or opening snap or a subnormal widely split second sound. So you think the second sound is very abnormal or the additional sounds are there. Of course, gallop. It is very hardly find a gallop these days because to find a gallop, you have to auscultate and you have to auscultate with the bell of the stethoscope lightly applied to the apex. Nobody uses stethoscope. Even they use stethoscope, nobody has got a bell. Even they have a bell, you cannot turn to the bell because many years they have not turned to the bell at all. So it is stuck in diaphragm. So you have to use beautifully to get this third heart sound and the fourth heart sounds that will tell you. Very simple. When you auscultate, a dyspnea patient is coming, when you auscultate, If you have a third heart sound, he's got a systolic dysfunction. If he's got a fourth heart sound, he's got a diastolic dysfunction. That's all. Now, echo may not be necessary to find out what is dyspnea is about. A simple sign of systolic dysfunction is third heart sound. A simple sign of diastolic dysfunction is fourth heart sound. But the thing is, we have to find out. And nobody is there to teach us. Abnormal blood pressure, irregular heart rate, abnormal ECG and X-ray chest, and the patient has got any type of cyanosis, central or peripheral, you have to do an echo. So this is an abnormal signs. The patient may be symptomatic or asymptomatic, but he's got an abnormal clinical sign. Then you do an echocardiography. Then this is a most important fact. To evaluation of risk factors. Patient is a hypertensive, patient is a diabetic, definitely when the patient has got diabetic hypertension, all these patients you must do echocardiography. So diabetes, we'll come to that, hypertension, obesity and sleep apnea, renal failure, and of course the COPD. In all these conditions, you must do echo. Because echo gives you very important information in all these diseases. Whether that particular risk factor is going to produce future cardiac disease is definitely shown. Although patient may not have cardiac symptom at this point in time, your diabetic may not have a cardiac problem, your hypertensive may not have a cardiac problem, but echo will tell you he will develop a future cardiac problem. So by detecting something. So these are the factors. Once again, when the patient has got these diseases, you must send the patient for echo. They must give enormous information. And fourth, patient is already a known heart disease patient, and you are following up. You are not doing any intervention. AST, there is a small AST, there is a small VST, there is a mild mitral stenosis. Already established heart disease. Serially you have to do echo. Every year you have to do echo to see whether particular disease is progressing or when to do intervention, when to send for the intervention. What is the echo? Mitral valve orifice my last year echo. What is my mitral valve orifice today? What is my gradient across my aortic valve last year? What is the gradient today? So we have a cutoff points beyond which intervention is necessary. So serial echoes in a known heart patient. You may be a cyanotic patient, acyanotic patient. So any known patient with a cardiac disease like coronary heart disease, valvular heart disease, congenital heart disease, cardiomyopathy and pericardial disease, you not only do the evaluation of disease, but also you must do serial echoes so that you know when to send the patient for this. Except this, we have asymptomatic patient. This is what I told you. Possessing an echo machine is the indication to do here. So all patients coming in do echo because I have an echo machine. So asymptomatic patients, the two important areas, three important areas says patient has got a known heart disease, especially hypertrophic cardiomyopathy, coronary heart disease, patient has got inherited syndromes, you must do for the siblings. Hypertrophic cardiomyopathy, entire family should be screened. You are very happy. On hypertrophic cardiomyopathy, there are 6 fellows, 6 echo. 6 echo, everybody come do echo, good money. But you must do free of cost for the family members. Isn't it? So you are not detecting a hypertrophic cardiomyopathy in siblings means you should not ask them money. So if the patient has got a problem, you can get money. For example, a sibling has got hypertrophic cardiomyopathy, you are going to assess it, charge him. If he's going to have a normal echo, don't charge him. If you charge him, he will not bring. Isn't it? You can see that I'll do echo. If there is abnormalities there, I'll charge. So that you can do asymptomatic patients. And families have sudden death and syncope. So you must do. And last thing is patient wants echo. Today, patients do not want echo. Today, all patients want an angiogram. Now the patients are changed. They'll come in and say, sir, chest pain. When are you going to do angiogram, sir? So that sort of change we have made in the society of regarding the angiogram, isn't it? So when are you doing angiogram, sir? For example, the people will ask, that person will be there in my United States. For 25 years, he would not have seen the parent. But that parent would have had some sort of chest pain, and he will bring you from States. 25 years he would not have seen, he would not have taken care of, we would have taken care of that patient for 20 years, he will think, oh, when are you doing angiogram, doctor? After 25 years. So these are all things we have. No, that's the important thing. So patient wants echo, do echo, no problem. Patient wants echo, he wants to give you money. No problem, do echo. So don't think you don't have an indication to do echo, I will not do echo. So for example, that fellow has got some silent problem, you will be in soap. So patient wants echo, do echo. That's all. The indication of doing echo is this. Then, having done an echo, what to be seen in the echo report? So the echo report, lot of things you have to see. One, look at the chambers. I tell you the size of the chambers. If there's enlarged chambers, I tell you how to recognize an enlarged chamber subsequently. Valves, the ventricles, in the ventricles you have to see the global function and segmental function. And of course, the most important thing you must see is a pulmonary hypertension, valvular heart disease, LV dysfunction, congenital heart disease. The one important point you have to see is two things. In a particular known disease, valvular heart disease patient or a congenital heart disease patient, two things you must see. One is pulmonary hypertension, what is LV function. Because when you do an echo, it will tell you intervention is needed for this particular lesion. But the pulmonary hypertension and LV dysfunction tells you when to do the intervention. For example, I have a coronary heart disease, I have a AIS patient with LV dysfunction, I will do immediately surgery. Or now it is a fashion, TAVR. So no longer surgery is fashionable, it's TAVR. Every aortic knows it's TAVR. Transaortic, transcatheter, aortic valve replacement. For example, I have a AST. I have a severe pulmonary hypertension. Immediately I will follow to go to close the AST. Whereas AST, normal pulmonary hypertension, I'll wait. That fellow says I have to write +2 examination. Then only I can have a closure. I'll wait for the +2 examination. No pulmonary hypertension. So the pulmonary hypertension LV dysfunction will tell you when to do the intervention. Echo and Doppler tells you whether intervention is necessary or not. So that's why in all heart disease patient, these two things will be always seen in echo report. What is pulmonary hypertension? What is my LV function? That will decide the timing of the intervention. And of course, the pericardium, whether pericardial fluid is there, and always look at the rhythm. Because for the same amount of severity of a lesion, tachycardia will exaggerate the lesion. Bradycardia will underestimate the lesion. For example, same, your mitral valve size is 1.3. If the patient is a tachycardia, if you assess, it will look like as if he has got 1 centimeter. In a bradycardia, you will assess it is as if you have 1.5 centimeter. That's why when you are doing, a patient will come with a fever, his heart rate is 120, you are doing echo, you must always write, kindly repeat the echo after the control of heart rate. Once again, when you repeat the echo, do it free of cost. You have to ask the patient, no, today echo, so the second echo is going to come, so next money is there ready, right? So you always write, when you are doing at a tachycardia or bradycardia, always write, assess the echo after the control of this, because this is going to interfere with my assessment of heart lesion. So I have to do when the normal heart rate is there. Right. So this is the things we will see. We'll see one by one. Please look at this. I wanted to look at the normal dimension of the heart. The normal dimension of your left ventricle is around 5 centimeter. Normal diastolic dimension. It's not systolic. Diastolic dimension is around 5.3. So it is around 5.3. Anything above 6 is going to be a dilated ventricle. Anything above 6, for example, you see end diastolic dimension, anything above 6 is going to be a dilated heart. You must know why there is a dilated heart, whether it's a valvular lesion or coronary disease, cardiomyopathy and so on. So remember this 5 and 6. And don't bother about all these volumes. The next number you have to decide is the most important number called ejection fraction. But that matter, if at all we see inside the echo report, the only number we see is ejection fraction. Many times with the last line, echo is essentially normal, echo is there, cardiologist. But if at all something, person who is little more studious, open the echo report and see what is the ejection fraction. So ejection fraction is a very important number indicating you the systolic function of the left ventricle. How the systolic function of the left ventricle is by the ejection fraction. The minimal ejection fraction is around 56%. Anything above 56% is normal. So below 56%, if it is between 45 and 56, it is called mild LV systolic dysfunction. 30 to 45 is moderate, and less than 30 is a severe systolic dysfunction. So kindly see, when the patient has got a LV dysfunction, they have given the echo report, the last report, go to EF and see. That will tell you the prognosis of the patient. Although they have given systolic dysfunction in the echo report, you'll think this is systolic dysfunction. For example, it's got only 45 or 46. It's got a mild LV dysfunction. You yourself can manage, provided that particular cause of echo LV dysfunction is addressed. Severe LV dysfunction, 30%. It is not your area. Send the patient to appropriate specialist and let them manage. So this is important. This is the number you have to see, whether I can keep the patient or I have to send the patient. For example, this is the most important number. Many times you would have to look for otherwise. I have not mentioned about one important area there in my indication to do echo. Two areas are becoming more and more important these days. One is a preoperative, another is pregnancy. Now all obstetricians want echo for antenatal mothers. So every antenatal mother is going for echo now. So these are the two indications recently, because all anesthetists want echo now. Because they don't want to examine clinically and find out, then echo pantuva. So these are the two emerging indications. All pregnant patients, all patients who are going for surgery. So for example, if the patient is going for surgery and they have some sort of LV dysfunction, you must hesitate and send it to a specialist. And if ejection fraction is normal, you can clear the patient by yourself for your preoperative evaluation. Right. So this is how it is called eyeballing. It is not as if you have to need a measurement of the numbers to say this heart is contracting well. And we can switch off this slide. Switch off this slide so that they can see nicely here. So you can see that, you can see beautifully how heart is beautifully contracting. You see the thickening of the wall and you see the thickness of the wall. Whereas look at here, the whole heart becomes, the normal heart is elliptical. Normal LV is elliptical. When it becomes globally dilated, so there's nothing necessary for, you need not be a specialist to say that will have a EF of 35% and this will have a EF of, can you understand the difference? See the wall are very thin. There is no contraction. When you look at the contraction is so significantly reduced. See the wall thickness here. See the size of the ventricle, So in this way we can calculate the ejection fraction just by eyeballing. Just looking the image itself, Sometimes if you don't want to do the echo, for example, you have an echo machine, just try to get one view, and that one view you have nicely contracting heart like this, there is no significant problem. The patient is coming with a dyspnea. So just put it here and see the normally contracting heart. Most often heart may not be the cause of your dyspnea. Whereas the echo is like that, definitely the cause of dyspnea is your heart. Right? So that's what, once again, you can own your echo machine, try to have some views you can get and you can decide yourself for many of the things. And the diastolic function is very, very important today. So don't only look at the systolic function, but also look at the diastolic function of the heart. The diastolic function is very, very important these days. And diastolic function is obtained by what is known as mitral flow Doppler. So don't go into all details. They will give a grade of diastolic dysfunction, grade 1 to 4. Whenever the patient has got a grade 3 and 4, the prognosis is poor. The grade 3 and 4 diastolic dysfunction tells you there is enormous increase in your LA pressure. At any point in time, you can go for pulmonary edema. Right? So grade 3 and 4, very, very dangerous. Most of the reports will have a grade 1 diastolic dysfunction. Today, we say that the absence of two things is going to be abnormal in future. In echo report, absence of two things is going to be abnormal in future. One is mitral valve prolapse, another is diastolic dysfunction. Because every report has got this. Mitral valve prolapse, diastolic dysfunction. Mitral valve prolapse, diastolic dysfunction. Right? Absence of this is going to be abnormal in future. So that's why the importance is given for grade 1 is most often age related. I told you, grade 1 is also can be dangerous in one situation. So, but look at grade 3 and 4. Because as I told you, whenever we have a grade 3 or 4 diastolic dysfunction, look at the LA pressure here. The LA pressure is normal here. Whenever you have a significant grade 3 or 4, look at the LA pressure, compare the height of the LA pressure here and compare the height of LA pressure here when you have grade 3 and 4. In this patient can have normal EF. Please remember, this patient can have a normal EF. But it's a grade 4 or 3 LV function tells you what? He's got an enormous increase in LA pressure. This is what called heart failure with a preserved ejection fraction. So today patient can go for a pulmonary edema in the presence of a normal ejection fraction because of a stiff ventricle. My LA has to generate a large amount of pressure to empty into left atrium ventricle which is not dilating at all. So its pressure increases, which is backwardly transmitted to have a pulmonary edema. So grade 3 and 4, dangerous. Grade 1 can be dangerous or not dangerous. Most of the time you think grade 1 is okay. It is part and parcel of echo report. Absence of grade 1 only I am going to be bothered. Because every report is going to have grade 1 diastolic dysfunction. Right. How does it change management? So when you look at a congenital lesion, for example, you are doing AST, the two things you have to see. What is the size of shunt? What is the pulmonary hypertension? They say it is a less than 2:1 shunt or less than 1.5:1 shunt. Na? For example, the blood flow from the left atrium go to the right atrium. From the right atrium, it go to the pulmonary flow. So your pulmonary flow is always higher than your systemic flow, isn't it? Because it is a left to right shunt. If your pulmonary flow is more than 1.5 times of your systemic flow, the patient has to have an intervention. 1.5 to 2. They will say the size more than 2:1 or more than 1.5. If they say less than 1.51 shunt, you need not interfere. If it is more than 1.5 or 2.1 shunt, then you have to interfere. Then what is the next thing? Once you have an interference, look at the pulmonary hypertension. You decided the intervention because more than 2:1 shunt. They have given large AST, more than 2:1 shunt. Look at the pulmonary hypertension. Pulmonary hypertension normal. Patient says, sir, I have got a +2 examination. Okay, pa, finish it and come. After 6 months, we can do it. But the patient already has a severe pulmonary hypertension with this AST. Don't give time. The patient's AST, because question of time, if the pulmonary hypertension increases and the right side pressure becomes more than the left side pressure, it will reverse and the patient will go for right to left. If the Eisenmenger, you cannot do anything after that. So any severe pulmonary hypertension, patient should go immediately. Whereas pulmonary hypertension with intervention, they can wait and appropriate time. If it is less than 1.51 shunt and no pulmonary hypertension, keep it to yourself. Because the cardiologist is also going to do that only. I will say, coming once in a year, we'll do echo. So you need not send it to cardiology at all if the echo report shows a small VST, small AST, and so on. Then you can see this is the AST report. You can see that this is a 4-chamber view. It's a large AST here. From the left atrium, the blood is going through the large AST towards the right atrium and towards the tricuspid valve. So this is the amount of blood which is going across the AST. So seeing that, it's a large AST, definitely this patient will need an intervention in the form of the balloon treatment or the device treatment. And of course, pulmonary hypertension will decide when to do the intervention. Then the stenosis. For example, if you have a severe stenosis, pulmonary stenosis, now it is only a balloon treatment. Severe pulmonary stenosis, it is balloon pulmonary valvotomy. Whereas in aortic severe stenosis, it may be lot of replacement is there. Now TAVR is there. Transcatheter aortic valve replacement is there. So when severe, send it them. Severe regurgitation also, it can be replacement also. But when the patient has got a moderate stenosis or a moderate regurgitation, the two important medical treatment is this. In a stenosis, you have to give a beta blocker. For example, mitral stenosis, aortic stenosis, you want to expand the cardiac cycle so that the chamber has got lot of time to empty. For example, mitral stenosis, if you expand your diastole, left atrium has got lot of time to empty into the stenosed valve, across the stenosed valve into the left ventricle. So prolong your cardiac cycle in a stenotic lesion. Don't give any vasodilator in stenotic lesion. Mitral stenosis, don't give any amlodipine, IRB, AC inhibitor in a stenotic lesion. Because it will increase the gradient. It will already stenotic lesion, your aortic pressure is low. What will happen when you give a vasodilator? It will further lower. So don't give vasodilator in stenosis, give a beta blocker in stenosis. Whereas in regurgitation, it's opposite. In a regurgitation, if you expand your systole in a mitral regurgitation, what will happen? You are allowing long time of systole to regurgitate. But what you have to do in a mitral regurgitation, you have to reduce the aortic pressure. If you reduce the aortic pressure, the blood will go into the aorta rather than going back into the left atrium. There you have to give the vasodilator and not a beta blocker. So the moderate stenosis and regurgitation, you manage yourself, giving a beta blocker for stenotic lesion, giving a vasodilator for a regurgitation lesion. Very, very mild lesion, it is only endocarditis prophylaxis. Don't forget about that. Although you are not doing anything, you have to advise regarding endocarditis. Cyanotic conditions, always refer. Any cyanotic heart conditions, always refer. But the patient has got an Eisenmenger syndrome. Then nobody is going to do anything. So Eisenmenger syndrome, one thing is you have to avoid these drugs. Calcium channel blockers, sildenafil, calcium channel blockers, and the calcium channel blockers should be carefully given. Sildenafil can be given. Diuretics if it's heart failure. So mitral stenosis, if it is severe, balloon mitral valvotomy or a mitral valve replacement. Mitral regurgitation, it is once again valve replacement. But what is happening? Moderate stenosis, I give a beta blocker. Moderate regurgitation, I give AC inhibitor ARB. Mild stenosis, mild mitral regurgitation, I get endocarditis prophylaxis. So severe I refer, moderate I treat medically. I know what things I have to give for stenotic lesion and a regurgitation lesion. So these are all things you must see in echo report. Not mild mitral stenosis, refer to cardiologist. Moderate mitral stenosis, refer to cardiologist. Not necessary. My cardiologist is going to do the same thing. After spending 1,000 rupees, the patient is going to take the same drugs. You can very well follow. Do every day, every year echo. Or if the patient is symptomatic, do an echo at that point in time. And the mitral valve, for example, not every year. For example, 6 months he says, I have more dyspnea. Do an echo at the time, see what is happening to the valve, and then refer. Mitral valve prolapse, as I told you, if the patient, all your echo reports has got mitral valve prolapse, because mitral valve prolapse is overdiagnosed. There is a specific echo criteria to diagnose mitral valve prolapse. Nobody is applying that. Everything, it is a gratitude of the echocardiographer to the referring physician. Because referring physician has a double echo, but if there's a normal echo report, the patient will ask, normal echo report, but if it's in mitral valve report, say there's a mitral valve prolapse is there, that's why I send it for echo. So this is a referring echocardiographer's gratitude towards the referring physician's mitral valve prolapse. So only when you have a click, murmur, patient has got a palpitation, all these things you must give drug. Otherwise, any mitral valve prolapse, don't say the patient has got a valvular disease. From that time, the symptoms will start. As it is, mitral valve prolapse will not start symptoms. But people will say, you have a valve problem. So patient will have mild mitral valve prolapse, no mitral regurgitation. It is a normal finding. So none of these things are present, don't do anything then. So similarly, I told the same thing for aortic stenosis and regurgitation. Severe is replacement and stenotic lesion, beta blocker, and this thing. Hypertension is the most important thing. For heavy hypertension, you must do an echo, and the echo you must do for LVH. If the LVH is present, the best antihypertensive is angiotensin receptor inhibitors or the angiotensin converting enzyme inhibitors or ARBs. Must be there when there is an LVH, because those are the drugs which are going to trigger LVH. If the patient has got a LV dysfunction, the hypertension, AC inhibitor and carvedilol and aldosterone inhibitors. If the patient has got a diastolic dysfunction, as I told you, grade 3 and 4, then you have to regress LVH and control blood pressure and avoid tachycardia. So this is when you get the hypertension. Which drug to be selected for that patient? The echo gives you an idea. It is not routine. For example, everybody I give atenolol. LVH is not going to be regressed by atenolol. LVH is not going to be regressed by metoprolol. LVH is going to regress by your this thing, right? That's why the echo is necessary. So, patient with the diabetes mellitus, the echo is very, very important. Even patients with no symptoms may have a diastolic dysfunction. The diastolic dysfunction in echo in the diabetics is primarily due to uncontrolled sugar. Uncontrolled sugar will produce abnormal relaxation. Why there is a diastolic dysfunction? The ventricle is not relaxing. Why it is not relaxing? High sugars produces fibrosis of the heart, and it produces stiffness of the heart, so the heart is not relaxing. The LA has to generate more pressure. So any diastolic function, you have to be very careful. And tissue Doppler, will come to the tissue Doppler a little later. The tissue Doppler will tell you which diabetes is going to develop future heart failure. At the time of diagnosis, the echo will tell you which patient is going to develop future heart failure. So in diabetics, we are always worried about the vessel, coronary heart disease, but we don't look at the muscle. So please remember, you have to look at the muscle also in a diabetic. Heart failure also should be prevented. So that's what the diabetes. So there is a parameter called E bar E ratio. If the E bar E ratio in a diabetic, in a asymptomatic diabetic, if this ratio is going to be more than 15, and his chance of developing heart failure in next few years is 30.8 compared to 3.1 when the patient has got this parameter normal. So many years ahead, you can see. So once again, systolic dysfunction, AC inhibitor, carvedilol, aldosterone inhibitor, diastolic dysfunction, very good BP control, and also early predictor of heart failure is E bar E prime. When coronary heart disease is there, antiplatelets. So we told you about the systolic dysfunction and diastolic dysfunction. In diastolic dysfunction, the grade 1 is most often is there in diabetes, hypertension, coronary heart disease, and in this patient you have to control these diseases. But I told you the most dangerous diastolic dysfunction is what? Grade 3 and 4. These are the patients who will have a severe left ventricular systolic dysfunction. Many times it's better you refer the patient to your enemy. So I told you why this is important, because whenever you have a grade 4 diastolic dysfunction, look at the LA pressure here, look at the LA pressure, normal diastolic function. You can look at the increase, the important increase in LA pressure whenever you have a significant grade 3 diastolic dysfunction. So these are the patient can go for pulmonary edema any time, because huge LA pressure, sudden transmission to the pulmonary wedge, pulmonary edema. So these are the patients will require more. Now we have what is known as a tissue Doppler. Because EF tells you about the circumferential fibers, whereas tissue Doppler tells you the longitudinal fibers. Heart is full of longitudinal and circular fibers. That's why in EF we have so far assessed only the circumferential fibers. But longitudinal fibers are assessed by what is known as a tissue Doppler. It's a new mode of echocardiography. So in mitral Doppler, we assess how the blood cells are moving. Well, the blood is moving. Whereas in tissue Doppler, we see how the heart muscle is moving up and down. So you see the muscle, how it is relaxing and contracting in tissue Doppler. So with the mitral flow information and the tissue Doppler information, they derive the most important ratio of all, E bar E prime. The E bar E prime should be less than 8. If this is less than 8, you have a normal left atrial pressure. Whenever the E bar E prime is more than 15, you can look at that, E bar E prime is more than 15, this patient has got significant increase in LA pressure. This is the caveat in grade 1 diastolic dysfunction. In all grade 1 diastolic dysfunction, what you have to see? E bar E prime. In a grade 1 diastolic dysfunction, E bar E prime is less than 8. It is ordinary or age-related mild stiffening of the ventricle, no problem at all. But a grade 1 diastolic dysfunction patient has got a E bar E prime more than 15. He is the one who will develop pulmonary edema any time. A pre-operative patient, you will think grade 1 diastolic dysfunction and send the patient. But E bar E prime is more than 15 means he's got a significant increase in LA pressure. During operation, he will develop pulmonary edema. So that's why in grade 1 diastolic dysfunction, this parameter is very, very important today to decide about which is a benign grade 1 and which is a malignant grade 1. So E bar E prime of more than 15, very, very important diastolic dysfunction and so on. So coronary heart disease, we know from which wall motion, we know which artery is involved. My septum is not moving, anterior wall is not moving, it is LAD. If my inferior wall is not moving, it is RCA. If my lateral wall is not moving, LCX. Anything to do with the LAD is dangerous. So this gives me what artery is involved and what will be the prognosis of the patient depending upon the artery is involved. Then we look at the LV dysfunction. So all dysfunctions, you will give AC inhibitor, beta blockers. If I got a thrombus, I have to give an anticoagulant, and they give a score called wall motion score index. So any coronary heart disease, this wall motion score index is more than 2, this patient will have a bad prognosis. And also look at the mechanical complication of MR, VSR and so on. So this is a patient, you can see that this huge thrombus in the left ventricle. So this patient deserves an oral anticoagulant along with your treatment. So look at the echo report. If the patient has got wall motion abnormality but LV thrombus, this patient has to be started on oral anticoagulant to prevent a systemic embolism. So these are the information you have to see in your echo report. And cardiomyopathies can be 3 types: dilated, hypertrophic and restricted cardiomyopathies. So all these things you need a reference to a specialist. And hypertrophic cardiomyopathy, you have a very thick walls and you have the mitral regurgitation and also systolic anterior movement of the mitral valve, which can give you LVOT obstruction. The most important advice to the patient with hypertrophic cardiomyopathy is what? One, family screening. All these patients right. In a pericardial disease, you have to see for the tamponade, that's all. Mild to moderate pericardial effusion, most often rule out thyroid. If it's a mild pericardial effusion or mild, all patients with a mild pericardial effusion rule out thyroid. Most important cause of mild pericardial effusion or moderate pericardial is thyroid. Treat thyroid, it will be normal. But a severe myocardial infarction with a tamponade is an emergency, so definitely refer to a patient. So this is a huge pericardial effusion with a cardiac tamponade where the heart is dancing inside the fluid, and this is what the tamponade means. You can see the right atrium is collapsing here. So because of the intrapericardial pressure is there, the right atrium is collapsing. So this is an echo sign of tamponade. Although the patient clinically may not have tamponade, when there is, you see collapse, atrial collapse, it is immediately this patient needs a pericardial drainage. So you have to refer him immediately. Although clinically patient may be all right, but this report of RA collapse tells you very simple thing. My intrapericardial pressure is higher than my intracardiac pressure. When my intrapericardial pressure is higher, it will not allow the ventricle to dilate to receive my venous return. So that my intrapericardial pressure is higher than intracardiac pressure, that is an indication for tamponade. So echo in ICU is itself a big topic. So if at all you are interested to call me again, after all these lectures, we give a lecture on echocardiography in ICU. Very, very great information. So all critical care units must have an echo machine. And the person who can do an echo, not only echo machine, a person who can do the echo machine, echo, and the person who you decide what to be done for that shock. So such sort of information is there in echo and ICU. So a great sigh of relief I can see from many of you. Summary and takeaways, right? Great sigh of relief. Low threshold of doing echo, it gives you valuable information. Read the echo carefully, I told you so many things. Correlate the echo report with the clinical diagnosis. Please remember, this is a very important information. You have detected a systolic murmur and the echo report comes as normal. What will you do? You think it may be innocent murmur because you believe echo report and not your clinical diagnosis. What we do is we send the patient for echo again. So this is not a murmur. Look for AS, look for VST. This murmur has got a murmur. I will not accept the echo report. So you must have such sort of confidence in your clinical findings. When they are not going together, you will suspect the investigation and not your clinical finding. But many of our mindset is what? We think echo is a gold standard. When the echo comes and we have detected the murmur, we think our murmur detection is wrong. And the echo report it is correct. So don't ever do that. So whenever there is inconsistency between your echo findings and your clinical findings, repeat echo in a good lab. And disparity, review the clinical diagnosis, echo report. Don't ignore, don't frighten. Don't ignore a severe aortic stenosis. Don't frighten a mitral valve prolapse patient. Right? Don't ignore, don't frighten. Concentrate on LV circulation because today we know with a normal systolic EF, patient can go for pulmonary edema. With a grade 3 and 4 diastolic dysfunction, E bar E prime more than 15, although his EF is normal, he is a candidate for future heart failure or a pulmonary edema. And I told you about pulmonary hypertension, how it decides the time of intervention. Always compare with the old recovery report. Ask them to keep the old recovery report. Every year you want to do what is the gradient there, what is the size there, what is the pulmonary hypertension there, what was the EF there for the last year, what is happening today, compare the echo report. Plan and refine management according to echo report. Do serial echo report in congestion. So echo is nothing but echo, ECHO, is enormous, comprehensive, high value, objective information. That's what your echo is about. So I know you are like this after hearing this lecture. You are confused, lost, unclear, perplexed, disoriented, and until the time I must stop here. So thank you for your patient listening, although it's a very complex topic. Thank you for your patience.
It is a one-day program fixed into 1 hour program, but enormous information has been put on thanks to Professor Chenniyappan, and I am very sure the value of echocardiography in clinical medicine is very well highlighted in this program. As he told, I hope a one-day program on this will be very much useful to all the practicing physicians as well as postgraduates. 2007, I did my diploma in echocardiography under Professor Chenniyappan, and I got my diploma in echocardiography at Annamalai University. I am very much honored that I could chair the session in which my professor is talking. Thanks to Dr. Arunachalam also for giving me this opportunity.
It's a pleasure and honor, sir. Pleasure and honor. Thank you.
Thank you, sir, for your comprehensive and scintillating lecture. We request Dr. Nallamuthu sir, Senior Physician, Shankaran Koil, to honor the chairpersons, Dr. Shanmugam and Dr. Govindarajan, sir. We request Dr. Chennayappan sir to honor Dr. Subramaniam sir, Senior Physician, Kadayanallur, who has played a pivotal role in this summit. Thank you, sirs. A gentle reminder, we bring to your attention an event where knowledge meets questions and the stakes are high. Access 24 quiz, after the scientific sessions at 5 p.m., will have you compete for the top honors and exciting cash prizes worth 20,000 rupees.
Knowledge is treasure, but practice is the key to it. With great vigor, we present to you the ECHO hands-on workshop post-lunch at the adjacent hall. Interested delegates can register themselves at the comparing desk now. It will be on first-come, first-serve basis. We repeat, interested delegates can register for the ECHO hands-on workshop at the comparing desk now. It will be on first-come, first-serve basis. Registered participants will be divided into small groups and get a fascinating hands-on experience in echocardiography facilitated by expert cardiologists. Certificates for all the delegates will be provided in the end. We shall now break for lunch for 45 minutes. Lunch will be served in the ground floor. We request everyone to have their lunch and be back in the hall by 2:15 for the next scientific session. Interested delegates can register for the ECHO hands-on workshop now at the comparing desk.
We request everyone to take their seats as we begin our next session. Up next, we have a session, How to Approach Arrhythmia by Dr. M.S. Vishnudas, sir, Consultant Interventional Cardiologist and Aruna Cardiac Care, Tirunelveli. Dr. Vishnudas, sir, is a graduate of Volograd Medical University, Russian Federation. He has completed MD Biophysics from AIIMS, New Delhi, DNB General Medicine from NRCH, New Delhi, and DM Cardiology from Tirunelveli Medical College. I cordially invite Dr. Vishnudas, sir, to the stage. As we wait for our session to begin, I once again remind you about an event where knowledge meets questions and the stakes are high. That is the Access 24 quiz, which will be happening after the scientific sessions at 5 p.m. It will have you compete for the top honors and exciting cash prizes worth 20,000 rupees. So please do not forget to grab this opportunity. Thank you.
Up next, we have a session on how to approach arrhythmia. Dr. M.S. Vishnudas sir, consultant interventional cardiologist, Aruna Cardiac Care, Tirunelveli. Dr. Vishnudas sir is a graduate of Volgograd Medical University, Russian Federation. He has completed MD Biophysics from AIMS New Delhi, DNB General Medicine from NRCH New Delhi, and DM Cardiology from Tirunelveli Medical College. I cordially invite Dr. Vishnudas sir onto the stage. Over to you, sir.
Good afternoon. Good afternoon, everybody. At the outset, I thank Dr. Aruna sir and the ACC family for giving me such a wonderful opportunity. And it's an immense pleasure and a honor, and it's a great privilege to share the dais with Dr. Chennappan sir. So post-lunch session, let's dive into the topic. My topic is practical approach to cardiac arrhythmia. As we know, what is practical approach? From MBBS days, we are giving the practical examination, and practical approach starts from the patient when you see in the ER or in the OPD. So first, what we will see, you will take a history and a clinical examination. And in clinical examination, what you will see is vital signs. Vital signs are blood pressure and pulse, temperature and respiration. You see the blood pressure alone, if it is less than 90 millimeter of mercury, or if it is more than 90 millimeter of systolic blood pressure is now more than 90 millimeter of mercury. What is the inference? If it is less than 90, means hemodynamically unstable. He may develop going to the shock. And similarly, if you see the pulse, just palpate the radial artery or carotid artery, see the pulse. If it is less than 60, it's a bradycardia. If more than 100, it's a tachycardia. So just seeing the patient in the clinical examination, you come to the diagnosis. We have four combinations. One is bradycardia with hypotension, bradycardia with normotension, and tachycardia with hypotension or shock, or tachycardia with normotension. So all bradycardia needs to be treated or not? That is the question. It's absolutely no. Only symptomatic bradycardia need to be treated. What is symptomatic bradycardia? The heart rate should be low, is less than 50 or less than 60. The patient has symptoms due to bradycardia. Once bradycardia resolves, the symptoms also should improve. That is symptomatic bradycardia. These are the three criteria. So what are the symptoms? Unfortunately, we do not have a specific symptoms for bradycardia or tachycardia. This is a common symptoms. Patient may present with hypotension, sweating, pulmonary edema, chest pain, chest discomfort, shortness of breath, all can be. It's not a specific one. It is both common for brady and tachyarrhythmia, and it is non-specific symptoms. So you have a symptoms and you have a bradycardia or tachycardia. We clinically examined, we need objective evidence to say this patient has a brady or tachycardia. What is the cost-effective investigation we have that is gifted by the Eindhoven in the beginning of the 20th century? That is an ECG. It is more than 100 years. It's a very cost-effective tool to diagnose brady and tachyarrhythmia objectively. So you have evidence. Next, what will you see in the ECG? The normal conduction system of the heart. You know all these normal conduction of the system. This is starting from the sinus node and AV node, his bundle, right and left bundles. The most important thing is, by seeing the ECG, you never think that you always tend to say, look at the P wave, look at the QRS complex. It is not a way to look the only P or QRS or PR interval. Actually, what is happening is the P wave means synchronized contraction of the atrium. Synchronized contraction of the atrium. What does it mean by synchronized contraction of the atrium? We have two atrias, right? One is left and right. So two atria should contract synchronously, synchronized contraction in the millisecond delay. What is acceptable millisecond delay is 120 millisecond. So normal cardiac cycle is 800 millisecond. What is millisecond means? This is a second. If you make it 100 parts of the second, that is the 1 millisecond. So 120 millisecond is a acceptable limit for atrial contraction. This is a synchronized atrial contraction. Next, ventricular contraction. We have a two ventricle. Similarly, it should contract synchronously without significant delay, that is acceptable delay, that is 120 milliseconds. So normal QRS duration is 120 millisecond and P wave is 120 millisecond. In between we have a PR interval. PR interval will say the sequential contraction of the atria and ventricle. What is the sequential contraction? First my atria should contract, then only ventricle should contract, right? So that is the sequential contraction, A followed by the V. What is the acceptable delay for A to V? That is 200 millisecond. That 200 millisecond it is not just one interval of 200 millisecond, it is the part of three intervals. It is from the P, that is sinus to atrium, that is the PA interval, and AH interval and HV interval. PA interval is 20 to 40 millisecond, and AH interval is 35 to 150 milliseconds or 125 milliseconds, and 35 to 55 millisecond is a HV interval. So acceptable limit is 200 milliseconds. If it is all this mechanical contraction of the heart, we are seeing electrically on the ECG. This understanding you should have to analyze the arrhythmia, even bradycardic arrhythmia. Okay. Next point I would like to say, the ECG paper, when you see the ECG paper, always look at the standardization. Okay? Standardization 25 millimeter per second it should move. The paper speed, meaning the paper will move per second is 25 mm. Our ECG paper is 10 second ECG if it moves 25 millimeter per second. Okay? Meaning it's a 25 centimeter paper. In it simple already paper adu avladha 10 millisecond we have the 10 millisecond how many cycles it is happening will be shown in the ECG. So okay, so normal ECG is a 10 second, if it is paper speed is 25 millimeter per second. Okay, got the point. Next, how to calculate the heart rate is in bradycardia it is very difficult to calculate the heart rate, because in between RR interval you have to see whether it is a small or large millimeters, like 5 millimeter. It make a large square, and one small millimeter is 1 mm square. It's a very difficult to calculate. Simply you count the QRS, how many QRS is in there, in multiply into 6, it's a 60 second, it's a 1 minute heart rate, you will get it. So we have a situation like this. The patient absolutely have a normal ECG, but he is asymptomatic. How will you, that is also even you can record the ECG up to 2 to 3 months. Okay. Now what is the cause of bradycardia? What are the causes? There is largely divided into intrinsic and extrinsic causes. Intrinsic are cardiomyopathy, congenital heart disease, degenerative fibrosis, infection and inflammation, infiltrative disease. Most important is ischemia and infarction. You can miss all those things, but you cannot miss infarction and ischemia and acute coronary syndrome in bradycardia. Why? Because time is the muscle, you should intervene immediately. And other extrinsic causes, autonomic perturbation, cardiac sinus, carotid sinus sensitivity, and neurally mediated syncope and situational syncope, all this can cause the bradycardia, and metabolic causes also. When you will correct the metabolic abnormality, the bradycardia. Okay. And the next important group is drug-induced bradycardia. This is the most common in our clinical practice. Bradycardia will come to you. These are the common drugs like A, B, C, D. You remember A is adenosine, and B is a beta blocker, and C is a calcium channel blocker, D is the digoxin. Among these, antihypertensive beta blocker is the most common culprit. Commonly, atenolol is the culprit. So you always look the prescription, what patient was taking the drug, then you intervene whether this bradycardia, we need to be intervened. Just stopping the drug, patient will improve. So major, if you, once you have seen the causes and you have taken an ECG, at the next, what will you expect in the ECG? You will try to find out the level of the block, whether it is sinus nodal block or AV node is affected or MI bundle branches are affected. So it's a sinus node block. There is any degenerative block. It is not a single disease, a spectrum of disease. Start from the mild, moderate to severe. Here it will start from grade 1, grade 2, grade 3. Okay. Grade 1 cannot be diagnosed on the surface ECG. That is an EP diagnosis. You leave it. And grade 2 is like our AV Venkibach. It's a sinus node Venkibach where you have to measure the PP interval. When the longest PP interval is less than the preceding PP interval, twice the preceding PP interval. Similarly, if you have the longest PP interval, exactly twice the preceding PP interval means it's a type 2 block. Okay? Type 2 block. And grade 3 is sinus node is not firing. It is a long pause, sinus pause. Here, in grade 3, patient require permanent pacemaker. If you see this ECG, immediately send to the cardiologist to get the permanent pacemaker after temporary pacing. So this is the same thing. It's a picture, ECG picture. I want to show this. So here you can see the pointer. Yeah, this is the P wave followed by the QRS, P wave followed by the QRS. This is a sequential contraction is maintained, and after that sinus node is not firing. There is a long pause, long sinus pause. This patient require permanent pacing after temporary pacing. Similarly, AV block, there's a 3 degree of AV block, prolonged PR interval alone, and progressive prolongation, and constant prolongation followed by the drop in the QRS complex, and the AV dissociation is a complete heart block. This is the ECG. In first degree AV block, there is just prolongation of the PR interval. I already told what is the acceptable PR interval is a 200 millisecond. If it is more than 200 millisecond, it's a first degree AV block. The A and B sequence is maintained. The point is okay. So second degree AV block, Mobitz type 1. This is the Venkibach type of block. There is no drop in the QRS complex, just prolongation of the PR interval. Okay. Second, there is no prolongation of the PR interval, and suddenly the QRS drops. That's a Mobitz type 2 block. And third degree AV block, there is no association between A and V. The atrium and V is contracting separately. There is no sequential contraction is not maintained. But here, if you will measure between the PP interval, between the RR interval, that will be the same. Okay? But only AV sequence is not maintained. It is a third degree AV block. Okay? So management option is very simple. First, you have to rule out acute coronary syndrome in any situation. Okay, if any ECG, not only brady tachyarrhythmia, any ECG if you will get, always rule out acute coronary syndrome. Whether there is very simple, whether there is ST elevation is there or not at any lead. If there is ST elevation, you suspect acute coronary syndrome. Why it is so important? Because management option is totally different from other causes of brady or tachyarrhythmia. Okay? So, and correctable causes, as I earlier told, metabolic causes should be corrected, and hypothyroidism you will correct, and if you drug withdrawal like beta blocker, if you withdraw, the bradycardia will improve. And chemical pacing, atropine, isoprolene, and aminophylline, noradrenaline can be used. Percutaneous pacing, we are not doing it. And temporary pacemaker implantation and permanent pacemaker implantation. These are the management options. So acute medical management, I will see, these are the drugs we commonly use in the ICU and ER, atropine, dopamine, isoprolene, and epinephrine. Now atropine, the maximum dose is 3 milligram, that is 5 ampoules. Beyond that, if you will give, there is a total parasympathetic blockage is achieved. How much, if you will give 6 ampoules, 7 ampoules, it doesn't going to work. You limit yourself up to 3 milligram. Beyond that, there is no point of giving atropine. Similarly, isoprolene, you can go up to 60 microgram, and dopamine 20, and epinephrine. And some special situation where you will use a beta blocker and calcium channel overdose, that's a glucagon, which will bypass the beta receptor and directly stimulate the heart. That is in the drug overdosage situation where bradycardia can be managed. This is one of our patients. See, here the patient is complaint of recurrence syncope. He is having the symptoms first. Second, there is a bradycardia. How you count the QRS complex? How much QRS complex? 1, 2, 3, 4, 5, 6, 7, 8. 8 multiplied by 6 because it's a 10-second ECG. If multiply into 6, so it will be 1 minute. How many times my ventricle contracts that you will get? That is 48. So here is a bradycardia. And you see there is a sequential contraction is maintained or not. If you see the here there is no P wave, only the QRS complex is here, and followed by the T wave. Here is the P wave, and here is sinus, this is junctional. So one junctional beat, and the sinus node is sleeping, and subsidiary pacemakers like a junction and ventricle taking over, giving the QRS complex. So it is like junctional beat, sinus beat, and again sinus beat and junctional beat. In between there is a pause. So this patient underwent permanent pacing. So this is another patient. That patient had a sinus node disease. This patient had a AV node disease. AV node disease, it's clear cut. If you see, only 4 QRS complex I am seeing. So 4 into 6 is a 24, his ventricle is contracting. And if you see the atrium, there is a P wave is more than here 1 P wave, 2 P wave, 3 P wave. So P wave is more, and there is QRS is less, there is AV dissociation. This is a complete heart block. This patient also required permanent pacing. So the adult bradycardia management, it's a 2020 AHA guideline. Whatever we discussed, they have given in the pictorial representation in the single slide. This all whatever we discussed, it's given in the single slide. Okay. Next, we'll go to the tachyarrhythmia. Tachyarrhythmia is much more simpler than the bradyarrhythmia. Believe me, very simple approach. Whether patient is stable or unstable, that is you decided in the ER itself. Emergency room itself you decided whether patient is stable or unstable, seeing just blood pressure. Okay? And assess the QRS complex whether it is narrow or wide. Narrow means acceptable delay in the synchronized contraction is 120 milliseconds. If it is within 120 milliseconds, a narrow complex. And wide means more than 120 milliseconds. Whether it's a regular or irregular. Regular means between the RR interval are same in each cycle, and irregular means between the RR interval is not same. It's a different. Then another one more morphological classification also there. Whether the all QRS complex is similar, you will say monomorphic ventricular tachycardia. If it is not similar, it is different from one morphology to another morphology. It's a polymorphic ventricular tachycardia. That's a morphological difference. Then, okay. If hemodynamically unstable, you find hemodynamically patient is unstable, you diagnose some tachyarrhythmia. What is the treatment? Very simple. DCCV, that is a DC cardioversion. Here, the DC cardioversion, that is one is automated cardioversion, which we do not have, the mechanical one which we have. The mechanical one, when you in front of the patient, when you take the defibrillator, you have certain things in your mind. First, how much joules I have to select, whether it is 25 or 250 or 200. So there is it is a rough criteria. If narrow complex means you select 50 to 100. If it is wide complex means you go higher joules. And in case of ACS, if patient is having acute MI or inferior wall MI throwing VT or VF, even highly sensitized myocardium, you give only 25 joules, it will get reverted to the sinus rhythm. So sensitized myocardium, you give with low joules. And the another important thing is, I would like to highlight here one point. What is synchronized cardioversion? What is defibrillation? Synchronized cardioversion means when patient throwing in VT, I am giving the direct cardioversion exactly on the top of T wave, exactly on the top of R wave. If you give the R wave, that is synchronized cardioversion. If you have that yellow button on that machine, you have to press it. It will show the yellow arrows on the top of the QRS complex where exactly the current shock will be delivered. If ventricular tachycardia is going on, if you are not synchronized, it will not deliver the shock in machine. But still, if you deliver, what will happen? Because on top of the T wave, if you will deliver, it is R on T phenomena, VT will be converted into ventricular fibrillation. Because initial part of the T wave is refractory, absolutely refractory. But later half of that T wave is not refractory. If you fall, the shock will fall on the later part of the T wave, it will degenerate into VF, ventricular fibrillation. So that must be careful. So next is, what are the shockable rhythm? Whether all rhythms can be shockable? No. So these are the arrest rhythm, these are the shockable rhythms. This is a monomorphic ventricular tachycardia. See, patient is hemodynamically unstable and I have a tachycardia. It is a wide complex tachycardia and all morphology is almost same. It's a monomorphic VT or SMVT, sustained monomorphic VT. You give a shock. And polymorphic VT, you have a QRS complex, different morphology, but it appears to be regular. Polymorphic VT, you can shock. And coarse ventricular fibrillation, I cannot make any QRS complex here. There is a mess. But still, it's a coarse ventricular fibrillation you can give. And here, it is almost looking like an isoline, isoelectric line. Still, you can, some undulation like sine wave pattern, you can see, you can able to appreciate. You may try the DC shock. But what are the rhythms? What are the arrhythmias you should not shock? This is a pulseless electrical activity and asystole. Asystole, no point of giving DC shock. And pulseless electrical activity. What is pulseless electrical activity? As alluded by Dr. Chennappan sir, the ECG is electrical and echo is mechanical. This pulseless electrical activity has another name, that is electromechanical dissociation. That is electrical activity. We are seeing some electrical activity on the ECG, but mechanically your heart is not pumping, your ventricle is not contracting. In that time, if you are giving the shock, it is no use of giving shock. So what should be done in this situation? That is CPR. So you continue to the CPR and you try to get any kind of the rhythm, then you shock it. Okay. Now, the another situation, hemodynamically stable, and in ER, his blood pressure is more than 90. Sinus tachycardia, nothing. Give one beta blocker, it will settle down. Our patient is febrile, you give a paracetamol, it will settle down. Okay? And supraventricular tachycardia, here I want to stress some points. In supraventricular tachycardia means any tachycardia occurring above the His bundle is at supraventricular tachycardia. That's a type of supraventricular tachycardia, atrial tachycardias, AVNRT or AVRT. AVNRT means AV nodal reentrant tachycardia, and AVRT is atrioventricular reciprocating tachycardia. And Junctional tachycardia, PJRT also there. These all are supraventricular tachycardia. If patient is hemodynamically stable, you no need to shock the patient. You can manage chemical cardioversion. You can give the drugs. This can be. What is the drug we commonly use for AVRT, AVNRT, supraventricular tachycardia? Adenosine. Yes. Adenosine will act on the sinus node and the AV node. Right. Next, atrial flutter. This atrial flutter is a 3:1 block. 3 flutter wave and QRS is my regular. It's a 3:1 atrial flutter. So this is also supraventricular tachycardia. It's narrow complex. Then wide complex, but hemodynamically stable. The patient with wide complex tachycardia, monomorphic VT and polymorphic VT, which I shown earlier, the same. But patient is walking to you with ER and his blood pressure is 100. And will you shock this patient? No, not required. Only the drug is sufficient to manage. So what are the drugs? So regular narrow complex tachycardia, you will give the, first you try with the vagal maneuvers. Vagal maneuver means carotid sinus massage. And even you can pour the, ice chilled water of patient face, which we are not doing, but, so that is adenosine 6 milligram IV bolus. It should be given in the bolus, means it's a rapid bolus, and it should, the vein should be not from the periphery. At least you should catch the brachial vein, then you push the adenosine and you raise the limb, and followed by 10 ml or 20 ml so saline should be pushed. So as early, what is the concept? As early drug should reach the AV node or sinus node. That's an idea. Next, regular wide complex tachycardia. With a probable VT, you can manage with amiodarone, 150 milligram or 300 milligram bolus, followed by 1 milligram per minute over 6 hours and 0.5 milligram per minute over 16 hours. That can be managed. Okay. And irregular wide complex tachycardia, consider antiarrhythmic drugs. If it is all, patient is hemodynamically stable. If hemodynamically stable, so don't shock it, you try with all this chemical cardioversion. I will show some signature pattern ECG. The cardiology and ECG are only the pattern recognition. If repeatedly you see this kind of ECG, just you are seeing, you will make a diagnosis. That's all. It's just a pattern recognition, nothing else. Okay? So here, you see, this is a wide complex, and it is look like a supraventricular tachycardia, and it is irregular. So it's the code is fast, broad, and irregular, FPI. This is, what is the diagnosis, anybody? This is the only supraventricular tachycardia will have an irregular rhythm with broad complex, and it is fast. That is pre-excited atrial fibrillation. Meaning, you have atria is fibrillating, and we have a bypass tract between the atria and ventricle, and all the atria which were the contraction is centered to the ventricle, and ventricle also try to meet it, but because it is irregular and its heart rate, you see, it is almost it's nearing 300. So what is the treatment? Cardiogenic shock. Patient is unstable and broad, irregular wide complex tachycardia. What will you do? DC shock. Yes. Next. This is one early morning I have entered the government hospital. They shown to me this ECG. The patient is in cardiogenic shock, and you can see there is a QRS like morphology or QRS morphology. It's a very fast rate. And if you carefully observe here, see, this beat is a sinus beat. Okay. This beat is a sinus beat. So, in the chaos, you are getting one normal sinus beat. It is called capture beat. Means the ventricle is running its in bone V, or we can call it as a running PVC is a VT. VT is nothing but running premature ventricular contraction. In that running PVC, I found one normal QRS complex, meaning somehow the sinus node able to capture my ventricle. That is the capture beat. Okay, this is the VT. So patient is in cardiogenic shock. What I will do? DC shock, yes. Next, this is another ECG. Here also you can see the broad wide complex tachycardia, which appears to be regular. You see the long strip, you see this complex. It is not a sinus, it is not a tachycardia pattern, it is somehow it is mixed. Okay, it is a fusion beat. It's a sinus beat and tachycardia beat is fused. If I will be able to recognize this is 100% VT, I will give a DC shock. Okay. Next, another scenario, cardiogenic shock and acute coronary syndrome. What will you see here? ST elevation. Where you find the ST elevation? In AVL, you have a ST elevation, and V1, V2, V2, V3, you have a ST elevation. This is an anterior wall MI. This is the PVC beat. Okay. If in one look, it's look like, some tachycardia is going on. It is actually acute coronary syndrome. What is the treatment? Thrombolysis. Very good. Yes. It's a thrombolysis or primary PCI. If you are patient and you can access the PCI capable center within the time period, you can send for the primary PCI. With this I conclude, and this is my last slide. And always rule out acute coronary syndrome during brady and tachyarrhythmia and treat ACS, and because time is the muscle. Okay? Thank you very much for patient listening.
Thank you. Thank you, sir, for your remarkable talk. Now I request Dr. Kamala Asaran, sir, Senior Practitioner, Surandai, to honor Dr. Vishnu Das, sir.
Thank you, sir. Next, we have an astounding session by Dr. E. Arunachalam, sir, Senior Consultant and Interventional Cardiologist, Founder and Chairman, Aruna Cardiac Care, Tirunelveli, on newer technologies transforming cardiac care. Dr. E. Arunachalam, sir, is a proud alumnus of Tirunelveli Medical College. He had completed his MD in General Medicine and DM in Cardiology from Government Stanley Medical College. He has done more than 8,000 independent procedures and is well versed in performing and interpreting advanced invasive procedures like OCT, IABP implantation, etc. Apart from his clinical activities, he also shows ardent interest in journal activities, quizzing, clinical research, and swimming. Over to you, sir. This session is moderated by Dr. Rajesh Babu, sir, Senior Consultant Physician, Sankarankoil, and Dr. Nallamuthu sir, Senior Physician, Sankarankoil. We welcome the chairpersons onto the stage.
Good afternoon, everybody. It's a little difficult task post-lunch session. And one thing, you cannot have all the time sweet. You have to change the taste to sour or spice. Morning had a very sweet lectures by legendary speaker. Now you are forced to hear this from myself. So I'll be little touching about the latest technology that is transforming our cardiac care. See, you will be forced to know this whether you like it or not, because in future, this optical coherence tomography, which has revolutionized the ophthalmic care, like anything for more than 2 decades, has entered into cardiology for 1 decade. And it's nothing but an infrared light. A catheter will be passed over the wire into a coronary artery. And this is our lab. And this is what you see, that inside the coronary artery, a catheter will be passed through a radial approach or femoral approach, and a catheter is like a tube. So the tube is a hollow. It will sit in the ostium of the coronary artery, say left coronary ostium. then that is the guiding catheter. It will be attached to a three-way outside, and then through that catheter one wire will be passed. That is called coronary wire. So angioplasty wire which will pass through the catheter into the coronary artery. Over the coronary wire, a small OCT catheter, soft monorail catheter will be passed. The 87 millimeter of the catheter will have a lens marker at the end from the tip 30. So what it will happen is, you pass that beyond the region of interest of the coronary. Say you want to take a proximal LAD picture. You keep it in the distal LAD, then you connect to a console outside, you inject the contrast, and immediately they will on the technician will simultaneously switch on that console. So what it will happen is, the infrared light will travel from the tip of the lens marker to 87 millimeter. You can see that. So it will capture the whole 360 degree of the coronary artery for 87 millimeter. So it will give like this. See, this is the cut section of the coronary artery, and by this artificial intelligence you can see whether the calcium is there. That is that arc you are seeing from 12 o'clock to 6 o'clock now, that orange color. It will detect the calcium automatically, this artificial intelligence machine, and you can know if the arc is more than 180 degree, you have to prepare the coronary artery and put a stent. Otherwise the metal will not expand and the patient will come back after a few months with restenosis. So this is all the things. You connect syringe, put the catheter inside, position the catheter, give a puff of, what do you call that, dye, and take a pull back, and you can see like this. What you can see down now, see this is the luminogram of the coronary artery. You can see that here the narrowing is there, everything, but this will also show that the length, and you can, using that, choose. For example, say you want to choose from here to here. So you can calculate in that console whether 33 millimeter stent, what is the diameter you want to take. Because so far, for past 7 years back, the cardiologists were doing only eyeballing. So only the oculostenotic reflex, they were doing that. So some cardiologists say it is 2.5 millimeter diameter, somebody will say 3, somebody 2.75. But now it is objective. This will tell this is the size of the coronary artery. Distal, this is the size, 2.75 millimeter diameter. Proximally, it is 3.5 millimeter. So you choose accordingly. Only one diameter you can choose. You have to choose according to the distal, say 2.75 into 38, and work with the balloon proximally and expand it. So this is what you can see, that this is right coronary artery and that is left coronary artery, LAD. And you can see like this, it will immediately bring down. This is the proximal, this is the distal, this is the point. Say if you take like this 3 areas, distal, mid, proximal. So automatically it will give how much diameter you have to choose and what is the length you can deduct from here, the length. So, and the morphology also you can find whether it is a lipid plaque, fibrous plaque or calcium. See how it is you don't go through all through these things which will confuse. I will just tell very simple. If you have signal rich region, and this is called brighter, signal rich region and clearly demarcated, it is fibrous. If it is the signal is not there, signal poor, then it is lipid. Here it is signal poor, but it is well delineated. So here it is not delineated. That is why there is high attenuation. The light cannot penetrate. Here, see, you are able to see up to here. Total, this is intima, media, and adventitia. So signal rich, like this, yellowish and well demarcated fibrous. Signal poor, well demarcated calcium. This is lipid. Why this is very important is you should not aggressively predilate with balloon lipid. It will cause atheroemboli, slow flow, and all the complications. Fibrous, you have to crack with non-compliant balloon. For calcium, you have to crack with cutting balloon. And what about red and white thrombus? Sir was talking in the morning, red thrombus is you must acute ST elevation, MI thrombolyze, and white thrombus, give antiplatelets. Red thrombus, you cannot see back. So that is a high attenuation. White thrombus, see this is white thrombus, you are seeing the artery here, beyond that. So this is very simple. If you are able to see the thrombus and you can see fully the artery, it is white thrombus. Why again it is important here is, you should be very careful of pre-dilating the thing. And again, you can quantify the calcium. If superficial calcium, we can do with simple balloon. If it is a concentric calcium, see, 360-degree calcium, you have to break with special apparatus like roto-ablator, drilling, or orbital atherectomy. And if the eccentric calcium like this, you should be very, very careful, nodular calcium. If you put a stent and dilate, this calcium will push opposite side and suddenly perforation will occur, patient will collapse on table. So if you see all these things, you should be very careful in dilating that region, and before that you have to prepare the artery. So this I will give a case, a 60-year-old acute coronary syndrome, a patient with mild LV systolic dysfunction. You can see this is the catheter, this is left main, this is LAD, and what you are seeing is the LCX. See this zone. You can see the thin part of it. So that is ostial LCX is, you can see this zone, this is ostial, you can see there also. So this is the place where you can see this zone. So that is called osteoproximal 90% lesion. See, everybody will have issue here because the problem is, see, the diameter of this artery is bigger, left main. Diameter of the LCX is not that bigger. How you will choose a stent? The biggest problem is LAD is perfectly normal. You cannot subject the patient to bypass surgery also, because unless LAD is not involved, the role for bypass is limited, because LAD, proximal LAD involvement is one of the criteria for CABG. So LAD is normal, only ostial LCX. Patient, if chooses, can go for bypass, but doesn't differentiate between angioplasty and bypass in mortality. So OCT run is taken and we assessed, see the lumen difference is here 5.6, there 4.2. So you can choose accordingly. In the center, you see that tight calcium lesion is there. See, the calcium is, you can see the cracked calcium, and this is fibrous, and see there almost 270-degree calcium. From 11 o'clock to 7 o'clock, the orange is there. So the artificial intelligence detected it was almost 2/3 calcium. So if you just put a stent with ordinary balloon dilatation, the stent will not expand and get into trouble. And once you put a stent, artery is an elastic one, right? So if you put a metal, the metal will make the elastic and metal will become metal. If you again put a balloon and try to do with something with metal, the metal will not help and you'll end up with complications. So if you see more than 2/3, this is a cutting balloon. This balloon will have these blades on its circumference. So the blades will, when you inflate, the blades will cut the calcium and will make the artery to expand, and that will result. This is another one where instead of blade, there will be a nitinol wire all the way. So when you inflate the balloon, the nitinol wire will crack the calcium, and then after that, when you put a stent, the artery will expand. So this is also same score flex balloon and all. So with that, the patient was, after preparing with the scoring balloon, the stent of 3.5 into 12 millimeter were deployed. You see that the beauty is, the stent is 3.5 and the LCX is 4 size. So I have taken 4 and 4.5 to prepare LCX, and I have taken 5 because LM is almost 5.3. So I have taken, what is this pot balloon is, this will be square-like balloon. This is conventional balloon. So it will exactly fit into the left main artery, and you will, so what you are making, you are designing a tapering stent with 5 millimeter stent in the left main with 4 4.2 millimeter into the LCX. So this is called pot. See what is pot is, the left main is 5 millimeter, this is 4 millimeter. You are taking a 3.5 millimeter stent. Here you are making into 4, then you have to make here, you can see that. So this is what the thing is designed. When that is done, so this metal will give way to the flow into the LCX, which you can assess by the OCT, optical coherence tomography. This pot balloon, this done pot. Then again, this run is taken. You see the beauty. It was expanded in left main to 5.2. Because when you take the run, no, it will be only 4.6 expanded, and you can see a gap. The stent will be floating. You cannot see with eye by injecting the dye, because it will show only the artery's outer lumen, dye. So you cannot know whether the stent is well opposed to the artery or not. So the recommendation is, if you are doing left main angioplasty, you must use OCT or IVUS imaging. So this is the final one. You can see that. See the corner. This is what you are seeing. It was hanging. Now it is well expanded. So another is orbital atherectomy, which I will tell this 83-year-old male patient, diabetic. This is severe calcium he had. If this taken OCT, this will not help with cutting balloon. So this is the OCT run taken. You can see that, see, almost only this area, it is almost more than 280 degree and thick calcium. You can see that. Same representation, see, fully calcium. You can see the islands of calcium from almost 10 o'clock to totally full round. So what I have done is, this is called, see, this is the orbital atherectomy. It will be like, I'll show it in the next one. See this is what it looks like. See this eccentric diamond, this will be cutting and it will be just shaving by two ways. One, it will be just shaving the superficial sanding of the calcium. At the same time, the pulsatile forces will crack the deep media calcium also. So we have to very slowly do this, because if you do very faster, it will perforate the artery. So this is a newer one, just come to India just 2 months back, and this is done our center in South. So with this, slowly you will be just moving millimeter by millimeter forward and backward. It will cause superficial sanding of calcium. At the same time, pulsatile forces will crack the media, and you will get a fine, good expansion. See, you can see the crack. This calcium is cracked, this is cracked, this is cracked, and this is, when you see here, it is fully 360 degree it is there. Once it is cracked, I will show in the next how the stent expands. So we are putting then dilating it to 3 into balloon, putting 323 stent, then dilating with 4 into 8 balloon, and this is the final result. See how it is fully expanded. If you give such results, the patient restenosis rate is almost less than 4%. And one other very important, I had heard of that, I get often a second opinion telling that in that center, my father was asked to undergo angioplasty. What do you say that? They would have mentioned 70% to 80%. So that's what I said, oculostenotic reflex. It will be 70 to 80 for you, 50 to 60 for me, and for somebody it will be 90%. So because is in my experience. So this problem is taken off by this latest fractional flow reserve. What is this? Is physiology. What you do with OCT is anatomy. As said in echocardiogram, 2D and M-mode is for anatomical assessment. Doppler is for functional assessment. Color and Doppler for functional assessment. Same like that for coronary anatomy assessment, optical coherence tomography. For coronary functional assessment, this FFR, what this FFR means, whether you should stent or not stent. Whether the lesion in the coronary artery is causing flow limitation or not. So then how it is, the formula is FFR is equal to PD by PA. PD means pressure distal, PA means pressure proximal in iota. So this is what the wire will be like this. This is the catheter, the wire will have a pressure transducer. First we will be assessing here the pressure, that is PA, then here lesion is there, beyond here lesion is there, beyond lesion the wire will be put, we will be again recording pressure with hyperemia. Why hyperemia? Again it goes to the physics. See, the pressure is equal to velocity into resistance. When resistance is constant, pressure will be equal to flow. So to make resistance constant, coronary microvascular resistance, microvessels constant, you give adenosine. Adenosine produces microvascular vasodilatation. So it will take off the resistance. So you put the wire, you give adenosine 200 microgram, again record what is the pressure, you record. So that if you divide the distal pressure by proximal pressure, if the value comes less than 0.80, then only you have to stent. If it is more than 0.80, you should defer. This is FFR. What is RFR is, this is another one, taking total cardiac cycle. For that, the value should be more than 0.89. If it is less than 0.89, you have to do that. You see here, this looks very tight. Anybody will put a stent for this. But you see that FFR is 0.98. This is the fallacy. But you see here, it looks not that tight. Somebody will put on medical management, but you see the FFR, so it's 0.76. So it clearly says that the functional, whether there is a flow limitation is there. For example, for intermediate stenosis, between 40 to 70%, there is a lot of confusion whether to stent or not, especially 60-70%. So this will do that. Another very important of this wire is, for example, somebody will have LAD, LCX, RCA lesion. They will suggest bypass surgery. But if you put wire, to surprisingly, like the RCA will be negative, and sometimes LCX will be also negative. Simple, one single vessel disease. So what by I triple vessel will become functionally single vessel. And even I have seen last week, a lady has a 70% lesion. The patient subjected to bypass surgery because LCX and ramus are tight. After 1.5 years, the patient came with left internal mammary artery graft to LAD occluded. See, even if you subject the patient to bypass surgery and you put a graft, venous graft or anything, for example, if the four-way line from here to Madurai is good, who will go in the state way? So when the LAD is flowing good, why the graft? The graft will get occluded. So that way also this is helpful, because unnecessarily if you put a graft just because you undergone surgery, chest is open, one bonus, if you put that graft, it will end up with issues. So this is another case. You see that this looks very tight. So somebody will definitely proximal LAD. If you leave, the patient will end up with issues. But it looks like eccentric lesion. Again, the FFR is negative and RFR is 0.93. So that's the thing. Again, I tell no, this is the patient who has, this is LAD. Tight lesion. You see here this is LCX, some 70-60%, and the OM looks tighter. So this patient was suggested CABG also. Then I gave option of functional FFR study. We put a wire inside the LCX, it's negative. Put inside ramus, negative. So there is no need to treat LCX or this OM, obtuse marginal. So only LAD to be taken care. So the patient was subjected to angioplasty, and finally this with OCT guided angioplasty. Some 2.7538 stent was deployed. And then you can see the stent expanded properly here, and you can see in the cut section whether the stent is well opposed to the artery, because if the three things are very important in finding out the thing. So with that, I just put one final thing. MLD max is the word. M stands for morphology, whether fibrous, calcium, or lipid. L stands for length of the lesion. D stands for diameter of the lesion. So this is pre-angioplasty. You can choose whether to crack the calcium. You have to take 33 millimeter or what are the length, what is the diameter. This is MLD. Max is medial dissection is there. If the edge of the stent there is dissection, you have to cover with another stent. You cannot see by eye or by injecting dye the distal part unless the dissection is very massive. If dissection is there, you shift the patient to ICU, patient will develop stent thrombus and suddenly collapse in ICU. So max, MAX, M stands for medial dissection, A for apposition. What is apposition is, this is the apposition, whether the stent is properly opposed to the artery, and X stands for expansion. The expansion has to be very perfect. See, this is a, you can see this is the stent, and you can see this is, see, the branch, side branch, LCX, LAD. The stent is put from LAD to LM to LAD, but see the ostium of LCX is good. So this patient will not have any problem in future for LCX also. And finally, this is one case. You can see the bifurcation lesion. This is the patient. See, this is a bifurcation lesion. What is dropping is LAD, and what is going above is diagonal. So the lesion is here. You can see that. So the problem is you put a stent from LAD, then diagonal will get closed. Diagonal is a dual LAD. You see that LAD is here, diagonal is here. So almost a large diagonal. So this patient was given an option of CABG from this LCX also, but he has a very bad COPD patient, and creatinine was 1.5, and surgeon said very high risk. So we went ahead with bifurcation stenting. Put a wire, dilate both the vessels. This is the cutting balloon. Put first stent in the LAD, and then take a run, OCT run, then post-dilate. Then you put a pre-dilatation again. Otherwise the restenosis rate is higher. See, if you get this figure of 8, this is good. This is LAD ostium, and this below is D1 ostium. You see that between this gap, say from here to here, there is no narrowing. So the wide open diagonal. So that means this patient will not have any issue with restenosis to the diagonal. So finally, to conclude that, imaging and fractional flow image OCT is to look at the anatomy to do the angioplasty perfectly. FFR is whether you should treat or not treat. For that FFR, the lesion is flow limiting, should you put a stent or not? And if the FFR says you should put a stent, then the OCT is the right one to tell how to choose the stent and how to prepare the vessel, what size stent should be deployed, and after deploying whether the stent is properly opposed to the artery. And if you see a calcium arteries, now we are getting lot 75, 78-year-old patients coming for with ACS, not willing for bypass surgery. Don't know, probably because there are 14 Cath labs according to STEMI project in 14 medical colleges. And now everywhere the intervention has started a lot. So the people were not much willing to do CABG, especially elderly high-risk CABG. So we are forced to do the elderly patients, 75 and more, to do angioplasty calcium arteries. For such calcium arteries, if you take imaging and choose proper cutting balloon, scoring balloon, or orbital atherectomy or rotational atherectomy, you can shave off the calcium well crack the calcium, deploy the stent, expand the stent properly. The results are fantastic, and the restenosis rate is kept very minimal. Thank you.
Thank you, sir, for your breathtaking session filled with intriguing videos. Now we request our chairpersons to honor Dr. Arunachalam, sir. We request Dr. Loganathan, sir, Senior Physician, Ambasamudram, to honor the chairpersons.
Moving on, we have the next session on acute pulmonary embolism by Dr. B. Sangamitra ma'am, Senior Consultant Pulmonologist, Professor and HOD, Department of Respiratory Medicine, Government Thoothukudi Medical College. Dr. Sangamitra had done her MBBS in Tanjavur Medical College and MD in TB and respiratory diseases in Madras Medical College. Her areas of interest include occupational health, interventional pulmonology, sleep medicine, critical care medicine, and pulmonary rehabilitation. She is a TN MGR Medical University Board member for postgraduate medical clinical courses. She holds about 7 research articles in both national and international journals to her credit. I extend my hearty welcome to Dr. Sangamitra ma'am and request her to take over the stage. This session will be moderated by Dr. Muhammad Faisal Bashir sir, Assistant Professor General Medicine, Tirunelveli Medical College, and Dr. John Singh sir, Senior Pediatrician of Tirunelveli. We invite the chairpersons, Dr. Muhammad Faisal Bashir sir and Dr. John Singh sir, to the stage.
Good afternoon, everyone. Today my topic of presentation is acute pulmonary embolism. So you all know what is acute pulmonary thromboembolism. It refers to a condition in which the blood clot migrates from the systemic circulation to the pulmonary circulation. Most of the pulmonary embolism occur as a result of thrombus originating in the lower extremity. That constitute about 80 to 95%. Most thrombi originate in the deep veins of the cough. Other sources of pulmonary thromboembolism are from pelvic veins. That is, the predisposing factors for pelvic vein thrombosis are pregnancy, uterine fibroids, pelvic thrombophlebitis, or pelvic infection, prostatic disease, or recent pelvic surgery. Cough-limited thrombi won't pose a maximum embolic risk, that it poses a minimal embolic risk. If the thrombi extend into and above the popliteal vein, that represents the most common source of acute symptomatic pulmonary embolism. So actually, venous thromboembolism constitutes both DVT or pulmonary embolism and is the third most common cause of acute cardiovascular syndrome behind myocardial infarction and stroke. So acute pulmonary embolism interferes both circulation and gas exchange, and RV failure, right ventricular failure due to acute pressure overload, is the primary cause of death in acute pulmonary embolism. So there is an entity called as upper extremity thrombosis, that is due to central venous catheter or intravascular cardiac devices, or may be associated with thoracic outlet syndrome, or upper deep vein thrombosis, otherwise called as Paget-Stewart syndrome. And a small number of patients with pulmonary embolism may have a thrombi in the right ventricle. That is also called as clot in transit, that may cause hemodynamic instability as well as increase in mortality. So in 1854, Virchow is the one first to describe the pathogenesis of venous thrombosis. Almost 170 years crossed till we have used this clinical predisposing to venous thrombosis. The three main consequences are stasis, hypercoagulability, vessel wall injury. So immobility, bed rest, anesthesia, CCF, carpulmonale, and prior venous thrombosis cause stasis of blood. Then malignancy, anticardiolipin antibody, nephrotic syndrome, essential thrombocytosis, estrogen therapy, then heparin-induced thrombocytopenia, inflammatory bowel disease, then paroxysmal nocturnal hemoglobinuria, DIC, protein C and S deficiencies, and antithrombin 3 deficiency can cause hypercoagulability of the blood vessel. Trauma or surgery can cause vessel wall injury that can lead on to pulmonary thromboembolism or venous thrombosis. So these are the strong risk factors for causing venous thromboembolism with the odd ratio of more than 10. Risk fracture of lower limb, hip or knee replacement surgery, then hospitalization for heart failure or atrial flutter or fibrillation in the last 3 months, then major trauma, then MA in the last 3 months, then previous venous thromboembolism, as well as spinal cord injury. These factors cause venous thromboembolism, strong risk factors for causing venous thromboembolism. Then moderate risk factors causing venous thromboembolism are arthroscopic knee surgery, autoimmune disorders, blood transfusion, central venous line, then intravenous catheters and leads, then chemotherapy, CCF or respiratory failure, then sometimes erythropoiesis stimulating agent, then in postmenopausal women, hormone replacement therapy. That depends on the formulation. Then IVF, then estrogen containing OCPs, then postpartum period infection like pneumonia, UTI and HIV, then inflammatory bowel disease, cancer like pancreatic cancer, lung cancer, gastric cancer, brain cancer. They can also cause pulmonary venous thromboembolism or venous thromboembolism. Then highest risk in the metastatic cancer disease, then paralytic stroke, then superficial vein thrombosis and thrombophobia. These are all the moderate risk factors for causing venous thromboembolism. The weak factors are bed rest for more than 3 days. Then common risk factors like diabetes mellitus and arterial hypertension can cause venous thromboembolism rarely. Then immobility due to sitting. That is prolonged car and air travel. Long haul flight syndrome, that is called as economy class syndrome, because of the limited leg movements can cause venous thromboembolism and can cause death. Then increasing age, then laparoscopic surgeries, obesity, pregnancy and varicose veins. So the types of pulmonary embolism are broadly classified into hemodynamically unstable and hemodynamically stable pulmonary embolism. Unstable means that results in hypotension and is associated with death from obstructive shock. Stable range from asymptomatic to right ventricular dysfunction. So factors that determine the outcome of pulmonary embolism are size and location of the emboli, coexisting cardiopulmonary disease, then secondary humoral mediator release and vascular hypoxic responses, and rate of resolution of emboli. So these are the key factors contributing to the pathogenesis of pulmonary embolism, causing hemodynamic collapse and death. Right? There is increased RV afterload with the RV dilatation and tricuspid insufficiency, thereby increasing RV wall tension, then neurohumeral activation causing myocardial inflammation, that is called as pulmonary embolism induced myocarditis, where high level of epinephrine released within 48 hours and patient may die. Then right ventricular oxygen demand may increase, then intrapulmonary AV shunting, then right ventricular ischemia and diminished RV contractility with the diminished RV output, then left ventricular preload decreased with the diminished cardiac output and systemic hypotension, thereby reducing the coronary perfusion of the right ventricle, decreased right ventricular oxygen delivery. These are all the pathogenesis of hemodynamic collapse and death in acute pulmonary embolism. So the presentation of acute pulmonary embolism may be presented with isolated dyspnea, pleuritic pain or hemoptysis, or may patient present with circulatory collapse, tachypnea, so that we may going for assessment of pretest probability. The clinical presentation may be dyspnea, pleuritic chest pain, cough, hemoptysis, then tachypnea more than 16 breaths per minute, tachycardia more than 100 beats per minute, then increased pulmonary component of S2, RALS and phlebitis. The atypical symptoms may be syncope. If there is a syncope, then there may be hemodynamic instability, remember. Then fever, productive cough, wheezing, decreasing level of consciousness, then new onset atrial fibrillation. So these are the three clinical presentation of hemodynamic instability: cardiac arrest, obstructive shock, and persistent hypotension. These are the three main clinical presentation of hemodynamic instability. In cardiac arrest, we have to do CPR. Then obstructive shock, systolic BP less than 90 millimeter of mercury or vasopressor required to achieve a BP of more than 90. Despite the adequate filling status, then end organ hyperperfusion may be there with the altered mental status, cold clammy skin, oliguria, anuria, increased serum lactate, then persistent hypotension that is lasting longer than 15 minutes. So we must apply clinical probability scores in diagnosing pulmonary embolism. Clinical probability scores are nothing but it is a combination of clinical signs and symptoms along with the predisposing factors what we have discussed just now. Then consideration of the probability avoids the unnecessary testing and is critical to the interpretation of results. Of the scores, Wells scores and Geneva score, Wells score is more effective than the revised Geneva score. So there are two versions, original versions and simplified versions. Simplified version is adapted to practice these scores in our day-to-day clinical practice, right? So there are 3-level score and 2-level score. 3-level score, that is low-level pulmonary embolism, then intermediate, then high level. 2-level score means pulmonary embolism unlikely or pulmonary embolism likely. So the next one is the revised Geneva clinical prediction rule for the pulmonary embolism. There are several variables, then we have to apply the original version and the simplified version. So we are all having a smartphones, so we can take a screenshot of this and we can apply it in our day-to-day practice so that we can easily diagnose the pulmonary embolism. Then there is a newer one that is called as years criteria. That is here the clinical signs of DVT with hemoptysis and pulmonary embolism, most likely the diagnosis. These are the three criteria. Along with the D dimer, we can diagnose pulmonary embolism. Right? This is the newer one. So if the criteria are zero, no criteria, then look at the D dimer values. If it is less than 1000 nanogram per ml, then pulmonary embolism can be excluded. If the D dimer shows more than 1000, then do the CTPA, right? If any one of the, that is three criteria positive, then apply the D dimer. If it is less than 500, then pulmonary embolism excluded. If it is more than 500, then do the CTPA. There is no fixed cutoff point for D dimer as per years criteria. So years criteria, we can apply it in a pregnant female, right? If there is a clinical signs of DVT, then do the compression ultrasound of the symptomatic leg. If it is abnormal, then initiate the anticoagulant treatment. If it is normal, then apply the three criteria like clinical signs of DVT, hemoptysis, and pulmonary embolism, most likely the diagnosis. If the three criteria is zero, then look at the D dimer. If it is less than 1000, then pulmonary embolism excluded. If it is more than 1000, then do the CTPA. If any one of the three criteria positive, then look at the D dimer. If it is less than 500, pulmonary embolism excluded. If it is more than 500, then do the CTPA. So there is a rule called as PERC rule, that is pulmonary embolism rule out criteria. This rule is applied in low probability assessment for pulmonary embolism. This can be applied in the ED department when the patient is presented with dyspnea or chest pain in whom the gestalt estimate for P is less than 15%. So this is the PERC rule. There are 8 variables. If the patient is more than 49 years, if the pulse rate is more than 99 beats per minute, if the SpO2 is less than 95% on room air, does the patient is having currently hemoptysis, is the patient taking estrogen, then does the patient have a history of venous thromboembolism, has the patient had a surgery or trauma recurring hospitalization in the past 4 weeks, or does the patient have unilateral leg swelling. Apply this rule in low probability suspected pulmonary embolism. Then as a part of diagnosis, ECG can be done. Sinus tachycardia is the most common finding in pulmonary embolism, and there can be inversion of T waves in lead V1 to V4 and a QR pattern in V1 and S1 Q3 T3 pattern in ECG and incomplete or complete right bundle branch block. Then finally atrial arrhythmias, most frequently atrial fibrillation may be associated with acute pulmonary embolism. So this is the S1 Q3 T3 pattern with a tachycardia of more than 100. So echocardiographic findings in pulmonary embolism with a 60-60 sign and McConnell sign. Combination of pulmonary ejection accelerated time less than 60 millisecond with a peak systolic tricuspid valve gradient less than 60 millimeter of mercury is called a 60-60 sign in pulmonary embolism. Then dilated right ventricle. Then McConnell sign is nothing but akinesia of the mid-free valve but normal motion at the apex. Then signs of RV pressure overload as well as decreased topsy, that is tricuspid annular plane systolic excursion. Then there are several signs in chest X-ray reading of thromboembolism, pulmonary thromboembolism. Westermarck sign is nothing but peripheral oligemia. Then enlargement of major pulmonary artery is called as Fleschner sign. Then abrupt tapering of the occluded vessel is knuckle sign. Pallas sign is nothing but enlarged right descending artery. Then volume loss and ipsilateral diaphragmatic elevation may be there. Then cardiac enlargement and there may be mild pleural effusion also. So this is Hampton's hum. That is, shows pulmonary infarction. Hampton's hum is nothing but a wedge-shaped opacity with the apex towards the hilum. That is Hampton's hum. Then Westermarck sign on the left side with the focal oligemia. So look at the left side of the lung. Then Pallas sign. The white arrow shows the Pallas sign, enlarged right descending pulmonary artery. Then do the CTPA, right? CTPA is the gold standard for diagnosing pulmonary embolism because it is readily available around the clock in most of the centers with the excellent accuracy and strong validation in prospective management outcome studies, and low rate of inconclusive results may provide alternative diagnosis if pulmonary embolism is excluded. Then short accursion time is needed in CTPA. So the limitations of CTPA are radiation exposure, right? Exposure to the iodine contrast. So contraindicated in severe renal failure, pregnant and breastfeeding female, as well as contraindicated in iodine allergy individuals. Tendency to overuse because of easy accessibility. Clinical relevance of CTPA diagnosis of subsegmental pulmonary embolism is unknown. So the yellow arrow shows the right main pulmonary artery filling defect, and that blue arrow in the second picture, the blue arrow shows the saddle thrombus in the main pulmonary arteries. Then there is a planar VQ scan. This is the second diagnostic imaging modality in suspected pulmonary embolism. Almost no contraindication with the VQ scan. Actually inexpensive, strong validation in prospective management outcome studies, but the limitation is not readily available in all centers, and there are inter-observer variation during interpretation, and the results are reported as likelihood ratios and inconclusive in 50% of the cases, unlike CTPA where there were only 3%. Then it cannot provide alternate diagnosis if pulmonary embolism is excluded, unlike in CTPA. So VQ scanning is the second line diagnostic modality. It is used in CT contraindicated patients like renal insufficiency, contrast allergy and pregnancy. Then VQ SPECT, single photon emission CT, right? Almost no contraindication, lowest rate of non-diagnostic test, but there are only two interpretations, right? Pulmonary embolism or no pulmonary embolism. Limitation, variability of the techniques and diagnostic criteria, then cannot provide alternate diagnosis if pulmonary embolism is excluded. So this is a VQ scan with a filling defect in the left upper lobe. Then pulmonary angio, once upon a time it was the historical gold standard for diagnosing pulmonary embolism. It was an invasive procedure, not readily available in all centers. Then compression ultrasound. It is more than 90% sensitivity and 95% specificity for diagnosing proximal DVT. It has a high positive predictive value if positive compression ultrasound is proximal. Useful in cases with the CT contraindication like in pregnancy. But the limitation is 1/3 of the cases of pulmonary embolism have negative CES, that is compression ultrasound, and there is operator variability. Upper limb DVT occasionally missed, negative compression ultrasound doesn't rule out pulmonary embolism. So D-dimer, actually the fixed D-dimer cutoff is 500, but now a new age-adjusted cutoff D-dimer should be considered for excluding pulmonary embolism in patients with low or intermediate clinical probability. That is, if the patient age is more than 50 years, then age into 10 nanogram per liter should be applied for age-adjusted cutoff D-dimer. Then, as an alternative to the fixed or age-adjusted D-dimer cutoff, D-dimer should be combined with the clinical probability score. So this is the algorithm for the suspected pulmonary embolism patient with the hemodynamic instability. Do the bedside transthoracic echo. If there is RV dysfunction, if it is yes, then do the CTPA immediately. If the CTPA positive, then treatment for high-risk pulmonary embolism. Then if it is negative, then search for other causes. If there is no RV dysfunction, then search for other causes of shock and instability. So suspected pulmonary embolism in a patient without hemodynamic instability, assess the clinical probability with the help of Wells score, Geneva score, and years criteria. Then low or intermediate clinical probability or pulmonary embolism unlikely, do the D-dimer. If it is positive, do the CTPA. Then high clinical probability, directly do the CTPA. If it is positive, then directly go for the treatment. So this is simplified PESI score, pulmonary embolism severe index score. It is applied for assessing the mortality in pulmonary embolism patient, right? Low risk, that is 30-day mortality, or in hospitalization death. Right? Low risk is 0. High risk 30-day mortality 63.8% if the score is more than 1. So age more than 80 years, history of cancer, chronic cardiopulmonary disease. If the pulse rate is more than 110 per minute, then if the systolic BP is less than 100 or the arterial oxygen saturation is less than 90, then apply these scores for assessing the mortality in a pulmonary embolism patients. So there are 4 indicators of risk, that is hemodynamic instability, clinical parameters of pulmonary embolism based on PESI score, that is pulmonary embolism severity index score, and simplified pulmonary embolism severity index score, RV dysfunction on echo or CTPA, then elevated cardiac troponin level. This is to assess the early mortality risk in pulmonary thromboembolism patient. So the treatment. So the first treatment is hemodynamic and respiratory support. If the patient is in desaturation, so target the oxygen to more than 90% with the oxygen therapy and ventilation. Actually, the mechanical ventilation can cause hypotension. Already patient was in heart failure, right heart failure. Then following intubation, patient may prone for hypoventilation. So NIV or high flow nasal cannula can be preferred over the intubated mechanical ventilation. The pharmacological treatment of right ventricular failure includes small volume fluids, vasopressors, norepinephrine, and dobutamine. first stabilize the patient, then initiate anticoagulation. That includes parenteral anticoagulation like low molecular weight heparin, then unfractionated heparin or fontaparinux, then non-vitamin K antagonist oral anticoagulants like direct thrombin inhibitors, dabigatran, or oral 10A inhibitors like rivaroxaban, apixaban, edoxaban. So NOAC drugs are to be awarded in severe renal failure, pregnancy and lactation, Apla syndrome, antiphospholipid syndrome, then mechanical heart valves, then drugs that interfere with the COP3A4. So this is a dose of low molecular weight heparin and fontaparinux. Then the third modality of treatment is reperfusion treatment with the systemic thrombolysis, because faster improvement with the reperfusion treatment by increasing the pulmonary obstruction, right? Improvement in pulmonary obstruction, pulmonary artery pressure and pulmonary vascular resistance within first 48 hours, but useful for 6 to 14 days. So if there is persistent RV dysfunction and clinical instability, then that might be an unsuccessful thrombolysis. These are the drugs, right? RTPA, recombinant tissue plasminogen activator, that is the preferred treatment over the first generation streptokinase and urokinase. Here we have given 100 milligram over 2 hours. So you must know the contraindications for fibrinolysis, absolute contraindications and relative contraindications for reperfusion treatment. Then other modalities of treatment are percutaneous catheter-directed treatment like catheter-directed thrombolysis, ultrasound-assisted catheter-directed thrombolysis, then rheolytic thrombectomy plus catheter-directed thrombolysis, then combined techniques involving all. Then the last one is surgical embolectomy. Surgical embolectomy in acute pulmonary embolism is carried out with cardiopulmonary bypass without aortic cross-clamping. This can be combined with surgical embolectomy, can be combined with ECMO. Then vena cava filters. The classic indications for vena cava filters are absolute contraindication to anticoagulant treatment, recurrent pulmonary thromboembolism, then primary prophylaxis in patient with a high risk of pulmonary venous thromboembolism, then free Ice. Okay, sir. So you have to decide early discharge and home treatment for the low-risk pulmonary embolism with the help of HTR criteria and PESI and NT-pro-BNP biomarker. So HTR criteria is, there are 11 variables, right? If the answer to any one of these questions is yes, then the patient should not be discharged, right? So therapeutic anticoagulation for 3 months is recommended for all patients with the pulmonary thromboembolism. First pulmonary embolism and venous thromboembolism secondary to major transient or reversible factors can be managed for 3 months. That is the initial anticoagulation phase. Then there is an extended anticoagulation phase for an that is APLA, recurrent pulmonary embolism, and in cancer, we can extend the anticoagulation beyond 3 months. So pregnancy and pulmonary embolism, CTPA and chest X-ray, if you have a high index of clinical suspicion, VQ SPECT can be applied because of the low fetal and maternal radiation exposure. The treatment of choice of pulmonary embolism in pregnancy is low molecular weight heparin. In high-risk pulmonary embolism in pregnancy, we can do thrombolysis and surgical embolectomy. So this is the algorithm for the suspected pulmonary embolism during pregnancy. If you suspect pulmonary embolism, anticoagulate with the low molecular weight heparin, then do the chest X-ray and compression ultrasonography. If proximal DVT is present, then directly go for the treatment. If it is not present, then do the CTPA and rule out the pulmonary embolism. So this is the guidelines, recent guidelines from ECS and ERS. Treatment in the acute phase, that is the patients who are eligible for NOAC can be recommended with the NOAC treatment. Then ECMO may be considered along with the surgical embolectomy or catheter-directed treatment. For chronic treatment and prevention of recurrence, indefinite treatment with vitamin K antagonist is recommended for antiphospholipid antibody syndrome. So pulmonary embolism in cancer, edoxaban or rivaroxaban should be considered as an alternative to low molecular weight heparin and should be given beyond 3 months. And pulmonary embolism in pregnancy, you should consider amniotic fluid embolism in a pregnant and postpartum female if there is unexplained hemodynamic instability or respiratory deterioration along with the DIC. NOAC are not recommended during pregnancy and lactation. So to summarize, unexplained hypoxemia in the presence of normal chest X-ray, you should raise a suspicion of pulmonary thromboembolism, closely monitor the intermediate high-risk patients, then all pulmonary thromboembolism patients do not require admission as per HCR criteria, then algorithmic approach will be helpful in guiding the management as well as in hemodynamic instability as well as hemodynamically stable patient. NOAC are the fast drug for becoming the drug of choice as an oral anticoagulant. Above all, clinical judgment still of paramount importance. Thank you.
Thank you, Madam. We congratulate Dr. Sangamitra, Madam, for her exhaustive speech in pulmonary embolism. I request the audience to post any questions if you have any. Any questions from the audience? So, Mike.
Yes, sir. Long car travel more than 8 hours and air travel more than 8 hours can pose a risk to the pulmonary embolism, thromboembolism and venous thrombosis, DVT.
Thank you, Madam. Any other questions from the audience, sir? So we'll close the session. Thank you, Madam.
Thank you, sir.
Thank you, ma'am, for the marvelous talk. Now, I request the chairpersons to honor Dr. Sangamitra, ma'am. I request Dr. Ratnakumar sir, Professor of Medicine, TVMCH, to honor the chairpersons. Thank you, sirs.
Coming up is a session by Dr. G.L. Arun Muthukumar, consultant anesthesiologist, Aruna Cardiac Care, Tirunelveli, on NIV over invasive ventilation in cardiogenic shock. Dr. Arun Muthukumar sir is a graduate of Pondicherry University and holds a university rank in general medicine. He is a certified ACLS expert. He obtained his DNB in anesthesiology from Sri Ramakrishna Multi-Super Specialty Hospital, Coimbatore. He also holds a PG diploma in hospital management. He has expertise in all fields of anesthesia, including pediatric, neuro, cardiac anesthesia, ICU, and trauma care. I now welcome Dr. Arun Muthukumar sir onto the stage. This session will be moderated by Dr. Ramaya sir, retired Joint Director, Alangulam, Dr. Raghavendra Asrana sir, Kamala Nursing Home, Surandai, Dr. Danya ma'am, Consultant Physician, Tirunelveli. We request the chairpersons to take the stage.
Thank you for the warm introductory note. First of all, a good evening to the chairpersons, to all the healthcare professionals, senior legends who are here, and all the paramedic professionals. Myself, Arun Muthukumar. So before starting, I would like to thank our energy forces, Dr. Arunachalam sir and Dr. Swarnalata madam, for constantly guiding us throughout, and our Mr. Managaran sir and Ramesh sir and Murugan for making this session and this day a perfectly wonderful one. So my topic is on NIV or invasive ventilation in cardiogenic shock. So I also wanted to make something like artificial intelligence, meta, so something interesting for this topic, because in the morning it was a fully brainstorming sessions by Dr. Chenniyappan sir, Vijay sir, Vishnu sir, and many star walls. So, but due to lack of time constraints, I couldn't make. But I have brought one significant personality in this slide. So he will be there in the slides somewhere here and there. So just to make, like in medicine we used to say eye-to-eye contact. So we say spectator's eye-to-slide contact. A person will be there throughout in the slide here and there. So just to make something. So moving straight into the topic, first we will break down the topic. It is like a cardiogenic shock, NIV, invasive ventilation. Don't worry folks, I won't go deep inside. I'm just going to share my views, how these three things are interrelated and how these three things are involved in taking care of the patients. So first of all, a cardiogenic shock, there are numerous definitions like systolic blood pressure of less than 90 mm with the supports for more than 30 minutes, unresponsive with end organ damages. And there are many classifications. One of this classification is SAAI classification. So earlier days, it was like intubation was the first preferred choice. Whenever a patient is in a shock, in an unconscious state, or like patient is like respiratory arrest, I'm not like a cardiac arrest, when the patient is going for respiratory problem, intubation was the first line of treatment. Slowly, it was in the beginning and classic stage, but now even during the deterring phase and the extremity phase, NIV is more preferred over the invasive ventilation. We'll see why. So cardiogenic shock. So what exactly is a cardiogenic shock? Like Vadiveli holds a structural or a functional cardiac abnormality causing a reduced cardiac output and an elevated intracardiac pressure. Mainly this elevated intracardiac pressure is going to be the culprit. So as an anesthetist or intensivist, our role is to reduce this intracardiac pressure. So for this we are going to use a mechanical ventilation. Like in previous ma'am told, invasive mechanical ventilation are going to be more deterrent. For that, non-invasive, Even non-invasive is also going to use the same PEEP and the negative pressures, but in a way less, so that it is comfortably safer. So what happens is when the intracardiac pressure increases, pulmonary and systemic congestion occurs, and there's an end organ hypoperfusion and a cardiogenic shock. So what we are going to do, whenever there's an increased intracardiac pressure, automatically the negative thoracic pressure starts increasing the preload, and it will increase the afterload. So automatically our cardiac output will be less. So to counteract this, we are giving a positive pressure ventilation in a safe way with non-invasive mode. So what happens is when you give a non-invasive ventilation by positive pressure, it counteracts and it reduces the preload, and it also reduces the afterload without affecting the cardiac output. So as we see here, whenever there's a myocardial infarction or a myocardial dysfunction or systolic or diastolic phases getting affected, two things are to be addressed. First thing is the hypotension, and next is the hypoxemia. How we are going to deal with hypoxemia, I will deal with this. And next for the hypotension, Dr. Ganapathy, an upcoming next presenter, will throw some light on that. So when there is, like I told, when there's a pulmonary congestion and when there is going to be hypoxemia, if you give an adequate amount of oxygen, the patient is going to move from the death phase to the survival with a good quality of life. So another one. So when to start this oxygen therapy? So when the pulmonary congestion happens, this is the point from which when the oxygen saturation is falling, we are going to switch over from the oxygen by mask to through ventilators, so that we are trying to increase the myocardial oxygen supply, and we are reducing the ischemia, and we are increasing the cardiac performance. So the NIV is a very broad spectrum. It involves both high flow nasal cannula, face mask, helmet. Each one has a pros and cons. To be in a very simple way, in this helmet mask, you can't fix a definite amount of tidal volume, and in high flow nasal cannula, you can't have a definite amount of PEEP. But when compared to this, in face mask NIV, you can have both. Again, in NIV, there are various modes. Nowadays, with the very innovative sensors and this silicon chips, the companies are giving you multiple modes. So I will just take three modes. They are NIV with pressure support, pressure control, and BiPAP. Pressure support is mainly when you just want to reduce the work of breathing in a cardiogenic shock patient, you can switch over to NIV with the pressure support. Here we are just going to give a positive pressure alone. But in NIV with pressure control, we also instruct the ventilator to deliver a particular amount of pressure so that we get a particular amount of tidal volume. BiPAP is very useful in many situations, but mainly useful for post-critical care follow-up. Okay, so our concern of CVS, like I previously told, if you sing very loudly, like Vadivali says, the heart will burst. So now when the preload is so more, so what we are going to, like I told, the increase in intrathoracic pressure will be reducing both the right and the left ventricular preload. So we give a non-invasive ventilation and we reduce the afterload. This is not increased myocardium, this is like it promotes easy contractility for the choked myocardium. So now thereby the myocardium can somewhat breathe. Next thing, what I would like to throw some light is on arterial oxygen capacity. Why like I told, why in cardiogenic shock, NIV and invasive mechanical ventilation? In our body, there is one main thing, this oxygen carrying capacity. It depends on two things, bound hemoglobin and bound oxygen and dissolved oxygen. This bound oxygen is mainly due to hemoglobin, and dissolved oxygen is due to the PaO2 which we deliver. So for this, you can just focus on the example. When a patient is having hemoglobin 14 and saturation is 95 and PaO2 is just 105, previously, maybe this is after NIV. Before NIV, if it is like PaO2 of 60, when you give a adequate NIV and the PaO2 increases, see, you are going to increase the oxygen content of the arterial blood. So when you increase the oxygen content, when the patient is in the extreme stages of the cardiogenic shock, you are delivering the adequate extra amount of oxygen through the limited amount of blood pressure to the vital organs, so that you can have some more time. Like I told previously, in this some more time, our consultants can go for revascularization, relief of ischemia, so we can have get some time for them. Next comes three situations. How do I tell you? Like three doubts will happen. When to start this NIV? And if started NIV, when to change over? And at last we'll have one doubt. If at all we had intubated this patient, whether the patient would have survived. But this intensivist put on NIV, so this patient died. So these are the three common things we'll come across. So So for when to put on NIV, when the patient is having increased respiratory tachypnea and when moderate to severe dyspnea, and when there's a signs of definite increased work of breathing, accessory muscles are being used, abdominal breathing, added breath sounds, and I will say serial rise in PaCO2. Always not a single ABG value of PaCO2 is not an indication. When the PaCO2 values are continuously getting elevated in ABG and there's a fall in PaO2 by FiO2 ratio, you can definitely start him on an NIV rather than going on for intubation. So like I told, key benefits are, it preserves the ability to swallow, cough, communicate. These three words may be very simple, but ultimately all the ICU care rotates over on this only, because when the patient is able to give a humidified oxygen through a proper NIV, his mucociliary clearance will be maintained. In the post-op period or the 90-day mortality time, this NIV is very helpful than intubation. It reduces the work of breathing and it also helps in opening the collapsed lungs. So what are the things we have put the patient on NIV. So what are the things we need to monitor so that we don't change over to intubation? If you do all these things, we won't be needing to change over to intubation. Continuous bedside multiparameter monitor with a supported trained staff, because in NIV the major problem is the patients will get anxious. At the time, the reassurance to the patient and tight fitting mask should be enabled. It is placed continuously, because often the suction port will be kept open or one of the prongs will be left open. So the NIV won't be given adequate, and we will be saying NIV is failure and we will be switching over to invasive ventilation. So with the bedside multiparameter monitoring and with the staff, the success rate improves. And serial ABG, like when the patient is stable every 12th hourly or SOS, or if it depends on 6th hourly to 12th hourly, depends on your institute practice and protocols. And minimum is like every 24 hours a chest X-ray to be taken to assess whether the alveoli are open or whether alveoli are going for close, or some other time. Not only always NIV does not causes the failure. I would come to the point on the next slide. Some other things will be causing the NIV failure. So to find that, we need every 24 hours a bedside chest X-ray, a simple investigation. And one more thing, targeted tidal volume balanced with dead space. So even when you give an NIV, you can see how much tidal volume is getting generated. Too much of tidal volume will again cause barotrauma, biotrauma. So to prevent that, we have to calculate and keep what is the necessary amount of pressure support. Because when we keep extra tidal volume, he may go for pneumothorax. If you keep less, the alveoli get collapsed. Again, judicious use of FiO2. Always when you keep the normal atmospheric oxygen is 21%, but that does not mean we have to wean till 21%. Acceptable limit in ventilator is 30%, because any ventilator whatsoever hi-fi, it will have some amount of leak in the tubings, connection leaks. So never wean the patients below 30, FiO2 30. You can go up to only 30%. When you go wean below 30%, patient will have atelectasis only. Like I told, judicious use of PEEP. When the PEEP is more, it will cause hypotension. When the PEEP is less, it will go for NIV failure. So compared to invasive ventilation, you can always go for a judicious use of PEEP in NIV, because the damage is comparatively less than the intubation. And anxiolytics. Now we have novel agents like alpha-2 agonist, dexmedetomidine. It will cause an arousable sedation. So the patient respiratory pattern mimics like a normal sleep. So you can safely, because one of the thing, the next moment the staff will call you, sir, NIV vachonu patient cooperate panla. So you can give some amount of anxiolytics, reassurance. You can discuss with the patient attenders. You can discuss with the patient. I will say, so in the early stages when you are counseling them, so and you can put them on anxiolytics. So like I told earlier, the silent masqueraders, who are those culprits? These culprits there will be inadequate nutrition, inadequate gastric venting. Whenever the patient is on NIV, it's always advisable to have a Ryle's tube and vent out the gastric contents in between the NIV. So that doesn't mean we should not keep the patient nil by mouth. We have to give adequate amount of either enteral or parenteral nutrition, because after 24 hours, even though NIV reduces work of breathing, it has not eliminated the work of breathing. Patient needs some energy. That energy has to be supplemented. Or if he is not having that energy, soon he will have PaCO2 build up and he will again go for NIV failure, and we will say NIV is the mistake. Again, NIV is not the mistake. We have to correct these things. Unaddressed albumin levels. We will be giving all high-end antibiotics from verapinum to teicoplanin, but when the albumin levels are not to the level, nothing will be reaching the effective end organ, and the patients will be going for sepsis only. So these things, again, we'll say patients is not, correct the albumin, your antibiotics will start working. So meantime, you can have some more breathing. Pleural effusion, whenever this, you have to tap it out. So we have done all this, but sometimes it's like all in the game, patient will be needing invasive ventilation. At that time, we have to generously accept, okay, this patient is, after all this effort, he has gone in for failure, and we have to get ready for intubating the patient. So when it happens, serial ABG shows are, like I told, non-reassuring PO2 and increase in PSO2. In ventilation, only one thing, oxygenation, decarboxygenation. When both are not happening, we have to ultimately get ready for intubation. So always, whether the patient is on NIV, you should have a crash cart nearby. Patient unresponsive and sometimes can go for respiratory arrest. Like I told, when in respiratory arrest, we can't be using for NIV, we have to go for intubation only. Attenders and maintaining attenders and patient, like I told, when you're discussing, and if the attenders are saying, no, we are not interested, never force the patient. And when the patient has severe facial injury, where you can't keep a tight fitting mask. So we are deal with cardiogenic shock, we are keeping NIV, we are oxygenating so that we are making sure some amount of oxygenated blood is reaching the vital organs with this low blood pressure. But sometimes, between this NIV and intubation, is there anything to find how this, whether this NIV is successful or not? Yes, that is something known as HECAR score. So there are lots of scores. Now is HECAR, this modified HECAR, many scores are there. One of this basic score is like HECAR score. What it's going to do? We are going to see 5 things. Heart rate, when we have kept an NIV for 1 hour. HECAR is like after 1 to 2 hours you keep an NIV. If that is not, the heart rate is not settling down, because ultimately when the PaCO2 is high, heart rate is going to be high. And when there's acidosis, when the acidosis is not getting corrected after 2 hours of ABG, when the consciousness is going down, oxygenation and respiratory rate. So what I felt was this was like a basic scoring, but a very huge difference will make in the treatment. One special situation will arise. Now the patient is on NIV, it will be in the ICU. Now we have to shift the patient to two places, either intra-hospital or inter-hospital. Now for all intra-hospital transfers, the latest studies and cohort studies, they have shown NIV is far better and it is safe, because patient is in a controlled situation and you can safely shift the patient for angio suite where they can revascularize. With the NIV, we can go for an angio. But for intra-hospital, like studies shows NIV is preferably good, but it should have a person who is ready to intubate along the travel from the basement hospital to the destiny hospital, whether we are shifting or whether shifting for an investigation outside. If a trained person is there, you can keep the patient on NIV and shift the patient, or else better to switch over for invasive ventilation, intubate and shift the patient. So at last, a few literatures. Main thing is this card shock study. What they told us, like I told, after 90-day outcome in a patient who was successfully treated from a cardiogenic shock, when the patient was in NIV, the patient's mortality rate has come down and the patient's morbidity also has come down. Next is one, effectiveness and safety of the management cardiogenic. It was a Portugal-based study, and it is for not only in the relatively effective and safe compared to the mechanical ventilations. So, any questions? Hopefully, if there's no doubt. Thank you.
Any doubts from the audience side? So we close the session now. Thank you, sir, for an extensive talk.
Thank you, sir, for the illuminating talk. I now request our chairpersons to honor Dr. Arun Muthukumar, sir. I now request Dr. Arunachalam sir to honor our chairpersons.
A gentle reminder we bring to your attention an event where knowledge meets questions and the stakes are high. Access 24 quiz after the scientific sessions at 5:30 p.m. will have you compete for the top honors and exciting cash prizes. It is just 20 questions in 20 minutes with rupees 20,000 as cash prize. So audience, brace yourselves for the most rewarding 20 minutes of today. We challenge all the inquisitive minds here to try their luck and test their knowledge. The next session on our agenda is by Dr. P.C. Ganapathy Shaktivel sir, consultant anesthesiologist and intensivist, Aruna Cardiac Care, Tirunelveli, about inotropes and cardiogenic shock. Dr. P.C. Ganapathy Shaktivel sir is a graduate of Tirunelveli Medical College and did his MD Anesthesiology in Tanjavur Medical College. He holds a fellowship in Basic Pain Management from Asian Pain Academy, Kolkata. His areas of interest include surgical, orthopedic, cardiac and obstetric anesthesia, intensive care management and pain management procedures. I now invite Dr. P.C. Ganapathy Shaktivel onto the stage. This session will be moderated by Dr. Ratnakumar sir, Professor of General Medicine, Tirunelveli Medical College. I invite Dr. Ratnakumar sir onto the stage.
It's an immense pleasure to me to chair for my beloved and one of my best student, Dr. Ganapathy Shaktivel, brother of Aarti Shaktibala, who has received more than 15 medals and in the MBBS curriculum. And morning my wife told, "Kudumame medal kudumam abdin." So Shaktivel, his wife and sister. So it gives me extremely great pleasure to introduce you. So he is very dedicated and sincere since his third MBBS. And I know him from the first anatomy, when I coached him in physiology, endocrinology quiz, I remember so. So he is very sincere, dedicated, hardworking and sustained, sustainment is romba kashtam throughout the life. He is one among the person, right? So I invite you to give a good talk.
Thank you, sir, for your kind words. And I begin with my talk in inotropes and cardiogenic shock. So the discussion goes in the following headings: cardiogenic shock, how does a patient present, and what are the inotropes that are used and their dose titrations. So to begin with, let's start with a clinical case scenario relevant to this. A 72-year-old male patient with a known case of diabetes for past 16 years. He presents with a shortness of breath for the past 12 hours with palpitation for 4 hours, and his vitals show pulse rate of 112 per minute with BP 90 query, and saturation is 80% with 88% with room air. Auscultation shows bilateral extensive Krebs, and on a general examination there is bilateral pitting pedal edema. ECG shows extensive ST elevation in leads 1 AVL and V2 to V6. Echo shows global hypokinesia. TROP-I was positive, and NT-proBNP is 25,000. It's highly elevated. So with this, we start with the discussion. So cardiogenic shock. It is caused by severe impairment of myocardial performance that results in diminished cardiac output, end organ hypoperfusion, and hypoxia. The clinical presentation here is hypotension, which is refractory to volume resuscitation, and features of end organ hypoperfusion that may require pharmacological or mechanical intervention. Here we are going to deal with the pharmacological intervention of cardiogenic shock. So what is the criteria from various studies and various trials? From time immemorial, like shock trial, IABP soap trial, EHS trial, and various European trials, the common criteria was systolic blood pressure of less than 90 millimeter of mercury for more than 30 minutes, cardiac index of less than 2.2 liter per minute per meter square, with a pulmonary capillary wedge pressure more than 15 millimeter of mercury, and urine output of less than 30 ml per hour. So all these are persistent to the hemodynamic parameters, and this shows an end organ hypoperfusion where the renal parameter of urine output is reduced. So from the same slide from the previous speaker, so this is the Society for Cardiovascular Angiography and Intervention staging of cardiogenic shock. Persons at risk, beginning, classic, deteriorating, and extreme characters. So the classic cardiogenic shock, a patient presents with hypoperfusion, which requires intervention beyond the volume resuscitation, where they may need inotrope support or mechanical circulatory support devices. And deteriorating is the stage where even with the inotropes, the hypotension or the cardiac output is not maintained, and in extreme stage the patient is refractory to all this and patient goes for cardiac arrest. So the time to intervene is either at the beginning where the patient has any clinical evidence of hypotension or tachycardia without end organ damage, and at the stage of classic cardiogenic shock. So how to identify this? So in stage B, the physical examination shows elevated jugular venous pulse, rales in lung fields, strong distal pulses, and normal mentation. End organ damage is not happened, and the biochemical markers show normal lactate, minimal renal function impairment, and even at the stage of beginning, we have elevated brain natriuretic peptide. So BNP is one of the marker of early cardiogenic shock. And hemodynamics shows either systolic blood pressure less than 90 millimeter of mercury, or it is getting maintained with pharmacological agents. In stage C, classical cardiogenic shock, the patient typically presents in a volume overload state, and he requires BiPAP or mechanical ventilation, and the biochemical markers show presence of lactate more than 2, and increased liver function test, elevated brain natriuretic peptide, and a urine output of less than 30 ml per hour. In this stage, there is a requirement of these inotropic agents so as to maintain the cardiac index and cardiac output. So what are the inotropes which were commonly used in this cardiogenic shock? Dobutamine and noradrenaline, dopamine, milrinone, levosimendan. So dobutamine and noradrenaline are the commonest agents, are the recommended agents to be used, and milrinone has a special mention. Dopamine, which we frequently use, but there is no study supporting the use of dopamine in case of cardiogenic shock. So let's see the sites of action of these agents. So inotropes are agents which act on the cardiac tissue and increases the contractility, chronotropy, and also the relaxation. So most of the catecholamines which act on the level of beta-1 receptor, including dobutamine, they act at the level of beta-1 receptor. They promote the activation of adenyl cyclase, cyclic AMP, protein kinase A. This protein kinase A causes increased ryanodine receptor mediated calcium efflux into the from the sarcoplasmic reticulum, and this increases the calcium troponin binding and actin myosin cross bridging, resulting in increased contractility. Once this calcium has been used, the next is the uptake of calcium by the sarcoendoplasmic reticulum calcium receptor. This protein kinase A also activates the calcium uptake. So there is increased cytosolic calcium turnover. So it promotes chronotropy, inotropy, and also relaxation. Another agent is milrinone, which acts at the level of phosphodiesterase, which is a phosphodiesterase inhibitor. Phosphodiesterase is an enzyme which plays a role in degradation of the cyclic AMP into adenosine monophosphate. So this agent, milrinone, acts at the level of phosphodiesterase 3, inhibits it, and it increases the level of cyclic AMP. So the same mechanism is followed. At the level of vascular smooth muscles, there are 3 receptors, alpha-1 and beta-2 and potassium channels. In alpha-1 receptor, the predominant action is vasoconstriction. Noradrenaline predominantly acts at this level and it causes vasoconstriction. Dobutamine and milrinone has vasodilating property. Dobutamine acts at the level of beta-2 receptor, promotes adenyl cyclase, and it causes increased calcium uptake by sarcoplasmic reticulum, promoting vasodilatation. And levosimendan causes potassium efflux and promotes vasodilatation. Milrinone also acts at the level of phosphodiesterase 3 enzyme, and it increases the cyclic AMP and it causes vasodilatation. So Coming to the two inodilators, dobutamine and milrinone, the hemodynamic effects are comparable. Both increase the cardiac output and heart rate. Cardiac output and heart rate are increased by dobutamine and milrinone, but the systemic vascular resistance and pulmonary capillary wedge pressure is predominantly reduced by milrinone than dobutamine. This is the result from various studies. So which is better? So from various studies, it has been shown that norepinephrine is the agent of choice in cardiogenic shock with hypotension. If the patient presents with hypotension, norepinephrine is the first agent of choice. Dobutamine can be used when the cardiogenic shock patient presents with preserved blood pressure, but there is features of end organ failure, hypoperfusion and end organ damage is there. We can preferably go for dobutamine. Milrinone is the preferred agent in cardiogenic shock with preserved blood pressure, but the patients who had been taking long-term beta blocker therapy where the catecholamines are out of use, milrinone is a better agent. So this is a result from trial where around 40 experts worldwide had been questioned based on a questionnaire, and the result was, what is the first line of inotrope? Their suggestion was dobutamine. It was around used by 82% of the experts, and norepinephrine around 8%. So So dobutamine was the preferred agent in most of the answers, and norepinephrine was the next preferred agent. Dopamine had no role in this study. So according to various clinical guidelines of European Society and American Society, the first line of agent in case of cardiogenic shock when the patient presents with hypotension was norepinephrine, and when the patient presented with a low output state other than hypotension, it was dobutamine. So these were the preferred agents in case of cardiogenic shock. So it's like an algorithm. First, in case of cardiogenic shock, assess the patient. If the patient remains normotensive but had features of end organ damage, commence either milrinone or dobutamine. And milrinone can be started in patients who had been taking chronic beta blocker therapy. And if the patient had developed hypotension, add norepinephrine. If the patient initially presented with hypotension, first commence devices which promotes cardiac circulation when till the intervention is done. So the dose titration. So dobutamine, it is available in 5 ml as 250 milligram. When it is titrated in 50 ml of NS, the one main point to be stressed is always use these vasopressors and inotropes in central line rather than peripheral line, where it may cause vasoconstriction and inadequate input. So for an average 60 kg adult, whenever the dobutamine is started in case of 2.5 microgram, the dosing is 1.8 ml per hour. For 5 microgram, it's double the dose of 3.6 ml per hour. For 7.5 microgram, it's 5.4 ml per hour, and 10 microgram, 7.0 ml per hour. So this can be taken as a rough calculation for an average 60 kg adult, and the table can be taken for other interpretations. So noradrenaline dose titration. So noradrenaline, whenever we load, we always load as 2 ampules in 50 ml NS. This is used for syringe pump, and for an average 60 kg adult, when we begin the dose of 0.01 microgram per kg, we can keep the infusion as 0.2 ml per hour. And when we titrate to 0.1, 0.2 and 0.5 microgram per kg per minute, we can increase the dose as 2.3 ml, 4.5 ml and 11.3 ml. So any dosage more than 0.2 microgram per kg per minute or more than 0.5 microgram per kg per minute, consider addition of other inotropic agents like vasopressin, the recommendation as mentioned. So dopamine, not to leave it alone, dopamine, it is mainly it is used in the dose of 2.5 microgram per kg per minute. It is a renal dose. As we all know that it causes renal perfusion, it promotes the renal perfusion, maintains the urine output. And for an average 60 kg adult, when we load a dopamine in 50 ml NS, it can be kept as 2.3 ml per hour. And for 5 microgram per kg per minute, when we double this dose, it has cardiac beta mediated action, and we can increase the dose and keep it as 4.6 ml per hour. But in cardiogenic shock, as already mentioned, dopamine has the least role compared to dobutamine and noradrenaline. So milrinone. Milrinone is an agent of choice in case of patients who had been taking beta blocker and who doesn't present with hypotension. So 50 microgram per kg is the loading dose given in 10 minutes, followed by 0.375 to 0.75 microgram per kg per minute as IV infusion. The dose should not exceed 1.13 milligram per kg per day. So for an average 50 or 60 kg adult, the doses are as follows. For 0.375 microgram per kg, we can keep it as 5.6 or 6.8 depending upon the weight, and we can titrate it according to the response. So to conclude, this is a take-home message. Any patient who presents with cardiogenic shock, in case of low cardiac output state with normotension, start dobutamine, or if the patient had been taking chronic beta blocker therapy, start milrinone. If the patient presents with hypotension, start noradrenaline. Always start the inotropes and vasopressors at a minimal dose and titrate according to the response. It is always wise to monitor intra-arterial BP and since it is a continuous hemodynamic monitoring compared to the non-invasive BP while we are using inotropes. Administer central venous line and intra-arterial line whenever possible, and if it is possible in the center. To not miss the point, in case of acute myocardial infarction, patients presenting with cardiogenic shock, the treatment of choice is percutaneous coronary intervention with mechanical circulatory support devices is the ideal treatment. So till then, in order to bridge between the presentation of cardiogenic shock and the treatment of choice, these inotropes play a vital role in maintaining the life of the patient. Thank you for the opportunity. Thank you, sir.
Thank you, Dr. Ganapathy Shaktivel. Your presentation was very good and very precise. And it is the topic of discussion in EMC or ICC because common day-to-day problem. It was well addressed. Any questions from the postgraduates? Tamil. You ask questions to make the session interactive. If no more questions, we will finish this session. Thank you.
Thank you, sir.
Thank you, sir, for the comprehensive talk. I now request Dr. Ratnakumar, sir, to honor Dr. P.C. Ganapathy Shaktivel, sir. We request Dr. Aruna, sir, to honor Dr. Ratnakumar, sir.
Thank you, sir. Coming to the final scientific session of the day, we have with us Dr. N. Subramanian, sir, consultant rheumatologist, Tirunelveli, and Velamal Medical College Hospital, Madurai, about the role of rheumatologist in cardiac diseases. Dr. N. Subramanian, sir, holds MRCP UK and MRCP CCT in rheumatology. He is a fellow of Royal College of Physicians, Edinburgh, and fellow of Indian College of Physicians. He has about 23 articles published in various in-depth medical journals. He has also received numerous awards. A few notable ones are the Bharat Jyoti Award, Distinguished Teacher Award TNIMA 2022, Best Doctor Hindu Tamilisai Award 2023. He is the present Secretary of the Association of Physicians of India Tirunelveli and the President of Indian Medical Association Tirunelveli. His special interests include rheumatoid arthritis, SLE, spondyloarthritis, biologics and biosimilars. I now heartily welcome Dr. N. Subramanian, sir, onto the stage. This session will be moderated by Dr. Rajesh, sir, pediatrician from Aikudi, and Dr. Padmanabhan, sir, senior physician from Attur. We invite the chairpersons to the stage. The quiz will begin soon after this session. OMR sheets will be distributed to all the delegates shortly. We request you to read the instructions carefully and fill in your details accurately. Over to Dr. Subramanian, sir.
Good evening, everyone. So, at the outset, I would like to thank the Aruna Cardiac Care, Dr. Arunachalam, Madam, and all the management for giving me this opportunity, and also thank the chairperson. So, it's going to be the last over for today. So, I'm not going to be like Dhoni, but I'll do justice for my talk. Rheumatology, as many of you are aware, that is a multi-system disease, and it has mission in every field in our system. So I would like to also remember my teachers, Prof. Edwin sir, my alma mater, Medical College Medicine Chief, and also Rheumatology Chief from Leeds. I'm currently based in Tirunelveli and also in Velamal. So what's the role of rheumatologist in cardiac diseases? So perhaps it's less role by the looks of the program and being the last batsman or in the final over. But the major diseases we normally deal with include three different groups like arthritis group, connective tissue disease group, and also vasculitis group. So these are the main auto-inflammatory diseases. There are some orphan diseases, unknown diseases we also deal with. And many of inflammatory systems are you also seen in infections. So that is probably the more common in acute care. And the risk factors are multimodal. So it can be a traditional risk factors or it can be disease-specific risk factors based on the duration of disease, autoantibodies, and chronic autoimmunity. So if you look at worldwide data, some musculoskeletal system, we all will get disease at some point in life. It may not be inflammatory, but it's musculoskeletal health is very important. So rheumatoid is a common one. Next common is lupus and other diseases there, and spondyloarthritis and vasculitis. So if you look at the data from WHO and Indian studies, so RA tops followed by knee, OA, and also SLE and ANSCOND. And remember, the gout also forms part of the major outpatient setting involvement. So these are the common symptoms people present with. It could be painful joints, it could be painful joints, it could be pain and limitation in the joints, and also it could be inflammatory or non-inflammatory. And remember, back pain in younger age group, pain in night, more inflammatory. And we also deal with other diseases in eyes, bowel, and also cardiac and cardiovascular. And there are some soft tissue rheumatism too. So broadly, we can classify 3 groups of diseases. One is connective tissue disease, the other one is arthritis, the third one is vasculitis. And there are 3 systems involved. My rheumatology teacher used to say, anybody who comes with 3 systems, nerves, eyes, joints, systemic symptoms, and a rash. So all these, any more than 3 could be think about inflammatory. And there are 3 approaches we normally discuss about whether to induce a remission at the time of a diagnosis and achieve or maintain remission, and then if there is a flare-up, you manage accordingly. And the 3 teams is normally the patient and the family and the rheumatologist and the other allied specialties, and the finance is another one. So that is because it's a chronic disease, so it's a long-term risk is also there. So cardiovascular disease, so where cardiac disease come into play. So any inflammatory disease has a long-term cardiovascular risk, and that is being evident in every country's journals. And the common ones are rheumatoid, lupus, and scleroderma, and other chronic diseases like stroke and peripheral disease always have an inflammatory component. So the new epigenetics and other studies have shown that they also have an inflammatory component. So the CVD burden, this was published in 2020, you can see. So 1/3 of total deaths are contributed by cardiovascular disease. And they say more common in South India, Kerala, Tamil Nadu, and Punjab. So there is the highest prevalence, partly because of our inactivity and cholesterol and high sugars. So the conventional risk factors are hypertension, diabetes, dyslipidemia, smoking, and obesity. And in the Interheart study, the other risk factors include vegetables. We take vegetables, but still it's coming down, and the fruit intake is less, and also psychosocial stress. So that is more common in the South Asian population. So inflammation, so whether it's an innate or adaptive immune response, they have an essential role in the inflammatory cascade. And the atherosclerosis is the prime driver for cardiovascular disease, and that also has an inflammatory component with the atheroma involved in it. And in fact, even AF, they have shown that inflammation is under the background. So plaque atherosclerosis, altered immune response, and remodeling all have an inflammatory component. And the contributors of disease is depicted in this picture. So you have risk factors, you have chronic inflammation, and also adding to that is anti-inflammatory therapy. Not all of them, but some like long-term steroids and anti-inflammatories can cause increased risk, followed along with endothelial dysfunction, plaque remodeling, and accelerated atherosclerosis. So most of the rheumatic diseases are women-dominant. Many people think why it is. So these are the main factors. You have high estrogen, which has more immune effect and cytoprotection, but you also have other hormones like progesterones, androgens, and prolactin. So they all can contribute to the abnormal immune outcome in patients with rheumatic diseases. So let's have a few discussion about the case-based patients. So I'll share with you a few of my patients, so get you into an understanding how the rheumatologist's role in cardiology or cardiac diseases. We always have a multi-system approach, so that goes there. So 24-year-old male patient returned from Dubai. He was admitted with chest pain, and he had an ECG showing T inversion lateral leads, and his top T was elevated. And he had Cath, which showed circumflex, which was stented, circumflex narrowed. And during the second day, he noticed ankle pain. So here many PGs are there, I believe. And any further questions would you like to ask, or what is the differential diagnosis? Ankylosing spondylitis, and how it is related to vascular disease at this age? Usually ankylosing spondylitis is inflammatory back pain. Good thought, but in acute setting. Any other? Gout is possible unless patients had high alcohol intake or being given lots of diuretics, because it's the third day, day 3 post-stent. It could be, stent, the angiogram and related nephropathy, acute renal, high uric acid, that is also possible. Any other symptom would you like to ask? Because my thinking was, why you have CV, coronary disease at the age of 24? So that is the point. Okay, so it's a vasculitis. And if you think vasculitis, what would you like to ask? Okay, so vaginous granulomatous is a good thought. If it is eosinophilic EGPA, you can get coronary disease, yes, correct. Hematuria, okay. So they are more pulmonary renal syndromes, right? Smoking, okay. Smoking, why do you get ankle pain? Unless you have TAO, Burgess, but it's a long standing. This is joint pain, right? Okay, less likely because it's a women dominant disease. Which vasculitis can cause coronary vascular disease? Okay, right. So during the discussion, he had intermittent fever, but that was treated as infection short term. He also had oral ulcers. SLE? What is that? Yeah, Behçet vasculitis. Okay, so that is the diagnosis. So if you had the diagnosis before the coronary event, you would have avoided the stent. So, and during the discussion, he is the only son of a family of 5 girls. All of them are married, so they are looking for a girl in this boy. So there is a lot of concerns and questions. Okay, so gout, lupus, vasculitis, which you rightly pointed out. So the Behçet vasculitis, which is a small vessel disease, and genital ulcers, oral ulcers, DVT you can get, and also painful joints and coronary disease. So he had a HLA-B51. I'm sorry, I didn't ask you the questions. HLA-B51 and 52 abnormal, and the CRP was up. So he is stable. He is on colchicine and azathioprine right now. So we don't do long-term steroids anymore nowadays. So second one, 42-year-old teacher. She came in with the chest pain and left arm pain for about 3 days. ECG showed ST depression in the lateral leads only, and there was a bit tachycardic. So BP is not recordable in the left arm, but the right arm BP is up there. I'm sure you all had the diagnosis? Yes, very good, thank you. So echo showed AV, aortic valve is dilated, and EFS 42 and dilated LV. So diagnosis, apart from Takayasu? Any other? Why do you have dilated LV? So you can have a coronary arterial involvement, or you can have aortic root involvement with the Takayasu. You can extend into the aortic valve. So the patient had aortic valve replacement and also subclavian bypass. She is currently on acetram, lifelong. And she is back to work. வந்து இப்போ 50 kilometers every day travel பண்ணி work பண்றாங்க. So just to be aware that Takayasu vasculitis, you can have dilated aortic arch and also subclavian stenosis and large vessel disease. It can affect intracranial, extracranial, abdominal, and also renal vessels. So this is a aortogram, angiogram, and also a boy with a reduced abdominal aorta up there. So clinical manifestations depending on which territory is involved, whether it's a cranial vessels, whether it's aortic arch vessels, or whether it's abdominal aortic vessels. So I'm not going to go into the details of it. It's 20-30 minutes. Third patient. So 24-year-old lady, recently married. They're working in Bangalore. So leg swelling for 10 days. Actually, this is the first patient in March 2019, in February. So no systemic features. They had gained 2 kilogram weight and very tired. So what do you think? Huh? It's a skewed presentation, right? So all will be rheumatology. I think APLA is possible. So you have a DVT, but weight gain of 2 kilogram, it could be due to the leg edema, it could be. Clinically, she had a DVT left femoral, but there was some abnormal symptoms like high thirst and tiredness. So I did a capillary sugar, it was 520. So, but hindsight, I was thinking this was the first patient during the COVID time. So I think it was a COVID-induced, all these abnormal. We didn't know all those things. So this patient had a urea creatinine up there, and the hemoglobin was 7.4, anemia, and they are from Coimbatore but living in Bangalore. So Doppler iliofemoral DVT. So what would you like to do? What is the next step to do? Okay, but there was no breathlessness, I believe. We did a saturation at the OPD. So any above knee DVT have to be admitted. Why? Risk of pulmonary embolism is very high. Okay, so they said we want to go home, young people. So and the COVID, coming. So the cause was, as you said, it could be contraceptive pills, it could be APLA syndrome, and it could be anything, but it could be diabetes because 520 sugars, you have a hemoconcentration, so that also can cause thrombosis. So the next day developed tachycardia. So before we get to the echocardiogram, we brought her down to ICU, and with the ECG itself, I thrombolized. And that was PE, pulmonary embolism, definitely. And APLA was positive, ANA was weak positive, it's not ANA disease, and other thrombocheck normal, and the patient is currently on insulin and acetrom. So for APLA syndrome and DVT or PE, acetrom is the only proven drug for anticoagulation. 58-year-old female, rheumatoid, methotrexate, anti-inflammatories, tofacitinib. You all know this recent JAK inhibitors, which is a tofacitinib, admitted with chest pain. Found to have myocarditis. So also have diabetes and metformin. Because of the risk, age, drugs, and also myocarditis and the diabetes, she went on to have a Cath, which showed a double vessel disease. Both of them have been stented. Is that a metabolic syndrome here? So, many patients, I think, in the current trend of school children and college people, we are going to see more metabolic syndrome because everybody is reaching 100, even in the school to college. Yesterday, I saw a boy who is studying 4th standard. He is 48 kilograms, just 4th standard. So, metabolic syndrome is definitely a big factor in our cardiovascular management. So it has an inflammatory cascade, obesity, hypertension, dyslipidemia, insulin resistance, that is the main factor, and endothelial dysfunction. And all of them have been triggered by our inflammatory diseases. So that's why there is a close interface between the cardiology and rheumatology. So what are the comorbidities we normally deal with or encounter in patients with rheumatoid or psoriatics or Angst-Pond? So insulin resistance, dyslipidemia, obesity, and NASH, which is a new concept. I think whoever has a BMI of 24 and 25 in this group will have a NASH. And it's a precursor for diabetes. So, and that is the cardiovascular risk too. So what are the cardiovascular manifestations of rheumatic diseases? You could differentiate into valvular, vascular, coronary, or myocardial, endocardial. So that is a teaching slide. So I'm not going much into that, but every part of the heart, you have problems with rheumatic diseases. Next patient, 17-year-old girl, fever and red spots in legs, purpura and fever. 17-year-old, more likely HSP, cervical adenopathy. So slowly towards lupus. no splenomegaly and no other signs. Why did you say no splenomegaly? Very commonly associated with Coombs hemolytic anemia. So you always look for splenomegaly. And ITP also. Anybody who has ITP and fever, adenopathy, think about lupus. So you have platelets up there, and thyroid is also abnormal, and urine showed 5 RBCs, and this is lymph node biopsy showed Kikuchi adenitis, which is again a precursor of lupus. So any patient, young girl with low platelets, think about lupus. Hashimoto thyroiditis, think about lupus, and abnormal lymphadenopathy, think about it, and do ANA. So this is telltale features of lupus. So 25 years, rash, fever, mouth ulcers, tiredness. Generally people treat as rheumatoid, but it's not so. So have a close history is very important. This lady within 4 days developed facial puffiness. So that was renal lupus involved in it. So medical condition associated with positive ANA. So ANA is not diagnostic for lupus, but it could be a screening test. And ANA, if you're looking at the titer, 1 in 40, 80, 160. 160 is diagnostic or pathognomonic, and beyond that also. But 1 in 80 is debatable, and if you are having a biopsy evidence, then you can accept it. If not, it could be additional only. So, and there are other patients who also have ANA positivity. So it's not specific, same like a rheumatoid factor. And this is a teaching slide for students. So you have all ANA profile important antibodies and which diagnosis. So until I joined rheumatology, this is a nightmare. So on the day of exam only you can remember, otherwise you tend to forget and get negative mark. So lupus is the commonest autoinflammatory multisystem disease, and it's a complement mediated tissue damage characterized by remission and relapse, and also have a very ill prognosis. These are systemic features of lupus. So that's why it's diagnosed very tough sometimes. So there are some patients who have been on anti-tuberculosis therapy, after 4 weeks not getting better, then they come to the rheumatology circle. And these are suggestive features where you have dry mucosal surfaces, inflammatory arthritis and rash and a mouth ulcer and Raynaud's and weight loss. Pulmonary and cardiac features. So these days predominantly cardiothoracic. So you have pleurisy, pneumonitis, fibrosis, and also you have cardiac features, which is pericardial effusion and non-bacterial merantic endocarditis. These are the lab features specific for lupus. So you have different types of anemia, leukopenia, and also thrombocytopenia. The earliest will be lymphopenia. So always look for lymphopenia in a patient with suspected lupus. So that may give you a clue. And CRP is most likely normal in lupus, but in inpatient you don't get as an inpatient straight away. They all get some infection additionally on top of it. So that's why CRP is slightly up on admission, but in the OP setting we do see normal CRP. They cannot go out of the hospital without urine looking at the hematuria, proteinuria, because the approach is very different, because renal lupus is very rapidly progressive. And antibodies up there, we all screen them. So the interface between cardiology and rheumatology comes here. Apart from pericardial effusion, pleural effusion, and myocarditis, you also have thrombosis, which is the Aplar syndrome related. So deep vein thrombosis, pulmonary embolism, which is the venous side, and arterial thrombosis, and also recurrent miscarriages. I thought these two are specific for students. So a lot of talk about rheumatic arthritis. Still, patients already 70 years old or 60 years old, still they do ASO and treat with the penicillin. So we don't know. So ASO and arthritis, is that entity now? Is that rheumatic fever still happening? Very, very less incidence, partly because of the way our life is and also the improved quality of life. So this is a study in Pune, and the mean ASO titer up there, and predominantly non-rheumatic diseases. That is the main one. So it's not associated with rheumatic fever. And all other diagnoses of rheumatology also can have positive ASO. So don't label them as rheumatic fever. So that is nearly 15% of patients tested positive only out of 825. Sorry. None of them had rheumatic fever. So it's not statistically significant differences also. Also rheumatoid arthritis and rheumatic fever, only 45% specific. So we do anti-CCP, which is the most specific antibody for diagnosing rheumatoid arthritis. So current status of rheumatic heart disease in India, this is a very good paper a couple of years ago, and it does show that it is very, very less incidence, and you can see over the last 5 decades, the incidence from 11 to 1.2. So it's very much reduced. So it's time to collaborate among cardiologists and rheumatologists. That is already explained before. So that's where the patient is, and these are the team members of cardio-rheumatology combination approach. So just out of education side, you have different characteristics of immune-mediated inflammatory diseases and what are the manifestations, what are the CV risk and treatment options, but it's there in American Heart Journal, so you can read about it. It's 2022 paper, very good paper. And the CVD risk factors are also up there, so smoking, hypertension, dyslipidemia, obesity, and physical inactivity and insulin resistance. So increase, decrease, but all the more it is more skewed towards high risk of coronary disease. And inflammation contributes to atherosclerosis, endothelial dysfunction, and also plaque vulnerability, leading on to rupture and also coronary events. So nuclear kappa factor B, that is a major transcription factor, which is playing a crucial role in the regulatory inflammatory cascade. And in endothelial cells, it's pro-atherogenic, whereas in vascular macrophages, it is anti-atherogenic. So that is just an MCQ point. So next patient, 52-year-old female, admitted with the breathlessness, chest pain. So known to have scleroderma, but no ILD. So usually patients, if you have ILD, they may have inflammatory or intermittent flare. So this patient is on mycophenolate and steroids and diabetes and insulin, dyslipidemia, maintaining an atherosclerosis and BMI of 31. So it's more of like a metabolic syndrome. So echo biventricular dysfunction. So what do you think about? Any thoughts? So the cardiologist returned this patient back to us, and this is the echo report, and you can manage. So we discussed about this patient again, back to the cardiology, and the angio showed a microvascular disease. So that is also important to note. So they may not have MI, but they may have ischemic symptoms and manifestations. So that is important note. So that's a diagnosis, and so I'll also quote this paper from 2014, but very good paper on cardiovascular involvement in autoimmune diseases. It looks at every different disease. So you have endothelial dysfunction, subclinical atherosclerosis, and manifest cardiovascular disease, followed by accelerated atherosclerosis and intimal medial thickness increasing and endothelial impaired function. So this is another male, 34-year-old chef in Middle East, non-vegan. So obesity there, hypertension there, came with painful toe and joint pain. So you know podagra, right? So all know. So hypertension and diabetes, everything is abnormal in that. So what is the diagnosis? This is more, as I said before, metabolic syndrome, gout arthritis, and syndrome X. Yeah. So very important to remember lifestyle and risk reduction. Whatever you do for the coronary disease or vascular disease, it's a havoc unless we control these risk factors. So education is important. So that's why this program is tuned for cardiovascular disease. And patients also, public awareness also has to be improved. So slowly, we have to reduce the culture of fast food and healthy eating to be promoted, and physical activities also to be promoted. So this is illustration between autoimmune rheumatic disease and various cardiovascular risk factors. Not only the disease risk factors, you also have drug risk factors. But from a rheumatology circle, we are trying to come off anti-inflammatories and steroids. So we have biologics, which has a very good disease control and risk reduction also. So we have from Velamal, we have sent papers across every year. So this is 2022 Stockholm Euro lupus paper. So cardiopulmonary disease in SLE, which is a changing trend, more of pericardial effusion and pleural effusion and pneumonia were the main features in those patients. And we had 120 patients studied and 51 had a cardiovascular manifestation. So very important to note. So we have various associations coming with the recommendations to manage these patients with the rheumatology and cardiovascular. So basically it's a team effort. So involving health professionals, patients and different stakeholders, and also social media dissemination is also important. So the key message is optimal anti-inflammatory treatment is important. So that will reduce the cardiovascular disease. And lifestyle interventions are also important. And risk factor management and also lipid lowering therapy and other diabetes also to be controlled. So it has to be a global event. Hope the access will become global soon. So if you want to follow me, that's the ResearchGate link. And also all research interested people to have ORCID ID. So we also raise awareness among public and different associations, Arthritis Day, Osteoporosis Day, and Lupus Day also. So the role of rheumatologists, because we deal with multi-system disease, we always have friends in every specialty. So from ophthalmology, dermatology, cardiology, pulmonology, and every specialty also. So aggressive disease reduction and remission is our goal, but we always look for cardiovascular risk and manage accordingly. And there is always an interdisciplinary approach. So right now today there is a patient who has been screened for breathlessness and found to have tricuspid regurgitation. So because of pulmonary hypertension. So just had an echo report from Madurai. So in always we have link with every other person, and rheumatology is all fascinating because immunology is involved, orphan diseases, unknown diseases. So we always have a passion to treat all those things. If you always do what you have always done, you always get what you always got. So that's from Mark Twain, it's not me. So with that note, it's 20 hours finished, I think. So thank you everyone for passionate listening, and also any questions you can ask. I'm sure there are a lot of questions. Thank you. Thank you, Chairperson.
Thank you, sir. Thank you for your excellent lecture. Any question from the audience?
So we have a cardiologist, we have a vascular surgeon, we have a cardiothoracic surgeon, but we don't have a cardiovascular doctor, yeah? So you can call rheumatology as a cardiovascular. So we look at the peripheral, central, and also cerebral. So all vascular systems we deal with. So that's the rheumatologist. Any questions? Yes, sir. So the question was tofacitinib and rheumatoid, right? So, yes. So if you look at the drug side effects, you normally have about 140 odd side effects. And every patient can have any of them. So the counseling is important. So autoimmune diseases are due to heightened immunity, but it's abnormal. So that is the bottom line. So நம்ம இம்யூன் சிஸ்டம் வந்து நமக்கு சப்போர்ட் பண்ணாமல் நமக்கு எதிராக சப்போர்ட் பண்ணுது. ஸோ அதனால் இஃப் யூ ஆர் சூஸிங் அ ரைட் பேஷண்ட் அண்ட் ரைட் ட்ரக், இட் வில் ஒர்க் ஃபார் ரைட் டைம். Common side effects we have encountered recently, weight gain, deranged lipids, and also vascular disease. So I have seen about 5 or 6 patients with abnormal, not coronary per se. You have bowel infarction, you have peripheral arterial disease leading on to amputation, and also stroke for patients who are already on tofacitinib. So there is a high risk of vascular disease and deranged lipid profile and weight gain. So these are the common ones we come across. We have just started a funded study in Velamal, so looking at metabolic profile and patients who are already on tofacitinib. So rheumatologists always have a bit of a caution not to start tofa unless there is a strong indication. But அது வந்து மெட்ஃபார்மின் மாதிரி எல்லாரும் யூஸ் பண்ணுறாங்க இப்போ. So we hope we get to see more complications. Shouldn't do, but that's the way it is. Regulators have to come in also. PGs always have to ask more questions. இல்லை நாங்களே கொஸ்டின்ஸ் எழுதி கொடுத்து வேணால் கேட்டுடலாம். Or maybe you are ready for quiz program. So I would like to stop here, and all the best for the access and also your quiz program. Thank you.
Thank you, sir, for the profound talk. I now request the chairperson to honor Dr. N. Subramanian, sir. I request Dr. Arunachalam, sir, to honor the chairperson.
We request the audience to occupy the front rows for better visibility as well as better chances of winning. If you have not received your OMR sheet, kindly contact the volunteers ASAP. An investment in knowledge pays the best interest, quoted Benjamin Franklin. We had a sumptuous feast of knowledge since morning. It is now time for us to deploy our grey cells. Answer these questions and bag the exciting cash prizes worth 20,000 rupees. The quiz format is written and 20 questions will be displayed onto the screen. Please answer in the sheets provided to you. Each question will be displayed only for 1 minute. I repeat, only 1 minute, so it is a race against time. The questions will change automatically once time is up. It is not just the fastest fingers, but also the accuracy that matters. No negative marking is followed. Please read the instructions mentioned in your answer sheets carefully before filling them in. We request you to shade the circle properly. The stakes have never been higher, so put those gray cells as well as your median, ulnar and radial nerves to work as we begin the first question for Access 24.
We request the participants to occupy the front rows. We request the delegates from the last few rows to come forward. We request everyone to mention their full name with designation, mobile number, and also sign at the end of the sheet. You have to shade the circle properly. So there are total of 20 questions with each question for a duration of 1 minute. After the 1 minute, the question will not be displayed again. So we request you to read the question carefully before answering. It is just 20 questions in 20 minutes with rupees 20,000. So audience, so shall we begin? We request all the participants to be honest. Please don't Google. So here's the first question. So next question. So the next question, question 3.
The next question. The fifth question. Sixth question. Seventh question.
Option D, milrinone. I once again repeat, which of the following is an inodilator? Option A, phenylephrine. Option B, levosimendan. Option C, norepinephrine. Option D, milrinone.
Next question.
Eighth question. Ninth question. Tenth question. We don't want to make you more anxious, but you have to remember there's 20,000 rupees running on the line. Eleventh question. Twelfth question.
I repeat, which genetic mutation is most commonly associated with pulmonary embolism? Option A, factor V laden mutation. Option B, prothrombin G202110A mutation. Option C, MTHFR mutation. Option D, antithrombin deficiency.
13th question.
Fourteenth question. Question 15. signs and symptoms of DVT, and option D is previously documented pulmonary embolism. So 16th question. We have 5 more questions, 5 more minutes. The clock is ticking. Question 17. Eighteenth question. So the 19th question. So the final question, the final minute that stands between you and the 20,000 cash prize. So the time's up, guys. Kindly return your answer sheets to the volunteers. The results will be announced within a short span of time. We'll display the answers until then. If there is a tiebreaker between 2 or more participants, we'll have a tiebreaker session also. So we request everyone to stay back. Certificates for all the delegates will be provided shortly, so please wait, guys. So now we'll be displaying the answers. So for the first question, inotrope of choice in cardiogenic shock when the patient had beta blockers. The answer is option D, milrinone. Second question, a 55 years male presented with chest pain. ECG shows ST depression in anterior leads and inferior leads. Echo done shows RWMA in LAD territory. Cardiac enzymes was positive. What is the diagnosis and how will you manage? So the answer is NSTEMI, anticoagulation, option D. Question 3, when should you avoid nitrates in ACS patients? The answer is D, acute inferior wall MI with RV and posterior wall involvement. Question 4, 60 years old female patient presented with ACS NSTEMI. On examination, patient has bilateral basal creps. ECG shows dynamic STT changes with recurrent refractory chest pain. When will you transfer the patient to PCI center? So the answer is option C, give loading dose and refer immediately. Question 5, most common cause of cardiogenic shock. Answer is option C, acute myocardial infarction. Question 6, what is the ideal LDL-C level you target for long-term treatment after ACS? So the answer is option C, less than 55 milligram per deciliter. Question 7, which of the following is an inodilator? It's milrinone, option D. Question 8, identify the true statement. So the right answer is option D, noradrenaline has predominant alpha-1 action and less beta action. Question 9, name of the sign, it's Pallas sign, option C. 10, an uncontrolled diabetic patient presents with acute severe dyspnea or palpitation. ECG shows ST elevation in lead V2 to V6, 1 AVL. Echo shows regional hypokinesia with EF 25%. Vitals BP 80/50, pulse rate 114 per minute. SPO to 90% with room air. Bilateral basal creps present. So the treatment of choice. Answer is option D, primary PTCA along with inotrope or mechanical circulatory support device. Question 11, which of the following is not a criteria for cardiogenic shock? So the answer is B, pulmonary capillary wedge pressure less than 15 mmHg. 12, which genetic mutation is most commonly associated with pulmonary embolism? The answer is factor V Leiden mutation. 13, what defines massive pulmonary embolism? The answer is P, that causes systemic hypotension and right ventricular dysfunction, option C. 14th question, the correct statement regarding the characteristics of OCT imaging. So the answer is all of the above. 15th question, which patient characteristic in Wells score is equivalent to 3 score? So the answer is C, clinical signs and symptoms of DVT. Question 16, true about OCT are all except. So the answer is option C, helps in functional assessment of CAD. Question 17, MLD max algorithm in OCT stands for. Answer is C, morphology, length, diameter in pre-PCI. Question 18, the cutoff value of FFR to treat. The answer is B, less than 0.80. 19th question, localize the culprit artery. The answer is proximal LAD, option B. So the final question, which of the following patient has the highest myocardial oxygen demand? The answer is D, patient 4, heart rate of 100 and systolic BP of 160.
So, uh, I call upon Dr. Aarti to stage. Just Aarti. And you all know that she doesn't need introduction, and she got almost 12 gold medals, and she's a gold girl. And moreover, her mother is, I know her for more than 40 years. She was my neighbor, and she's the first person to undergo MBBS in our neighborhood. And she is well talented, not only in academics and everything. So just to honor her, a small memento from myself. I call upon Adya to the stage, please. Both Adya and Aarti did well today, and they engaged you all well.
So the most awaited moment of Access 24 is here. We now request Dr. Arunachalam sir to announce the results of the quiz.
So actually, two people scored 17 out of 20. So the two people will be given the second prize, and one person has scored 19 out of 20. And the second prizes, two second prizes will be given, and I call the person Deepak Kumar, postgraduate. Who is Deepak Kumar? Yeah, please come to stage. And another is Reshma. So both have scored 17 out of 20, and they back the second prizes, two second prizes of 5,000 each. Can anybody guess who has scored first prize? So it's Dr. Santosh, postgraduates from TKMCH. So give a big hands to him. So he's given 10,000 as a first prize.
Gratitude makes sense of a past, brings peace for today, and creates a vision for tomorrow. It is time to give our heartfelt thanks to everyone who has been a part of today's event. So I now request Dr. S. Madhavan sir to deliver the vote of thanks.
And thank you for giving me the opportunity to thank all the participants. And first of all, I would like to thank the organizers of Aruna Kadeka, Dr. Swarnashwada Madam, and Director Dr. Arunachalam, and the entire team of Aruna Kadeka led by Dr. Manohar and his team. And I would like to give a special thanks to Dr. Chinniappan, who has come all the way from Trichy, and his spellbound lecture held the audience for a quite long time. And I would like to thank all the speakers, and especially Dr. Subramaniam and our in-house speakers, Dr. Vishnu Das, Dr. Ganapati Saktivel, Dr. Arun Kumar, Sangamitra Madam, and all other speakers. And I also like to extend a warm thanks to our chairpersons, faculties, and delegates, and various senior persons, including our former teacher, Dr. Saraswati Madam, who has come and gone through the entire session. And finally, I would like to thank our postgraduates, without whom our session would not have been that much successful. And I'd also like to extend a thanks to Dr. Arunagiri sir, who was very instrumental in providing this hall and making suggestions to improve this program. And I would also like to extend the thanks to the digital audio-visual team and our Aruna Kadeka staff, hospital staff, administrative staff, and our nursing superintendent madam. And also, finally, I would like to thank the press people who made this event live. Once again, thank you. Thank you.
Thank you, sir. Thank you, guys. Signing off Adi and Aarti on behalf of Team Access 24. A big thank you once again. See you all at Access 25. Let us all rise up for the national anthem.
National anthem.